Okay, and then
Okay.
I will play her video,
Okay.
and then next speaker is C Nagori.
C. Nagori.
Yes,
Yeah.
and
Chaitanya Nagori.
yes. Is the director Dr. Nagori Institute for Infertility and IVF, Ahmedabad, India.
I'll just say this much and rest you will
Yes.
show. Dr.
Then I will
Nagori
play his video.
Institute
It's also
for
recorded.
Infertility. Okay.
Okay, and then next speaker is Dr. Sonal Panchal.
Okay. Sonal Panchal. She is also consulting in the same space. Yeah.
And इनका भी recorded session है ma'am.
Yeah.
Also recorded session. I will play after you introduce. Okay, ma'am.
Okay.
Yes. So the first session is till here.
Okay.
Okay. Then next session is panel discussion and Dr. Mamta Dindayal, moderator for next session. So could you introduce Dr. Mamta Dindayal?
Yeah. Just give me her brief.
Actually, I don't receive her CV. She will do my own, I think she said.
No, but she is from, I think, Hyderabad.
Okay.
Okay, I'll check.
Oh,
Leave
okay.
it.
Okay. Hello, Sanchit. Sanchit, can you hear me?
Yes, sir.
Please don't show the timer for first session. Actually, they all are recorded session. For first session, don't show timer. Okay.
Okay, sir.
Okay. Thank you.
Thank you.
Already like. বলছি এটা একটু চার্জে বসিয়ে দেবে?
Ma'am, we will go live in 1 minute.
Okay, right.
I will give you the countdown, then I will show your CV.
Okay, but you tell me what this session is called, the name of the session.
The name of the session is ultrasound imaging, a boon
No,
in
no, no, no. Huh? Ultrasound imaging?
ultrasound imaging,
Imaging.
a wound in infertility management.
Okay, a boon.
Okay, ma'am?
Okay.
Yes. So I am giving you the countdown. So I will show your CV first,
Okay.
and then speaker CV. You can introduce them. Okay, ma'am?
Okay.
Okay, I am giving the countdown. 5, 4, 3, 2, 1. Be alive, ma'am.
Good morning, everyone. Greetings from Kolkata, the city of joy. You are all welcome to the first session in Hall E on ultrasound imaging, a boon in infertility management. This will be divided into 4 lectures. The first speaker will be Dr. Harpreet Kaur, who is an associate professor in Obscine at AIMS, Bilaspur. And she will be giving the first lecture of this session. And I invite Dr. Harpreet Kaur to deliver her lecture.
Good morning, everyone. My heartfelt thanks to the organizing team AS2021 for giving me this opportunity. My topic for today is basic imaging in infertility, what clinicians should know. And definitely, we need to know a lot about ultrasonography and imaging modalities for the management of infertility. And in fact, the treatment of infertility has been made quite simple with these imaging modalities in hand. So infertility, we know, is defined as inability to conceive after 1 year of regular unprotected sexual intercourse. And worldwide, about 1 in 6 couples, they suffer from infertility. And male and female contribute almost equal to infertility. And when we talk about the diagnostic evaluation of an infertile couple, nothing can replace a detailed history, a thorough physical examination. And when we talk about investigation, imaging plays a vital role, especially in the female partner and to some extent in the male partner as well. The major part of my talk will be on ultrasonography because we as a clinicians have a lot of role as far as the ultrasonography is concerned. We all need to be trained when we are managing an infertile couple. But yes, definitely, we need to be aware about the role of other imaging modalities as well, when to order those imaging modalities and how to interpret those imaging modalities. So talking about the ultrasonography, it starts right from the very first visit when a couple visits a fertility specialist or a gynecologist. A baseline scan can give us a lot of information. So we need to know about the anterior follicle count and the baseline scan done on a day 2 or day 3 of the cycle. to know about the ovarian reserve, and we can classify the patients accordingly into those who are poor responders if the AFC is less than 5, or into hyper responders if the antral follicle count is more than 15. So that we can tailor our stimulation protocols accordingly, and we don't land up into the troubles of ovarian hyperstimulation or non-response, cancellation of the cycles. And similarly, it's equally important to rule out ovarian pathologies. And when I say ovarian pathology, we need to make the diagnosis of polycystic ovaries. And it's very, very important to know whether the ovaries are PCO ovaries or non-PCOS ovaries, especially if I have to start an IVF cycle. I need to know which type of protocol, whether agonist or antagonist protocol, how much dose of gonadotropins I need to start for a particular patient. So depending upon the number of the follicle, which are measuring 2 to 9 millimeters in diameter, and depending on the volume of the ovaries, we make a diagnosis of polycystic ovaries. And it's not only about the ovarian stimulation, what a lot other prognostic factors are related to PCOS for the infertile patient. The prognosis during pregnancy, once she conceives, the risk of antenatal complications like preeclampsia, like GDM, and even the long-term metabolic consequences. So we as a gynecologist should be able to make a diagnosis of polycystic ovaries on the baseline scan. Then we need to know about the ovarian cyst. They can be simple cysts, like those with thin walls, with anechoic contents. And most of the times, these are the simple physiological cysts, and we need to just wait and watch for them so that they disappear at their own. And or they can be complex cysts, or they can be cysts with internal echos. And this cyst with internal echos can be endometriomas, those with the ground glass appearance, or they can be hemorrhagic cyst, or they can be corpus luteum, depending upon how much is the vascularity, which part of the cycle we see those cysts. So with experience, we come to know, even if it's a hemorrhagic cyst, whether it's endometrioma or it's a corpus luteum. We need to be very clear to differentiate these two types of the cyst on the ultrasonography. Needless to say, and ultrasonography is vital for the follicular monitoring and ovarian and ovulation induction and control ovarian stimulation cycles. I would rather say that we should not be giving gonadotropins until and unless we are familiar with doing scans ourselves. In fact, when we give the stimulation to a patient, we just can't rely on a report, which is a snapshot of what is happening in the ovary when we give the gonadotropins. And it's not only important to know about the dominant follicle, but it's also equally important to know what any intermediate follicles, which are in fact the ones which give us a trouble as far as the ovarian hyperstimulation or multiple pregnancy is concerned. And equally important is to have a look at the endometrium, which we need to know about the pattern of the endometrium or the thickness of the endometrium, as well as to know the endometrium is growing in synchrony to the follicles. So a scan done by the treating physician, the gynecologist themselves, is very, very crucial when managing ovarian stimulation and for IUI or for IVF cycles. After moving next to the ovaries, it's equal to have a look at the uterus and to rule out any abnormalities of the uterus, the congenital abnormalities or the acquired abnormalities. Acquired abnormalities can be fibroids, or it can be a polyp, or it can be adenomyosis. So our baseline scan, we need to spend a lot of time to rule out these abnormalities, which can be tackled rightly if they are diagnosed at the right time. The uterine anomalies, 3D scan plays a vital role. In fact, it's called a virtual hysteroscopy because more than 98% of the abnormalities, they can be diagnosed with the 3D ultrasonography. We don't need the MRI, we don't need a hysteroscopy, laparoscopy for the diagnosis. If a 3D scan we have available with us. Endometrial pathology, the important ones are synechia, polyps, or the fibroids, which are the main culprits for recurrent pregnancy loss or recurrent implantation failure. As far as the infertility is concerned, or even for the infertility, we need to rule out these pathologies in a patient of infertility when we are planning for the treatment, and we need to tackle these abnormalities before going ahead for the treatment of infertility. Polyp mostly are seen as discrete growth. but it's important to put a Doppler, and there will be a feeding vessel, so that makes our diagnosis easy. The myometrial lesions, the important ones are fibroids or adenomyosis, and adenomyosis mostly it's easy to differentiate from the fibroids if it's diffuse, but once it is a localized adenomyoma, then sometimes the difficulty may be there, and we might need other imaging modalities like MRI. I'll be discussing in the subsequent slides. And even for the fibroids, it's important to map the fibroids. We need to know the number, the size, the location of the fibroids, and their relation to the endometrial cavity. If we are, say, planning for a surgery, for myomectomy, to plan the route of surgery, whether to remove them hysteroscopically or by laparoscopically, a scan done by the clinician themselves preoperatively gives a lot of information, so that the surgery can be planned accordingly. The endometrial grading in IUI cycles and in IVF cycles, before we put back the embryos, we need to know the endometrium is in the right stage, and for the seed to grow, the soil has to be in the optimal condition. So that is what the endometrium has to be. Whatever type of the stimulation we have given, however good the embryos are, until the endometrium is good, we are not going to get the results. So we need to look at the thickness, the pattern of the endometrium, and the vascularity of the endometrium. There are various codes like Applebaum scoring, and we need to know about the endometrial details before going ahead for the treatment. And not to forget the important pathology, the adnexa, we need to have a look to rule out any hydrosalpinx, which is seen as a fusiform cystic swelling with a cogwheel appearance. And if we make a diagnosis of hydrosalpinx, we need to manage this hydrosalpinx before proceeding for the treatment of ART, because with the hydrosalpinx, the treatment results are going to be half. If we are proceeding for IVF, after managing the hydrosalpinx, after clipping of the tube or after removal of the tube, our results almost double up. So that is why making a diagnosis of the hydrosalpinx is very crucial in a patient of infertility. Assisted reproductive techniques, I would say it's not possible to go ahead for the ART treatment before having a scan in hand. And almost for all the procedures related to ART, we are dependent upon the ultrasonography for monitoring of the ovarian response, for oocyte retrieval, all embryo transfer, they are done under ultrasonography guidance. Then further, the prediction of ovarian response and making a diagnosis of early pregnancy. Until and unless we have seen a clinical pregnancy, in intrauterine pregnancy, we are not sure what the success of our IVF treatment cycle. Then coming to next imaging modality, that is HSG, which is done by injecting the iodinated contrast media into the uterine cavity, and we check for the patency of the tubes under real-time fluoroscopic guidance if the dye comes out through the tubes. And at the same time, we can check for the uterine cavity as well. It's mostly done during the follicular phase of the cycle. Day 7 to day 10 of the cycle is the ideal time. So when looking for the HSG, it's not that we just have a look at the report. We should be familiar how to see the X-ray picture. We should always have a look at the X-ray picture of the HSG. And so this is a typical picture of the hydrosalpinx, a swollen tube. There's no spill on this side. The other side is patent. Then in the uterine cavity, a picture of Asherman syndrome. We can see the adhesions here. So making a appropriate diagnosis is important so that the timely treatment can be given to the patient. Then sonosalpingography is a ultrasonography based tubal patency testing, wherein a mixture of normal saline and air is injected into the uterine cavity to check for the patency of the tubes. It's relatively less invasive, and for the patients who are allergic to radio iodine contrast media, sonosalpingography is an alternative. We inject the normal saline, and under real-time ultrasonography, we check for the turbulence at the fallopian tubes, and the passage of the saline into the femoral end of the tube is assessed. And almost a similar technique is the SIS or saline infusion sonography, wherein after injection of the saline, uterine cavity is assessed. It is very good investigation to delineate the intracavitary lesions like polyps and intrauterine adhesions. Wherever we are in doubt on the transvaginal sonography, we can inject small amount of normal saline into the uterine cavity and make out these lesions very clearly. Then MRI, though not done routinely, but yes, there are some pathologies like Mullerian anomalies, and to differentiate adenomyoma and fibroids, we might need MRI. And because it's a costly investigation, we should be justified when ordering for an MRI. And sometimes when the sonography is inconclusive, MRI becomes investigation of choice because the soft tissues are better delineated on MRI. And then another important pathology is pituitary adenomas and hyperprolactinemias, where extrapelvic MRI may be required in a patient of infertility. This is a picture of T2 weighted image of MRI of unicornuate uterus, and the rudimentary horn we can see side by side on the side of it. And the HSG picture of banana shaped uterus is shown for correlation. And in adenomyosis, also the typical finding on MRI, they are almost diagnostic. There is a widening of the junctional zone, and whenever we are in doubt on TVS, we can go ahead for MRI. And adenomyoma, pituitary adenomas, we can make out the diagnosis, confirm the diagnosis. We can also make out whether it's a microadenoma or whether it's a macroadenoma, so that the treatment can be planned accordingly. Then last but not the least, in male infertility, though imaging doesn't have much role, the single most investigation in male infertility, I would say, is the semen analysis. It gives us a whole lot of information, and there are very few selected cases of male infertility where we might need scrotal ultrasound and Doppler, like in case of varicocele. But still in varicocele, the diagnosis is made on the physical examination. But if the physical examination is inconclusive, the scrotal ultrasound may be required to collaborate the findings. Then epididymal abnormalities and undescended testes, we might need scrotal ultrasound. This is a typical picture of normal testes, and this is a atrophic testis with calcifications and a decreased size of the testis. And transrectal ultrasound imaging may be required for prostate, seminal vesicles, and the vas deferens, and in cases of obstructive azoospermia to localize the site of obstruction. Penile ultrasound and Doppler may be required for the evaluation of physical causes of erectile dysfunction. So needless to say, ultrasound has got a vital role in infertility, and this is called as third eye for the clinicians. Thank you very much for the patient hearing. Thank you.
Thank you, Dr. Kaur. That was a wonderful presentation, and you have covered everything in detail. Okay. Can I get the video, please? Can I have the video, please? Yeah. So we have our next speaker, Dr. Richa Jagtap. She is the clinical director of Nova IVI Fertility in Chennai, and she will be talking on ultrasound evaluation of the fallopian tubes, or SSG, when, why, and how. Please, Dr. Jagtap.
Ma'am, please unmute yourself.
A very good morning to everybody. I'm thankful to ACE for giving me this opportunity for the presentation. And as the zone has been started on ultrasound evaluation, we will be discussing about ultrasound evaluation of fallopian tubes, that is the SSG. Tubal evaluation has a big importance in fertility diagnosis. In fact, fallopian tubes are the place where the egg and the sperm fertilize, cleave, form a blastocyst, and then it comes into the uterus for implantation. I would say it is the natural incubator of a woman's body. And tubal factors contribute to around 30% of female subfertility. And hence, tubal patency is a mainstream diagnostic test for women presenting with infertility, where semen parameters and ovulatory dysfunctions have been ruled out. It does fall into good practices before planning interventions like intrauterine inseminations as per the ISHRE committee. When we come to tubal patency test, the history, as we have read it, it starts with Rubin's test, which is all but obsolete now. HSG, the hysterosalpingography, hysterosalpingo contrast sonography, saline sonography, and of course the gold standard of laparoscopy. We know that fallopian tubes play an important role in sperm ovulation development, and the ciliar and muscular activities are very important elements in ovum transport. The diagnostic evaluation is all limited to either patency or non-patency. The functional role of tube is still not very well evaluated. HSG has always been the first line of imaging for tubal patency, and laparoscopy has been the gold standard. However, they both give approximately similar results, other than the fact that laparoscopy is operative, where you could correct any defect seen, and is also an invasive technique. HSG does present with some disadvantages. It could be the iodinized contrast materials could produce an anaphylactic reaction for patients. It requires a full radiological setup and associate staff. And this, instead of this, an ultrasound being a non-ionizing is an alternative to HSG, also an alternative to laparoscopy by being non-invasive imaging technique. Now, a normal transvaginal ultrasound will not delineate the thin fallopian tubes until unless either they are filled with fluid or air, or they are surrounded by fluid. And this is because the lumen of fallopian tubes is thin, and ultrasound wave signals reflected back does not differentiate with them unless it's contrasted by tissue of different density. Sonography role in tubal patency was started first by Richmond et al. And then Randolph et al. And they realized that tubal patency can be checked by transabdominal sonography methods. When they observed fluid collection in cul-de-sac, they concluded that patency of 1 or 2 tubes was there. Descartes et al. Developed a new transvaginal sonography technique, and by transcervical injection of a contrast, they were able to visualize the tubes directly and hence have shown the tubal patency. Further on, it was also advised to use pulse wave Doppler to see if there is any kind of disturbance or intertubal flow demonstration over a short distances, which would help us to determine the tubal patency. The sonosalpingography, also known as the Cyan test, is used as a transvaginal sonography to confirm tubal patency near the femoral end when the mixture of air and saline was injected through a Foley's catheter. The color signals generated by air bubbles and the flow of the fluid can also make it possible for us to demonstrate the tubal patency on both the sides. It's not offered as a substitute for HSG laparoscopy or salpingoscopy, but as an office screening procedure that would be complementary to the armamentarium of infertility investigations already available to a fertility clinic. So this is how the procedure happens graphically. I will explain it further. So under all aseptic precautions, a Foley's catheter is inserted into the uterine cavity and 3 ml saline is inserted to make it self-retaining. After that, imaging of the uterus and Foley's catheter are taken. Post this, around 20 ml of saline along with air is pushed through the Foley's catheter, and a flow of saline and micrometer-sized bubbles is recorded on grayscale ultrasonography. So if you see, this is how an image of a patent bilateral tubes will be seen by a color flow. In this case, the uterus looks normal. This is uterus in trans. There's the fluid inside the uterus. You can see very clearly on the left side, there's a cascade of flow seen on color Doppler, where on right side, there's not much happening, and that tells us that the right tubal block might be present. We cannot stop this discussion without discussing hysterosalpingo contrast sonography, where SonoView is a non-toxic, non-irritant endometrial tubal mucosa, and it has enough viscosity to prevent rapid filling of genital tract before you can see the images, and hence it is probably more helpful in understanding. The image that you can get on 3D scan with hysterosis is amazingly beautiful. You can evaluate the cavity as well as the entire tubal pattern and see if there's any thinning of any ischemic areas, there's spill or not. Everything can be seen very clearly. Now, very quickly, I'll show you a small video of how right tubal patency is seen in this. You can see the uterus here, and here we are seeing, you see that cascade. This is demonstrative that right tube is, of course, patent. In this video, you can see the similar pattern, the uterus in trans, and here we see the cascade of color in the left adnexa, pointing to the fact that left tube patency can also be established. Some points of interest in transvaginal sonosalpingography is either the forward flow of saline or microbubbles for at least 5 seconds should be seen, and then we can say that yes, there is tubal patency. There shouldn't be any interruption or hydrosalpinx formation, or else if you see a fimbrial turbulence, that will also be considered as the presence of tubal patency. Of course, as we just saw, color adds another dimension to the demonstration of flow turbulence in either adnexa. If you see no flow or turbulence in either adnexa, that denotes a probable conval block, and occasionally an inflated tubal stricture with no fimbrial and tubal turbulence can point to fimbrial block as well. In the presence of bilaterally obstructed tubes, you would probably see a uterine cavity expand without subsequent decompression, and you could see reflux of saline and air microbubbles very clearly. Of course, this will release on deflation of Foley's bulb, which makes the fluid leak out of the cervix. Another very important clinical sign is in almost all patients with bilateral obstruction will complain of an acute groin pain that can settle down on releasing the pressure on the syringe. We would also like to just go through a sign procedure, which was demonstrated first by Allahabadia in 1992. And here, the lack in SSG was that we did not know about the mobility and external milieu of the fallopian tubes. And sign procedure tried to solve those unanswered questions. Here, 300 ml of fluid is pushed into the POD with the adnexa and uterus submerged in the fluid medium. The scanning of pelvis is performed. And when surrounded by the fluid, the tubes appear as 1 centimeter tubal echogenic structures that come from the lateral aspect and go towards the adnexal area. Here, this can delineate all sorts of adhesions, filmy dense adhesions, even septae in the periadnexal region very clearly. So the advantage of SSG is that it can be performed with just isotonic saline without anesthesia. It's physiological, it's easy to perform, safe, cost-effective, non-invasive, and probably much more convenient when compared to other conventional methods. Use of Cusco speculum instead of Rubin's cannula or for Leach-Wilkinson calendar as used in HSG means that the cervical manipulation is minimal and leading to avoiding the well-known pain associated with HSG. And as long as it's done with sterile condition, there's hardly any risk of any infection. The ultrasound gives a 3-dimensional view of pelvis rather than just an X-ray giving us 2-dimensional view. It can be performed by you in your gynae clinic in a real-time standard equipment. And of course, it will need experience to evaluate and to pinpoint the adnexa in the real time. So we know that the transvaginal sonography gives results around 76% consistent and partially consistent for around 21%. Overall, there's a complete agreement in the sonography finding and that of a conventional method. And so far, that's been found in around 65 to 71% of the cases. The disadvantage is that it makes a diagnosis of a tubal occlusion with dilated hydrosalpinges difficult because the flow through the dilated fallopian tube may simulate spillage also. And limitation is compared with HSG. It may be impaired diagnostic value if you cannot see any tubal flow, when you will have to go towards a definitive procedure like HSG or laparoscopy. Also, results are not exactly reproducible like an X-ray film that you have for clinical interpretation at a later date until unless the procedure is recorded in a real-time video for the people to see. So in conclusion, today we are in midst of a sonographic revolution in the field of infertility and imaging, and SSG adds another dimension to the fertility evaluation as a gynec clinic as an outpatient procedures. Of course, the pros and cons in which patient you would definitely take for SSG has to be taken in account while you're planning and executing the procedure. Consent and the counseling of the patient, because this is anyways a procedure, it's very important. And just like you would any kind of aseptic procedure, you would have to follow for this procedure also. Thank you so much for your patient listening. Thanks a lot.
Thank you, Dr. Richa Jagtar. That was a wonderful lecture, and we would like to hear whether there are any questions. We can take it up later. So I invite the next speaker, Dr. C. Nagori, who needs no introduction, in fact, as an infertility specialist in India. And he is the director of Dr. Nagori Institute for Infertility and IVF in Ahmedabad. And he will be talking on endometrial assessment of receptivity by ultrasound. Dr. Nagori, the stage is yours now.
Good morning, everybody. At the outset, I'm thankful to the organizers of ACE 2021 for inviting me here. I'll be talking on endometrial receptivity assessment by ultrasound. All of you know very well today that ultrasound is the main tool for the assessment of the endometrial receptivity. Receptive endometrium may be described in just two lines as such, 8 to 10 millimeter thick, and second is a triple line endometrium. But this is too insufficient, it is not enough. It is essential to rule out the endometrial pathologies if they are there, then understand their impact on the endometrial receptivity. And second is it is essential to understand the physiology of receptivity. One-time assessment of the endometrium does not give the correct idea about the endometrial receptivity, and that's why the serial examination is very important. Assessment of the endometrium should be by B mode, that is 2D assessment, color Doppler assessment, and maybe even the 3D power Doppler assessment. Always bring the endometrium in the center and use the proper zoom, then you can visualize the endometrium very well. When there is a fluid in the endometrial cavity or assessment of the junctional zone is very important to decide the receptivity of an endometrium. To diagnose the endometrial pathologies, you may have a polyp, you may have a single feeding vessel in the polyp that is seen, which may be hampering the receptivity. Saline infusion can also detect the number of polyps and the location of the polyp also. Endometrial fibroid, you can visualize the fibroid whether it is touching to the endometrium or it is not touching to an endometrium. And second thing is, when the fibroid is more than 4 centimeters, then it is considered that it affects the implantation, and that's why it requires its removal. Acute and chronic endometritis. In an acute endometritis, you will get the hyperemia as well as you will get the thickening of the endometrium, while in a chronic endometritis, you will get a thin endometrium and you will not have the vascularity of the endometrium. Cox is also a common cause. You can see the micropolyps, you can see the calcification, you can see the vertical rise of the ischemic portion of the tube. You can see the fluid in the cavity, you can see the narrowing of the lumen also, as well as you can see the adhesions. These are all for the diagnosis of the Cox abdomen. Adenomyosis is also affect the implantation. Now, understanding the physiological changes of an endometrium. Endometrium appears single line in the early proliferative phase, and after the bleeding has stopped, it increases its thickness by 1 to 2 millimeter daily in the proliferative phase. You can see as the estrogen level rises, the endometrial vascularity also increases, as well as the thickness of an endometrium increases. Endometrial peristalsis between 3 to 5 can be observed in the normal patients. Endometrial vascular changes nearly the same time as follicular vascularity. The spiral artery starts extending towards the endometrium, and this is the effect of an endometrium. Endometrial and subendometrial flow increases in the follicular phase and reaches its maximum 3 days prior to the ovulation. So here you can see that the endometrium and subendometrial flow increases. First it touches the outer margin, then it enters the endometrial lumen, and then it touches the midline. So it is zone 1, 2, 3 and 4 vascularity can be seen, and that affects the receptivity. Spiral artery Ri will be between 0.49 and 0.59. So here the endometrial vascularity decreases until the day 5 after the ovulation, and again it increases in the mid-luteal phase. You can see here that on day 5 of the ovulation, the endometrial vascularity decreases and then once again it increases in the luteal phase. Now, in pre-ovulatory period, the uterine artery resistance decreases PI of 3.2. So, uterine artery PI should be less than 3.2 for the better implantation, which was higher earlier. The resistance increases as the surge starts, and then when the progesterone level starts increasing, this resistance starts decreasing for the nourishment of an implanting embryo. On the onset of an LH surge induces significant increase in the resistance of the uterine artery for 48 hours, which can affect the evaluation on the day of follicular aspiration or the rupture. So it means that whenever you want to evaluate the uterine artery PI or the endometrial vascularity, it should be done before you give HCG to the patient or before the onset of an LH surge. So after giving an HCG, it definitely changes, and that's why it should be assessed just before the HCG injection. This is, you can see that the fluffy margin, then the hyperechoic endometrium is seen on the outer margin, and then later on you can see the full-fledged secretory phase is seen in the luteal phase. Uterine mid-luteal indices, uterine artery PI is between 2 to 2.5, spinal artery RI is between 0.48 and 0.52. Towards the advancing luteal phase in a conception cycle, the velocity of the endometrial and the corpus luteal flow increases and the resistance decreases. In a non-conception cycle, the resistance in the corpus luteum increases and the velocity decreases, and same is the effect on the endometrium too. In the treatment cycle, to improve the conception rates, it is preferred that the endometrium achieves the thickness that is most optimal for the implantation. It's a good morphology and it is well vascularized before the trigger. And also it does not have any pathology affecting the implantation. Then you will get a very good endometrial receptivity. Pre-ovulatory endometrium, the thickness is 6 mm or more in the thickness, preferably 8 to 10 mm, and morphology it will be triple line, grade A or B endometrium morphological pattern. Apart from the thickness, the dynamicity is an important sign of a good endometrial receptivity. Though thick, if the endometrium is not growing, the receptivity is poor. Conception rates are very low when the vascularity is not seen in the zone 3 and 4. You can see here the Applebaum score that vascularity in zone 3 and 4, it gives a good endometrial receptivity. This was one of our publications where you can see that the beta HCG is positive in almost 70% when the vascularity is found in zone 4. So the gestational check is also found and the abortion rate is also very low. That's why when the vascularity in zone 3 and zone 4, the pregnancy rates are very high and the abortion rates are very low. Endometrial and subendometrial vascularization may serve as a prognostic marker for ongoing pregnancy, unlike any other marker of the endometrial receptivity. This is very important statement that you don't have to undergo the certain tests like ERA or all other cytokine measurements. Here, just by a vascularity, you can definitely say that the receptivity of the endometrium is very good, and when it is in zone 3 and 4, the implantation rate will be very good. Absent endometrial and subendometrial intra-endometrial vascularization on the day of trigger appears to be a useful predictor for the failure of implantation in an IVF, irrespective of the morphological appearance. So, if the vascularity is not in zone 3 and 4, even if it is triple line endometrium, the implantation is very poor. This vascularity should cover at least 5 mm square area of the endometrium. Below this cutoff, the pregnancy rates are extremely low. Those women with an intra-endometrial power Doppler area less than 5 mm square achieved a significant lower pregnancy rate. So when pregnancy is achieved in the absence of endometrial and subendometrial flow on the day of embryo transfer, more than half of this pregnancy will finish as a spontaneous miscarriage. And that's why the embryo transfer should be done, particularly when the vascularity is present in zone 3 and zone 4. More than 2.5 ml has a significant higher pregnancy rates, and median values for the favorable endometrial is 4.28 plus minus 1.9 ml, and subendometrial flow at the time of trigger more than 5 cm per second PSV. It is good for implantation. This was also one of our publications where pre-HCG 3D and 3D powered Doppler assessment of the follicle for improving the pregnancy rates in intrauterine insemination cycles. No pregnancy when endometrium volume is less than 3 and VI less than 10. Exceptional better pregnancy rates are achieved when the endometrial volume is more than 7 ml and some endometrial VI between 10 to 35%. A study of Kupasik et al. Shows the lower resistance index of 0.49 to 0.57 in subendometrial blood vessel in FI between 11 to 15.4 as compared to 9.5 to 13.3 otherwise. On the day of transfer, high FI gives the better pregnancy rates. VFI on the day of the trigger is more sensitive than the volume VI and FI for a prediction of pregnancy. VFI more than 0.24 has high sensitivity, high specificity, positive predictive value is very high and negative predictive value is also 72%. For prediction of pregnancy with 33% pregnancy rate has been observed with VFI. Uterine artery PI should be between 2.2 through 3.16. If the upper limit of the cut of the uterine artery is established at 3.3, prediction of a non-receptive uterus is specificity 100%, positive predictive value is 88 to 100%, sensitivity 13 to 35%, and and NPV is between 44 to 56%. So uterine artery PI should be less than 3.2, then the pregnancy rates will be very good. Present concern about the endometrial receptivity is progesterone levels and its effect. It is known that the progesterone level always starts rising before ovulation, and the effect on the endometrium is essential for the pre-ovulatory preparation of an endometrium. Here you can see that before the ovulation the progesterone starts rising. Here you can see the margin which becomes fluffy and then becomes an echogenic as the progesterone level increases. And then you can see a full-fledged luteal phase. The progesterone effect is seen on day 5. So this is on day of the trigger, this is on day 3 and this is on day 5. You can see the vascularity also. On day 3 the vascularity decreases and on day 5 the vascularity increases in an IVF cycle. So just I summarize that the endometrium should be more than 8 mm, grade A and B, vascularity in zone 3 and 4, RI less than 0.6, uterine artery PI less than 3.2, volume more than 3 cc, FI more than 20, VFI more than 5, then this gives an excellent receptivity of an endometrium. Thank you very much.
Thank you, Dr. Nagori, for that wonderful lecture. You have explained everything in detail. So now I will call upon the last speaker of this session, and she is none other than Dr. Sonal Panchal, and who is known all over the country for her excellent work in ultrasound. And she will be speaking on diagnosis, adenomyosis by imaging techniques. She is a consultant at Dr. Nagori's clinic. So Dr. Panchal.
Good morning, friends. At the outset, I thank the ACE 2021 team. I'm going to talk today on diagnosis of adenomyosis by imaging. Adenomyosis is defined as a benign invasion of the endometrium into the myometrium. It microscopically exhibits as ectopic non-neoplastic endometrial glands and stroma surrounded by hypertrophic and hyperplastic myometrium. Though the prevalence quoted is about 50% in the infertile population, its actual prevalence is difficult to estimate because many patients are asymptomatic, though those who present with symptoms may have menorrhagia, dysmenorrhea, dyspareunia, especially if associated with endometriosis and infertility. The cause of infertility in these patients is deranged contractions, inadequate blood supply, and immunological basis. The adenomyosis may present as a diffuse lesion, as a focal lesion, or a polypoid lesion. Diffuse lesions, they usually present as a globularly enlarged uterus or asymmetrical thickening of one of the walls of myometrium when there is involvement of one wall. This myometrial wall, which is thickened, is grossly heterogeneous. The heterogeneity may be because of hyperechoic and tiny anechoic or hypoechoic areas. Hyperechoic areas in the myometrium may be due to fresh bleed or collapsed endometrial cavities. And this heterogeneous echogenicity is typically described as either a Swiss cheese pattern or a salt and pepper pattern by some. Whenever there is a diffuse lesion, you need to quantify it, and this quantification is done as penetration of the diffuse lesion, and the ratio of the thickness of the lesion to the thickness of the myometrium at the same level. And of course, you also need to mention whether it involves less than or more than 50% of the total body of the uterus length. It is also good to mention whether it involves anterior-posterior wall or the lateral wall or the fundus. The heterogeneity typically with hyperechoic multiple tiny lines or dots has been shown in this clip. And as described, this may be because of acute hemorrhages or because of collapsed myometrial cyst. You are also seeing a localized lesion here. In this case, this high intensity myometrial foci are embedded within the myometrium, most commonly in the inner myometrium, and display a high signal on T2 and low signal on T1 weighted MRI. Hyperechoic lines may be seen extending from the endometrium to the myometrium, and this may be a reason to obliterate, reason that obliterates the endomyo junction. You see the extension here and the involvement of the myometrium there. Subendometrial hyperechoic striations, linear striations may be seen along with the myometrial cysts. These are collapsed myometrial cysts. These are myometrial cysts with blood products inside. Multiple myometrial cysts may often be seen in the entire uterus, and it is this myometrial cyst and hyperechoic dots and lines which together lead to the typical rain in forest or the Venetian blind pattern. This is also described as fan pattern in the according to the Musa. The myometrial cysts, whenever they are present, it is important to note whether it contains anechoic or low material or a low level echogenicities or ground glass echogenicities. The number of cysts, if they are multiple, you need to mention where they are, which wall they are more, and if they are up to 3, it is important to mention the location of all the 3 and also the size of these. The myometrial cyst of adenomyosis typically presents with the peripheral vascularity. This is unlike tuberculosis. Differentiation of the adenomyosis from tuberculosis often may be difficult. It is because both involve the endomyo junction, both may lead to thin endometrium and myometrial cyst, but the myometrial cyst of tuberculosis will not have peripheral vascularity. Myometrial cysts have 98% specificity and 78% accuracy for the diagnosis of adenomyosis, and heterogeneous echogenicity has a sensitivity of 88% for the diagnosis of adenomyosis. Myometrial cysts, though almost always pathognomic of adenomyosis, are detected only in about half of the cases on T2, and therefore for the diagnosis, for the demonstration of the myometrial cyst, ultrasound has been considered a better modality. Hyperechoic islands may be seen in the myometrium, and these are endometrial glandular tissues. It is important to mention the shape, the margins, whether it's irregular, or ill-defined or well-defined margins. You need to mention the location of these lesions, especially if they are less than 3 and along with the sizes. But if they are multiple, you can just mention that they are seen in a particular anterior-posterior lateral walls. The Venetian blind pattern or the rain in forest pattern or the fan shadows as described earlier are because of myometrial cyst and hyperechoic lines and dots. It's hyperechoic lines and dots which leads to posterior shadowing, and the myometrial cyst which leads to posterior enhancement, and this leads to typical alternate vertical hyper and hypoechoic bands in the myometrium, which is described as fan shadows by Musa guidelines, the morphological uterus sonographic assessment guidelines. Infiltration of the endometrium into the myometrium usually causes disruption of the junctional zone, and this makes the junctional zone either irregular or you can also see irregularity of the junctional zone in this area, or it may also make it inaccessible at times or interruption. So you are seeing interruption of the endometrial junction here, that is the normal endomyoid junction, and this is the interrupted part of the endomyoid junction. So interrupted, irregular, or inaccessible endomyoid junction is what needs to be mentioned. Then you also need to, if you want to quantify this, you can measure the thickness of the junctional zone, which can be done on 3D or can also be done quite confidently on 2D ultrasound. Of course, 3D shows the endomyoid junction much more clearly. Even if you don't want to measure it, it is 3D, which beautifully shows the invasion of the endomyoid junction with the endometrial strands and also irregularity of the endomyoid junction. But if you want to quantify it, even then 3D is useful. You can measure the thickness of the junctional zone in the part which is irregular, and against that the myometrial wall thickness, which tells you about the severity of irregularity, and the magnitude of junctional zone irregularity can be measured as a ratio of minimum junctional zone thickness to the maximum junctional zone thickness. Adenomyotic uterus may also show a typical question mark sign of the uterus, which is because of asymmetrical involvement of the myometrium, and may also be because of adhesions due to associated endometriosis. Adenomyosis, when focal, also leads to deranged shape of the endometrium and may also come in the way of implantation. Doppler features of the adenomyosis, spiral vessels which feed the endometrium are usually parallel to each other and perpendicular to the endometrium. This vascular pattern is typically deranged, and the vessels have a much larger diameter than the normal spiral vessels, and these are typical signs of adenomyosis, which can be even better appreciated on 3D ultrasound, which typically shows penetrating in vascularity, which is described on MUSA as a translational vascularity. Along with that, the uterine artery resistance is also decreased because a lot of blood is being drained into the lesion itself. Sometimes adenomyosis may present as a localized lesion, and this is called adenomyoma, as you can see in this case. Now, the localized adenomyoma is maybe fairly defined, and sometimes this usually has a hypoechoic margins, but sometimes maybe hyperechoic also. Its location, size, and exact penetration needs to be mentioned. You may, if at all required, mention the minimum distance from the endometrium and the myometrium, though this is not of much concern because adenomyomas are usually not a surgical preference. It may be well defined, it may be slightly ill defined, as I told you, and you need to mention the penetration according to the palm coin, and the shapes may also vary as round, lobulated, or oval. Typically, shadowing is very important because when there are adenomyomas, they may mimic degenerated fibroids. It is the edge shadows in the fibroids which differentiates adenomyomas from fibroids, along with the vascularity, which shows peripheral vascularity with intralesional vascularity in a degenerated fibroid, whereas translesional vascularity in the adenomyomas. Sometimes there may be a localized involvement of the myometrium, the outer wall, especially when it is a secondary involvement of the uterus from the endometriosis, but generally it is an internally located. So because the endometriosis, the adenomyosis continues from the endometrial wall into the myometrium. Polypoid adenomyosis, polyps with heterogeneous echogenicity, and the feeder vessels which shows multiple branches is a polypoid adenomyosis. Cystic adenomyoma is described by some which has a lot of hemorrhagic component inside, but this is not a routine description that is made. The description, when you write the report, must include the symmetry of the myometrial wall, echogenicity, junctional zone irregularity or ill-defined or accessibility, extent and magnitude of the irregularity, and the cause of the same, which means it is hyperechoic wall, cystic lesions, whatever. The lesions, if they are localized, you need to mention ill-defined, well-defined number, location, size, maximum diameters. Mapping of these lesions are very important, along with the vascularity pattern and the scoring pattern. If the lesion is present, it is relevant to the symptoms or not. So when we are talking about adenomyosis and imaging, Transvaginal ultrasound is the modality of choice. Increased myometrial thickness and heterogeneity are the typical features, along with the altered junctional zone, and the altered vascularity is important to be documented. Thank you very much.
And please unmute yourself.
Thank you, Dr. Panchal, for that wonderful lecture, and you have told everything in detail. We don't have any questions right now. Thank you very much once again. Okay, so now we move on to the next session, and that will be a panel discussion. The panel discussion on clinical dilemmas and USG, case-based discussions. And the moderators of this session will be Dr. Mamta Dindayal and Dr. Aarti Dindayal. Both are renowned infertility specialists from Hyderabad. So Dr. Mamta Dindayal, the stage is yours now. You can introduce the panelists and go on with the session.
Thank you very much. I'm just sharing my screen. Give me a moment. How do I share my screen? Just give me a minute. Can you see my screen?
Yeah, right.
Yes, ma'am. Yes, ma'am.
So as I can see, we are nearly 5 minutes ahead of time, but I can see my panelists nice and smiling. So I'm very happy to be here, and I thank the organizers for having given all of us this opportunity to be a part of this wonderful program. I think there's just one little request to my panelists. Though I have tried to limit myself, if we could answer quick so that we complete all the cases completely. And so today, the talk that was, the panel that was given to me was clinical dilemmas. So when you see an ultrasound picture of this nature, the first thing is, it is a clinical dilemma. And the question that I ask when I'm going to operate a patient like this, if I am, is what are the possibilities? Should I operate? Should I not operate? What could be the problems I must anticipate? Because this was a patient who was going in, she's a case of recurrent implantation failure, and she was going in for an IVF cycle. So the first thing I did was that I put down, which is a part of the way I work, I put down the picture I could see on the ultrasound. And then I said, okay, fine, this lady has a septum. She has a myoma, which is going in about 50% into the cavity on the left side. And this is what I said. But to myself, I said, okay, this is what I'm dealing with. So now I had to find an ultrasound solution for that. And so we went ahead to do a hysteroscopy for her. And in the hysteroscopy, we did find that she had a septum. We also found that she had the same myoma that we had anticipated. And of course, resection became a cakewalk, literally, at least in terms of diagnosis. So that is why I have been asked to introduce to you the wonderful panel that I have today. I call it Stump the Expert, but basically what I'm really doing is gluing my audience to use the ultrasound to solve very, very common clinical situations in reproductive medicine. And the experts I have on my field are Dr. Radhika. Would you put your hands up, Radhika? So we all know you, but just that we are recognized. We have Dr. Radhika. Dr. Radhika is the founder and clinical director of Women Health and Fertility, Hyderabad. We have Dr. Syed Wasim. Dr. Wasim, are you here? Hi, Dr. Wasim. Dr. Wasim is a consultant in Nova IVF, Lucknow. Dr. Sangeeta Sharma, could you please put your hands up, please? She is the center head, Jaipur Fertility Center, the past secretary, IFS Rajasthan chapter. So you can see it's wonderful having the whole of India here on the screen. And Dr. Pallavi. Dr. Pallavi is, could you put your hands up, please? Yes, thank you. So that's the conventional way our gods put their hands up. Basically, they are used to identify themselves with us, I think. So Dr. Pallavi is the fertility consultant, Cloud9 Hospital in Haryana. Dr. Rita Modi, I see she has not come on the panel. So Dr. Aarti and myself were supposed to moderate this panel. Aarti has just gone to the hospital for an emergency, and I hope she will be able to still make it. So with this, we start the program, and it is wonderful having all of you. And what I really did, this is for my panelists, what I really did is use some of the very commonly used, the commonly faced cases that we see in reproductive medicine, so that it becomes useful. Though we are used to more complex cases that we handle in our practice, I have put in some of the very basic, because I think what really makes us good reproductive physicians and surgeons is doing the simplest things uncommonly well. So what I'm doing in my presentation is taking the clinical problem, using the ultrasound findings for you, asking you the management strategies, and then of course, you will give me the take-home message for everybody who is here listening to us, who's taken the time to listen to us. So may I request my panelists to give me quick answers, please? So my question to you is, maybe any one of you could answer. Do you believe that in the practice of reproductive medicine as of today, 2D is all that we want? Yes or no?
No. No, we would like to have an addition of this 3D, because it adds on to the 2D values, 2D findings.
Okay. Do any of my panelists differ in this? All right, because it's nice to differ. It's nice to differ because then if we all have the same opinion, we don't need each other, right? So is there any difference of opinion on this?
Ma'am, I certainly feel that 3D is better because it's a newer modality, but I have been using 2D, and I feel that it's quite sufficient, because in a low resource setting, or in a setting where you don't have a 3D, even 2D gives good results. So we can rely on our 2D also.
Wonderful. Wonderful, Pallavi. Thank you for being different. You know, I'm one big crazy 3D follower, so I want to differ. Okay, so just to prove my point, I'm going to ask you some questions, and at the end of it, probably the companies will be very happy because you'll be the one to use 3D the most. So do you think 3D is essential in our practice? Already Radhika has mentioned that it sort of adds to what we get. So here is the same 2D picture, which is now depicted in 3D. So it actually tells you what you are going to see on a hysteroscopy, or you can show your picture, because you remember, Pallavi, that we are in a day of patient-centered clinical practice. So when you show it to the patient, they know that this is exactly what it is. Having said this, we'll go on to some of the common scenarios in ART clinics. However, Dr. Pallavi, I would completely agree with you that 2D, a good 2D is what makes a good 3D. So I completely agree with you. Having said this, today there are only 2 case scenarios that I'm going to discuss. All right, and this is going to take the next 40 minutes. So the common scenarios in our clinic is that we are starting an IVF cycle and we see the patient has a very thick endometrium. And then we put our probe into the adnexa, and what do we see? We see there's a cyst. Okay, these are what we see on a very, very regular basis. So what I'm going to do is I'm going to take my panelists through this, and we'll talk about the possibilities. Can I start treatment? Which parameter should I take advantage of in ultrasound? So having done this, we go to the next. I see the endometrium, it's day 2 scan. Patient is coming for an IVF cycle. She's got a thick endometrium. Is this enough? My tendency is always to draw out what I see on my 2D. So do you think this is enough for me to say I'm going to start or not going to start?
I think, can I answer?
You must answer, Sangeeta. I'm all here for you.
What
Because-
I can see on this on the film, the
Yeah.
endometrial thickness is something like 17 millimeters.
Yeah, yeah,
What I can- So it's,
Yeah.
it's extremely thick.
Yeah.
And I think first of all, we should rule out a pregnancy in this case, because sometimes, especially if she has been down-regulated with GnRH agonist in the previous cycle, sometimes the patient comes to us with scanty menstrual flow and she has already conceived. So
I have done a pregnancy test for her. It is negative. Next.
the second thing is there could be an missed polyp in the previous cycle
Next.
in the past. So
Maybe
I think
another panelist. Yeah, I agree with you. So your first possibility is that you say, okay, fine, there may be a polyp. Pregnancy, completely agreed. A polyp, very nice. Yes,
maybe an endometrial hyperplasia.
excellent. Another panelist, Wasim,
Ma'am, there could be some mucosal fibroid as well.
wonderful. Pallavi. See, now you realize it's so wonderful having all of you because you are answering exactly like how I put down the possibilities. All right. So you said endometrial polyp, very good. Submucous myomas. You can see, I'm sure all of you who are listening to this will suddenly realize that it's wonderful to have such lovely panelists. So a submucous myoma, hyperplasia of the endometrium, like what Radhika said, and of course, a
We have
malignancy.
to rule
of-
out a malignancy also because
There you
we
go,
have to rule
Pallavi.
out.
Yeah, there you go, Pallavi. I've got all my answers. All right. So there's nothing more you can think of. So using this, now what I'm going to do is that I'm going to take you through individual endometrium. How many minutes more do I have? Yeah. So now coming to a persistent thick endometrium. What is going to be my next strategy? My 2D Pallavi tells me endometrium is thick. What should I now do?
Ma'am, if we are still approaching with the 2D scan, we can go for a color Doppler flow also to see the color
Super.
Doppler.
Well, how is it going to help me? Suppose it is, you said there
Ma'am,
may
like
be a
suppose it
polyp.
is a polyp, then we can see a feeding vessel in a case of
Excellent,
polyp.
excellent.
If it is a hyperplasia, we can see multiple vessels arising from the endometrial junction. So that will give. Then if we see the RI and PSV, we can make a difference. Is it a malignancy we are dealing with or it is a simple hyperplasia?
Do you need to depend on an RI and a PSV?
Apparent vasculature itself will tell us.
Yes.
Okay.
The variegated appearance of the vessels, their mosaic pattern, and low resistance flow. Though low resistance flow is not a generalized rule in case of malignancy.
Wonderful, Pallavi. Wonderful. So you are convincing everybody that 2D is the answer. All right. And I completely agree with you because this is exactly what I'm going to say just now. So here is a patient with a very thick, and these are all real cases that I have seen in my clinic, and I've just put everything together. So here is a patient who has a very thick endometrium. And like Pallavi said, I'm going to put a Doppler. And if on the Doppler, I saw that this patient had the pedicle sign positive, you can see a vessel there. And when we did a hysteroscopy, you can actually see the same vessels that you see on ultrasound here going into the polyp. So it's so beautiful what ultrasound can really do for us. Fine. Now, the next question is, the endometrium is very thick. And as you said, we put on the Doppler again. And this time you could see that it was, there was fire inside that endometrium. So obviously we are dealing with a malignancy, and a hysteroscopy proved it, that we were dealing with an adeno-CA. So having said this, we know that what could lead to the diagnosis, like all my panelists have said, is color and power Doppler. So once we have a thick endometrium on 2D, you're going to put in a power Doppler and then make your diagnosis and confirm it. So you're giving yourself a lead. Fair enough. Now, I just want to quickly tell you this case. This was a patient she was a very young medical professional who was married for 5 years, chronic anovulation, came for ovulation induction. She had a endometrial biopsy just done 3 months before for menorrhagia, which showed disordered proliferation. So could any one of you, Sangeeta maybe, could you just see what, you see a thick endometrium here, but is there something else that you see here? And in this case, what would you do?
There is loss of endomyometrial junction.
Yeah.
So, yeah, I can see that the junction is not very clear and there is some invasion.
What would you do? What would you do?
Is this the previous case only, or this is
no.
Different case? Okay. So it could be maybe adenomyosis, or it could be.
What would you do, Sangeeta? What would you do?
Again, we would put a color Doppler.
I put a color Doppler, and that is what it was. This is day 2.
Okay. So
now what would you say, Sangeeta?
Aspirate biopsy should be done because we would require a histopathology. Or
So
we can
where would you do the biopsy from? Would you control it with an ultrasound? Because just the previous month, 3 months ago, she had a biopsy which showed disordered proliferation. I'm trying to get a message across.
Do a hysteroscopic guided endometrial biopsy in this case.
Would you want to do a hysteroscopic guided, or would you just do it with ultrasound? I mean, fine, I do a hysteroscopy.
Endometrial biopsy has already been done for menorrhagia. So this time I think we should do a hysteroscopic guided, because we
does anybody differ?
I think an ultrasound guided biopsy would give us a better picture because it has a very localized aberrant vasculature. So maybe
and you really don't know about tumor spill, right? You're a little concerned about.
May not involve the endometrium.
Yeah. So what we did was we took a biopsy from the area where there was a loss of junctional zone, and we sent it. Of course, the patient, and she's a medical professional, so she said, I want a hysteroscopic guided biopsy as well. So we did a biopsy, and we found, like Sangeeta said, we did a hysteroscopy biopsy of the focal lesion, and this turned out to be a poorly differentiated endometrioid adenocarcinoma. She went ahead for a hysterectomy. So you can imagine now the take-home message here is that in addition, when you see a thick endometrium, it is extraordinarily important that you not only look at the thickness, measure the thickness, look at the vascularity, look at the junctional zone, and of course, then go ahead with a direction towards your diagnosis. Now we'll go to the next one. Is there any other parameter you would like to use in these thickened endometria? We could be a little faster if you don't mind, because we have 28 minutes left.
You can go ahead and do saline infusion sonography to differentiate.
So this is what we did for this patient, saline infusion sonography. And when we did a saline infusion sonography, you can see very clearly that she had a polyp there. Now, the point here is on saline infusion sonography, what would tell me that this may be a malignancy? A quick answer.
Irregularity of the lesion.
Fair enough. And of course, the age, right?
Yes.
Fine. So we went ahead, and this is a very smooth lesion. We did a 3D. We actually found out where the polyp was. So now we know that a thick endometrium has many parameters that you can take. 1 is the thickness, 2 is the blood flow, 3 is the junctional zone, 4 is saline hysterography, and this would help you to make a diagnosis. This again is not for my panelists, but more for those who may be a part of this program. Having done this, there are certain take-home messages, and my panelists can disagree with me on anything. I just put everything down because we are dealing with not you and me, but a group of our colleagues who may want to learn some of the take-home messages. It is important always to know what is the age of the individual, because if it is a menopausal woman who has an endometrium that is even 6 millimeters, I would give it importance, particularly because we are doing IVF for menopausal women in terms of egg donation programs. So it's important that thickness not only looks at the thickness per se, but also the age. It is also important that we look at the ovarian, the endometrial volume, and look at the vascularity very well. You had described how the vascularity should look. The morphology is important. And of course, the higher the color score, the higher is the risk of malignancy. Having said this, we go to the next. Sorry for being a little fast, but then I want to complete the cases, right? So now coming to the features of a benign. Can Wasim, could you just tell us what are the features of a benign polyp?
Ma'am, it has a smooth contour.
Yeah.
And the adjacent endometrium seems smooth as well.
Yeah.
And sometimes we can appreciate the pedicule also.
Yeah. Anything else?
And when we add to the color Doppler, we just see a feeding vessel rather than the whole vascularity.
Super. So it's uniformly hyperecogenic. It has a bright edge. You have an undefined central echo, and you may have a branch and the color score. But the most important point is the junctional zone is intact. Okay. So having done this, this is the feeder vessel that you were talking about, Wasim. And of course, when you do a hysteroscopy, you've already made a diagnosis and your patient is ready for the procedure. But there are a few things that I want to just mention here quickly as take-home messages. You should always do this in the proliferative phase. The risk of malignancy in this is really low. And sometimes you may find in one cycle there's a polyp and it disappears. And it is not, the size of the polyp is not an independent predictor of malignancy. Having said this, I'm going to show you a case. All right. So here is a 32-year-old woman who's come in for secondary infertility. She's a polycystic ovaries and she had irregular spotting. So could you quickly describe, any one of y'all quickly describe this? Pallavi, this is 2D Pallavi.
Okay. This is an endometrium, a thickened endometrium, which is heterogeneous and showing multiple cystic spaces in between. So it can be a polypoidal endometrium or an endometrial hyperplasia. So we need to do a color Doppler flow after this, and then a biopsy will be a confirmatory test for this.
Okay, anybody else could contribute? You're fine, you're absolutely fine. Any one of y'all could contribute. This is a very recent case of mine, and in November of last year. And could any one of you contribute? Anything else that you know?
In the cavity as well with.
Come again. Come again.
There seemed to be some fluid in the cavity as well with shaggy appearance of the endometrium.
Okay. Anything else?
It can be a retained products of conception also.
No, she's not pregnant. Her beta HCG is negative. Her beta HCG is negative.
Okay.
Anything else? It was an unusual case, but then it was a case that I saw. So here you can see very clearly that you can see the bright ecogenic line. So this is a mass, and if you can see, it is going into the myometrium. There's a loss of endomyometrial junctional zone here. So I always make it a habit to draw a diagram as soon as I see something. So you can see very clearly there's a loss of endomyometrial junctional zone. It was a mass. It is very clearly a polyp. It is a polyp with cystic spaces within it, very irregular, and necrotic areas with high vascularity, which is chaotic. Okay, this was a sarcomatous change in a polyp. So of course, she's gone in for a hysterectomy, but these are things that happen in our very young women as well. Now, having done this, now we go to Radhika's thing. Radhika, you mentioned hyperplasia. So would you tell me the ultrasound findings to suggest hyperplasia?
Thickened endometrium, especially in the early proliferative phase, thickened endometrium for menopausal more than 5 millimeter. And in reproductive age, also in fact 5 to 6 millimeter, and increased vascularity.
Yes. Anything else?
Decrease in the improved blood flow basically with decreased resistant index.
Okay. Anything else? So we put down the findings here. A thick endometrium which is hyperechogenic. There may be cystic spaces. The midline echo can sometimes be seen. There is no feeding vessel, and it may be polypoidal on sonohystrography. So that is what you see in endometrial hyperplasia. Now, we'll go to the next. Having understood a thickened endometrium to a certain extent, of course, we'll now go to the fluid in the cavity. Now let's look at the possibilities. I have such a wonderful panel. So maybe Sangeeta, we'll go up, down. So tell me, Sangeeta, when you see—
If there is fluid in the cavity, I think endometritis, or it could be a component of PID. Apart from that, we should also think of any hydrosalpinx or maybe an associated pyosalpinx. We would like to go put the probe into the adnexa and rule out that as well.
Radhika? Sorry, Sangeeta, I'm just trying to get all of them totally into it.
Sure. Yeah. It can be a simple periovulatory period as such, also gives us a little fluid in the cavity.
Fair enough. I like your approach to consider everything is normal unless proved otherwise. So anything else? Periovulatory, in which are the patients who actually show more of this? It's usually the PCO patients who tend to have a little more fluid than normal. But what would be the diameter of that fluid in a PCO, which is physiological?
It should be less than 3 mm.
Yes, that's right. So anything else?
It can be a submucosal polyp or a submucous fibroid also, with a necrosis and superadded secondary infection and leading to a fluid inside the cavity.
Anything
it can
else?
be a case of cancer cervix, where the cervix is stenosed and there is collection of fluid inside. Any cancer for that matter, endometrial cancer and even fallopian tube carcinoma can lead to a— they are rare possibilities, but they can be—
fair enough.
They can present like this also.
Yeah, women by per se, we are rare. Okay, so inside the uterus is as rare as any one of us. So
intrauterine adhesion as well, it also causes fluid in the cavity.
Fair enough. So let's look at, for the purpose of putting everything together, I have now pictures. So when you see fluid in the cavity, important to look into the adnexa and look for a hydrosalpinx. It is important to look for chronic endometritis, very well said by Sangeeta. And here you can see these little micropolyps and this subendometrial echogenic foci. You can see a few synechiae there. And of course, you can have in malignancy of the uterus. Now, this is again a young nurse, actually, when she came to us. She was 40 years old, coming for an egg donation cycle. Her endometrium was just 6 millimeters thick, but for a postmenopausal woman, that was significant. And she also had fluid this of the endometrium. So, and of course, like Pallavi, you mentioned, cervical stenosis has to be excluded. So having said this, let's go to the next one. Let's talk about cysts. Okay, we are not today going to talk about the cysts that we see in polycystic ovaries, because the women, as they say, I'm so classy that I wear pearls even in my ovaries around my neck. So it's we are not talking about this, but we are going to talk about this. Now tell me, what's your diagnosis?
Polycystic ovary.
Okay, bilateral, unilateral?
Bilateral, both ovaries.
Okay, anything else? Anybody else? Okay, so I'm going to add, this was a trick one, because this patient came saying that, I mean, she was a resistant polycystic. She had laparoscopic ovarian drilling, but at another place. And when she came to us, this is what we found. Okay, diagnosed as bilobed polycystic. This is the diagnosis. Okay, so when I did a scan for her, this is what I see. All these were Nabothian cysts.
Oh, Nabothian cysts.
These are all Nabothian cysts. So now, Pallavi, my dear friend, it is only, the patient was not convinced. So it was when I did a 3D and I showed her, you know what, you have polycystic, not only in your ovary, but you also have polycystic, I mean, you have cysts in your cervix, and this is probably a case where it helps. So let's go to the next one. So what is the message here? The message here is, before you make a diagnosis, it is always nice to see the endometrium and the uterus, both in the longitudinal transverse planes, and of course, a 3D reconstruction. Pallavi, are you convinced?
Convinced, but this Nabotian cyst can even be seen if we see a sagittal section.
I know. I'm just after Pallavi. Okay, it's just it's a lighter side. So we have 16 minutes left. So I want to complete this. So here I'm now going to the next step. I told you we finished endometrium. In the endometrium, we finished the different things that could make a thick endometrium. So now we go into cysts. Yes. What is the diagnosis? Quickly, so we finish everything.
Ovarian cyst.
I think it's clear
Simple ovarian.
ovarian cyst.
Simple ovarian cyst.
This cyst was 7 centimeters in diameter. What would you do?
We would put a Doppler first.
Okay, the Doppler shows only peripheral flow.
Okay.
7 centimeter cyst, what would you do?
We would do the hormonal evaluation, like
Hormones are normal. Hormones are normal. Her progesterone is also normal. Her estrogen was 56.
We would reevaluate in the follicular phase, like in the early proliferative phase, so that to see.
She's come on day 2. This is day 2. She will call her back next cycle. Would you do anything else? She's coming in for an IVF cycle, and you have given her 1 month of OC pills. She hasn't responded. What next?
Maybe we can aspirate the cyst because it's.
Okay. Fair enough. So this cyst was already aspirated in another center twice, and it recurred. And so what we did, what would you do, Radhika? Okay, so
endometrial thickness, ma'am,
the
along
endometrial thickness was flat. There was no thickness. She was on OC pills for a period of 3 months. And this is when we went ahead, because it was more than 5 centimeters, we went ahead and did a laparoscopy for her. And this is the 3D picture. Pallavi, this is for you. Isn't it impressive? The only thing the patient is going to agree immediately. So we did a laparoscopy for her, and we removed that cyst. That is how the cyst looked. You can see the stark similarity to what we see on 3D. And this turns out to be a simple serous cyst adenoma. So fair enough, didn't recur again. And we went ahead for a cycle for her. As a matter of fact, she conceived spontaneously. So we should realize that in some way, our procedure, our lab diagnosis itself helped. What is your diagnosis, Sangeeta?
hemorrhagic cyst, ma'am. Although I would put a color Doppler and then see the central mass. And if there is no, okay.
I've done it for you. You asked me and I did it for you. See?
Okay.
So how would you describe this?
So this is a cyst with the heteroechoic picture inside, and there is a peripheral vascularity.
Yeah, the ring pattern. Yeah, the ring of fire pattern.
Yeah,
right?
the ring of fire. So the internal mass does not show any central vascularity.
Fair enough. So you know that it is a benign, it's not a solid mass. It is a, I have 24 slides more. Can I go a little faster? All right. Now the diagnosis, quickly the diagnosis.
Corpus luteum.
It can be a corpus luteal cyst. Corpus luteal cyst.
The corpus luteum cannot come outside the ovary, right?
It can be an ectopic pregnancy.
No, she's not pregnant. All these patients are not pregnant.
It has a sliding sign, probably a para-ovarian cyst.
Yeah, this is a para-ovarian cyst. And this, you can see this the sign where this is called the split sign. When you go with the probe in between the ovary and the cyst, it actually moves away. All right. So, okay, have a look at this diagnosis.
Can be a dermoid cyst.
Please have a look.
We need to put Doppler to see any vascularity in this central part.
I put it. You just have to ask me, Sangeeta, and I'll do it for you. All right. So
probably a dermoid cyst, ma'am.
No, this is an excrescence. When do you call it an excrescence? This is the wall of the cyst. This is the crescent sign, and that is a smooth mass within the cyst a plain cyst, and you can see a wall, and there's no increased vascularity. It is adherent to the wall, so it's not a blood clot. You can see it very clearly adherent to the wall. I've done a 3D reconstruction, and a histopathology showed a papillary serous cyst adenoma. Okay, so the next one is, please look at it carefully. Diagnosis.
I think a fallopian tube malignancy maybe, although very rare. And
Could you quickly, I have 20 slides more in 11 minutes.
Near the ovary, and we can see certain projections inside also.
So they are
Maybe color Doppler.
Okay, I'll do a color Doppler for you.
Yeah, so I feel it's a mass maybe of a fallopian tube, because
What is the origin of this mass? You say fallopian tube, anything else? This patient, we advise surgery. This is a para-ovarian cyst, like I showed you. The split sign was positive. There were excrescences within this, and the color score was 3. So we told her to go in for surgery. She refused and came back with severe pain. Okay, what's your diagnosis?
It looks like a malignancy.
I think it's a malignancy.
This is a whirlpool sign showing there is a torsion of that para-ovarian cyst, and you can see that is the para-ovarian cyst, that is the torsion. You can very clearly see the whirlpool sign here. So we detorsed it, we removed that cyst, and this is how the cyst appeared. And this was, the histopathology was a borderline papillary serous cyst adenoma in a para-ovarian cyst. Okay, so these are not unusual. I've seen 3 of these cases in the last 2 years, so it's not unusual. All right, now in 9 minutes, we'll quickly finish the remaining. Yes, diagnosis. Any one of you.
Mucinous cyst adenoma maybe.
Okay, can you see incomplete septa here? These are incomplete septa, right?
Hydrosalpinx.
So this is a cogwheel sign. This is a cogwheel sign. This is the mucus folds, is a cogwheel sign, and you see incomplete septa there. So it can be a challenge. So it's important that we evaluate this. So we always do a 3D here, Pallavi. We do a 3D here, because then you need to talk to the patient and you need to assess it. So this is a 3D. And now you tell me, is there a need to characterize this by 3D? And why? Can I answer this so that we complete? All right. This is a hydrosalpinx very clearly. You see there is a incomplete septa here, and we do what is called a 3D with the Sono AVC general. So you can actually show the patient these are the follicles, and this is the hydrosalpinx curved over itself. And then when we reconstruct in a rendered view, you can see mucosal folds here. There are synechiae within the tube. So you tell the patient, you know what, you will require removal of the tube. It is extremely important to characterize a lesion, because you have to tell the patient you cannot reconstruct it, you need to remove it, and you need the consent of the patient before surgery. So this, Pallavi, I think is one of the greatest advantages that you can convince your patient even before convincing yourself. Okay, diagnosis. This is easy. Any one of you.
Dermoid.
Correct. All right. So this is spotting the diagnosis. It is a dermoid, and because of paucity of time, I'll just quickly enumerate here some of the features. You could have acoustic shadow. The features of the dermoid will be acoustic shadowing. You will see fluid levels. You will see bright echoes, and of course, you make a diagnosis much before. All right. So we go to the next one. This is an interesting case. I'm going to spend a little time a little time here because it's a very interesting case. It's a I mean, it is in the adnexa, I saw this mass with very irregular, it was probably, I've seen only 2 cases in my career like this. So can any one of you make a diagnosis? It is different from the ovary. It's at the side of the ovary, is different from the ovary.
Is it a fallopian tube malignancy?
This is what I made a diagnosis, all right? And then we sent her for a laparoscopy. And in the laparoscopy, what they found was Dr. Mohan Vamshi had an oncologist here, did the laparoscopy for her and said, Mamta, you missed it. It is a myoma, a polyp, myomatous polyp undergoing degeneration. And so all he did was he removed that myomatous polyp, sent it for frozen section. Frozen section said it is only degeneration in a myomatous polyp, till he jumped out of his chair when the histopathology came, and this was a leiomyosarcoma in a polyp coming from the uterus. So it was malignant. I made a diagnosis of fallopian tube malignancy, but here you can see very clearly, he even checked the fallopian tubes. Okay, so this was a leiomyosarcoma in a myomatous polyp. So it was an unusual case, and I felt it is important that I put it up here. All right. So having said this, we'll just go quickly in 5 minutes that we have into what is diagnosis. We'll go a little faster. Pardon? Diagnosis.
Looks like a hemorrhagic cyst again.
Yeah. Anybody else?
Endometrioma.
Correct.
But it has.
Yeah, this is the same one, Radhika. This is the same one. You can see a blood clot here, but it's an atypical endometrioma, but there's no vascularity there. And I've also put up the vascularity pictures for you. There's no vascularity in that mass. There's only peripheral vascularity, and it is not adherent to the wall. Okay, so it's not a solid tumor. All right. If I see the same mass in a postmenopausal woman, would I be cautious? Yes, no?
Yes.
Why? Why?
Chances of malignancy are more in postmenopausal.
What is the percentage? What is the percentage? Same mass, premenopausal, same mass, postmenopausal.
Around 35% in case of postmenopausal.
Fair enough, fair enough. So you're nearly there. But the data shows that the same mass in a premenopausal, the chances of it being malignant is about 3.8%. The same mass, same features, postmenopausal 44%. So my take-home message here is never ever make a diagnosis of endometrioma in a postmenopausal woman. All right. If I see an endometrioma in a patient, what does that tell me about the patient when I'm doing a laparoscopy?
You're looking for additions. So
yeah, but what does it tell me? If I see an endometrioma, I make a diagnosis of endometriosis, grade 4 or whatever. But what does it tell me? What should I be careful of? What is the incidence of solitary endometriomas? Without any pelvic pathology, what is the incidence? Only 1%. Did you know that? Well, I came to know this only when I studied for this lecture. All right. So I'm actually in a better position because I know what I'm putting up, right? So it's very unfair to you, but it's something I learned, and you learn every time you teach. I think the person who is being a moderator is actually in a better position, right? So at this point in time here, you have an endometrioma, but when you see an endometrioma, it tells you that it is a marker of deep infiltrating endometriosis because only 1% is actually solitary. Okay. This is a patient who had recurrence of endometriosis within a year of the previous surgery. We have only 2 minutes. So could you quickly say, I put a Doppler in that mass. What does it show?
Quite vascular to be called as endometriosis.
Yes, it's very vascular. There's central vascularity, right, Radhika? Okay.
Yes,
so what would you suspect? What would you suspect?
maybe some malignant changes.
Malignancy.
This is the laparoscopy. It showed absolutely normal pelvis. And again, Mohan Vamshi still told me, you know what, Mamta, I think you're overdiagnosing. Till the histopathology came, and this was a well-differentiated endometrioid carcinoma. What is my take-home message to all here is always be careful when you have recurrence and endometriosis occurs earlier. You have to suspect endometriosis and endometriomas. If you see kissing ovaries, what does it signify? Sorry, if only I have 1 minute left, so we'll go quickly through this.
Adhesions inside.
Yes, you must anticipate bowel involvement. And also 80% of them have fallopian tube obstruction whenever you see kissing ovaries. So this is not the kiss that we would like, right? So the next one, quick diagnosis.
Adhesions inside the
Asherman syndrome.
Yes, perfect.
Asherman syndrome.
Perfect. So this is 3D. This is for you, Pallavi. 3D, see how it helps. You can tell your patient, right? And of course, go ahead. So I end my talk just now. Thank you so much, my dear panelists. You've been so wonderful, really, really so wonderful. Time, though it was so much time was given, it always looked short. So how do I end my talk? I end my talk by telling you that ultrasound is more cerebral we are what we repeatedly do. Excellence then is an act and a habit, and we should remember that ultrasound is 75% cerebral, 25% manual. I thank the organizers of ACE, my dearest panelists, and my wonderful team, and I cannot but stop thanking my patients who continue to teach me so much every day. And I thank you, my dearest panelists, Pallavi, Wasim, Radhika, and Sangeeta. It was wonderful having 4 of you. Wonderful knowing you virtually till we meet you and I give you a big hug. Till then, my only message to you, considering my age, is you are the artist. Your patient is your canvas.
Thank you so much.
Be sure to take properly every image as optimally as possible. Evaluate your images and be sure you're using your best image, because who knows, you'll be a moderator again and I'll be on that other side listening to you and feeling very happy that you made wonderful images. And to demonstrate anatomy, both normal and abnormal, you must take your best pictures for lectures like this, because ACE will definitely call all of you again. Thank you very much. And I think we've finished on time. Thanks to all of you.
Thank you.
Thank you, ma'am.
Okay, so they didn't cut us off, so that was a good thing. Is there somebody to take over, or are there any things that any one of you would want to say since they are keeping us on?
Ma'am, it was a wonderful session. I learned a lot.
Thanks, Wasim. That's very sweet of you, Wasim.
Thank you.
Yeah, whether Wasim, if I hope I do see you sometime, Wasim. Yeah,
Sure, ma'am. I would love to meet you.
I would love to come for a 3D ultrasound training at your center.
Absolutely. Absolutely. I will convince you to buy a 3D machine.
Yes, ma'am. So remember me.
Radhika, it was wonderful seeing you. Though we live in Hyderabad, we hardly see each other. And I do hope we will see each other. Yeah. Sangeeta, it was wonderful.
Nice to meet you.
And they've given us so much of time. I wish I would have put up a few more cases, but then I limited myself to only 2 things, the endometrium and cysts.
The most important ones.
Yeah, well, I want to say that just now. I'll tell, she couldn't come. Aarti couldn't make it as yet. She rang me up 3 times and I said, doesn't matter, I'll hold fort. Yeah, she's the one who made the presentation and I'm just sort of representing her and taking the credit for what she did. Yeah, that's what our children do to us, right? So how do we get out of this? Do they leave us on this?
I think we should.
Okay.
Okay. Thank you, ma'am.
Thank you so much, ma'am.
Thank you, ma'am.
You just leave?
Hello, Dr. Geeta ma'am. Could you take over the session?
Make me unmute karo. Unmute karo. Hello.
Please take over the session.
Yes, but very others, other chairpersons are there.
Dr. Naina Patel is joining in just few seconds.
And Jyoti Bali?
Jyoti Bali will not join.
Huh? Not joining.
Jyoti not joining. Yes.
Okay. And our speaker?
Speaker will recorded session, ma'am.
Recorded session?
Yes, yes.
They will come physical here.
I will
Ma'am,
present
they have
them.
already sent their recordings. We will play it.
Then the questions and answers, how they will give? There is 3 minutes. Okay. I think it is time is there. Start it. Can you start it now?
Dr. Naina Patel also join.
Later join. You know, this is a very
Yeah,
important
join.
session. That is counseling. Counseling in ART is very important because you have to tell them what they're going to. Oh, Dr. Naina is here. Naina, very nice to see you, though it is virtual. Unmute yourself. That you can talk.
Same here. Very nice to see you. At least.
Yes, after a long time. But though it is not physical, and we are waiting for having a physical conference now. We are fed up with this all the webinar and other things.
I know.
Yeah.
It's not the same.
You know, everybody agree that counseling is very, very important in ART. Before it, because there is so much misunderstanding and about ART, they don't know how it will be your own children or not, whether they'll be all right or not, whether there will be any physical deformity, all these things they'll ask you. And about the cost also, they'll be afraid. So, before starting ART, we must have the counseling, both husband and wife. And then during the counseling, we must tell them what is going on. Whether they have to take rest, whether they have to take leave from their service, everything they will ask you, all this. And ourselves should not be very worried about this. We must tell them because they're already depressed of infertility. And if they don't have the proper knowledge, they'll be more depressed. So I think, I'm very sure.
Ma'am, I am showing Dr. Padmarekha Jigre. She will introduce her and I will then play her video.
Yeah.
Okay.
Padmarekha. Where is she? Now, the Padmarekha Jigri has counseling in young and old co-responders. Can we have the biodata of Padmarekha? Can you show the CV of Padmarekha so that everybody can see it?
It's on the screen, ma'am.
Where is it? It's not shown. The CV of Padmarekha.
Now can you see, ma'am?
No, we cannot. We cannot say. Hey, Raju, अरे आप लोग क्या हिच बोल दो? अरे देखो
Dr.
तो
Naina Patil, can you see the CV?
No, I cannot see the CV.
आपने बोला? No, no, शुद्ध but we cannot see here. एक दाव तो एक
স্ক্রিন শেয়ারটা হচ্ছে না দেখো
হ্যাঁ
স্ক্রিনটা শেয়ার
Is it visible now?
No, not visible. Then you show her talk. If CV is not visible, show her talk. Recorded talk.
Good morning, everybody. I would like to thank Dr. Gautam and the entire organizing team of ACE 2021 for organizing this excellent event and inviting me to speak on counseling in young and old poor responders.
But we cannot
While
see.
we are immersed in the nuances of scientific nuances of a team.
Hello, we cannot see. We cannot see.
Yeah, we are just doing, just wait for 1 minute.
Nothing can be seen.
I'm just doing it.
আগেরটা তাই হয়েছে
আগেরটা স্টার্টিং এর না তো বলছিল আগেরটা রেকর্ডেড ছিল আগেরটা তো দেখলেন না
Good morning, everybody. I would like to thank Dr. Gautam and the entire organizing
No,
team of
not seen.
ACE 20.
Not seen.
Organizing team of ACE 2021 for organizing this excellent.
Hello, is it all right now? Hello. তুমি কে বলো তো আরে দাঁড়াও তো।
ACE 2021
Yeah.
for organizing this excellent event and inviting me to speak on counseling in young and old poor responders. While we are immersed in the nuances of scientific nuances of taking couples through treatment, particularly when they're poor responders, at times it may become we may overlook the amount of distress they experience and go through while fighting against odds. And it is extremely important, hence, to look at what are all the aspects we need to bear in mind and why counseling is important in poor responders and why it may have to be done differentially in young and poor responders. It's very important to note that 40% of couples going through IVF abandon treatment after the first cycle itself because of physical or psychological burden or a combination of the two, and an additional 10% quit because of unexpected poor response in first cycle. And this is extremely important for us to take cognizance of, to provide a holistic approach to any treatment. And it is so we will go through, look at the areas why some people experience poor response in IVF and what are the implications of diagnosis, how actually we diagnose this condition to highlight the need for appropriate counseling. So poor response in IVF happens because of varied etiology. First and foremost is the age-related reduced response. So we know that as women go through their 30s, they experience a progressive decline in their ovarian response, and it appears that it is more dramatic beyond 37 years of age. However, a proportion of them may experience poor response at a younger age due to either various receptor polymorphisms affecting their response to gonadotrophins, previous pelvic or ovarian surgery, past pelvic or ovarian infection damaging the ovarian follicles, and in many of them there may be no apparent cause for it, and it's usually diagnosed based on age of the woman and the results of ovarian reserve markers such as FSH and, more importantly, AMH and AFC. So when we diagnose poor response, we have to bear in mind that these couples are facing additional challenges apart from routine infertility related issues of reduced reproductive lifespan. So they're given a very important diagnosis and they have relatively less time to plan all the scenario around the treatment, and they have to, they need to go through the treatment as urgently as possible, or typically the treatment has to be fast tracked, and they have to accept a reduced success despite all these important decisions they have taken, and also have to make provision for increased financial burden. In addition, there are direct treatment-related issues as to, there is a choice of treatment of conventional IVF with high dose of stimulation, gonadotrophin stimulation, whether more recent options of dual stimulation or repeated cycles and pooling of embryos, or indeed not natural or modified natural cycle should be considered, and what is the expected success rate with different strategies. Whether there is need for considering any experimental strategies such as ovarian rejuvenation, or whether one or more of these have to be thought of in combination. What about the interventions such as androgen supplementation or growth hormone supplementation and any additional supplementation? So there is a lot to take in, and hence it becomes apparent why counseling has to be has to play an extremely important role to achieve the maximum possible in these couples with poor ovarian reserve. There have been two important set of criteria used for diagnosing poor responders. The first concentrated effort has been Bologna criteria, which says that anybody who has had 2 proven poor response to conventional IVF with maximal stimulation dose of gonadotropins should be considered as poor ovarian poor responders, or those who are older and have had at least 1 cycle of poor response to maximal stimulation, ovarian stimulation, should also be considered as poor responders, whereas those who have just abnormal ovarian reserve tests, either low antral follicle count or low AMH, can be considered as expected poor responders. Then there has been more detailed stratification of this to identify, to classify women into different subgroups of low prognosis through Poseidon criteria into 4 subdivisions. Group 1 includes young women below 35 years of age with normal ovarian reserve markers, but who have unexpected suboptimal or poor response in the first cycle of IVF. And group 2 consists of women who are 35 or above with normal ovarian reserve markers, but have an unexpected suboptimal or poor response. Whereas group 3 includes young women with low ovarian reserve markers, indicating that they would respond poorly to ovarian stimulation. And group 4 includes women of 35 and beyond, who with low ovarian reserve markers. So why this stratification is such a detailed stratification is important. It appears to be important because we are looking at age and ovarian response, and they play different roles in and contribute towards success. So it is important to stratify them. While pregnancy and live birth rate generally are associated with increasing number of age, this doesn't appear to be a simple, straightforward correlation. Age plays an important role because despite the number of eggs we obtain, the number of euploid embryos are very important, central in deciding the chances of somebody achieving a pregnancy, and number of euploid embryos decline with increasing age. So here comes the importance of using an ART calculator devised by this Poseidon group, either before IVF or following stimulation. So before we know the number of oocytes, if we put in a set of criteria, that is age and source of sperm, and as desired by the calculator, it actually predicts how many oocytes are required. We can set the number of success of probability, that is success probability, we can set it at anywhere between 50 to 90%. And depending on how precise we want the results to be, it gives the number of oocytes which are required to achieve a single, at least one euploid blastocyst. This helps tremendously in counseling the couples before they go ahead with treatment, to sort of give them an idea as to how many cycles of treatment they may have to be prepared, depending on what is the expected oocyte yield. Whereas post-treatment, following retrieval, again, putting in the necessary criteria, it actually also helps us to guide couples with the information as to what is the probability of achieving at least one euploid blastocyst. So providing scientific information and a visually easily appreciable information plays a very important role in counseling these couples to make best of the possibility they have of achieving pregnancy. So looking at some more evidence, here is a recent review looking at various studies published so far, which looking at the importance of counseling. So the authors have concluded that counseling plays a very important role in poor responders prior to and throughout IVF cycle. And with appropriate counseling, there appears to be a reduction in their distress level, and distress level faced by these couples appears to come down to the same level as those who are considered as normal responders. And they hence advocate that there should be counseling provided by clinicians, which highlights all the ramifications of treatment, and specifically mental health professionals should address any of the psychological or emotional issues the couples might be facing. This not only helps in allaying their anxiety or address more worrying psychological issues, but also may contribute towards improving the pregnancy rate. So considering this, the authors have concluded that one of the very important recommendations is a key factor is to set the expectations realistically with the patients and their partners prior to beginning IVF, and then reinforce all this with ongoing counseling before and during treatment, both in formal and informal ways, meaning in addition to mental health professionals, informally, IVF nurses play a very important role as they frequently meet these couples. They can take each opportunity of scanning or blood collection or indeed administration of injections when necessary to offer counseling and also highlight the other team members if more directed counseling is essential. Again, one more study here looking at the nursing support and impact on quality of life. It stresses the importance of role of IVF nurses played in achieving better outcome for these couples going through IVF. Now, this is the most recent review which has looked at the efficacy of psychosocial interventions for both psychological and pregnancy outcomes in infertile men and women. And as we can see here, the forest plot, all the studies uniformly have shown strong benefit, significant benefit of psychosocial intervention as far as improving the pregnancy outcome is concerned. And we know that achieving a pregnancy in itself is a major mood booster, and this is extremely important to note. In addition, a review of meta-analysis of the studies has also shown that psychosocial intervention has a strong beneficial effect on the psychological outcomes in these couples. So it is very important to have these key recommendations in mind while dealing with couples with poor ovarian reserve going through IVF. It is extremely important that we discuss clinical aspects in detail. Sometimes it is important to have dedicated sessions with these couples before going ahead with the treatment, so they are aware of all the aspects we need to pay attention to. Young and older poor responders may have different success rate despite similar response to ovarian stimulation, because of the impact of age on quality of oocytes, and hence the availability of euploid, development of euploid blastocysts. Arrive at a consensus with couple about the best options or interventions for them, provide them with realistic goals at each stage of treatment, and then encourage discussion with designated team members regarding their specific concerns, actively address possible emotional distress, and address other concerns, financial, family, and societal. Many a times just making them open up to these, discussing these options itself is a relief for them, and they may not necessarily be expecting any solutions to be provided by the team members, particularly when family issues or financial issues are concerned. Just a shoulder to support them. May all that be they'll be looking for. So to conclude, diagnosis of poor response necessitates early recourse to IVF. Age and number of oocytes are two important factors which contribute to success of outcome. While we are expediting their treatment to offer them the best possible success, it's important to use all the available evidence during pre-treatment counseling and set realistic goals. Current evidence strongly supports ongoing counseling before, during, and immediately after treatment to minimize the treatment-related anxiety and depression, to also reduce pre-existing such issues, and improved psychosocial scores contribute towards improvement in pregnancy rates as well, and to pass on this information to them itself may have a very positive impact on these couples going through very strenuous and tough period in their life. Thank you.
Dr. Noina Patel. Hello.
Hello.
Dr. Noina, please introduce Dr. Narendra Malhotra.
No, it's Dr. Narendra Malhotra's talk. I
Yeah.
don't see the CV. First of all, Rekha gave a very good insight into the importance of counseling and how it will improve our practice and how it will give confidence to the patient. That is very important. And we have also seen litigations now when if you have not counseled properly and done the procedure and there is no good outcome. The next talk is by Dr. Narendra Malhotra. Can we have his CV? I know he doesn't need any introduction. Okay.
Yeah.
Professor.
We can see now.
Yes, yes. He is the Managing Director, Global Rainbow Healthcare, and he is been president of almost all the organizations, very dynamic. And we can tell he is like the universe of IVF and total gynecology. So, Dr. Narendra Malhotra, the stage is yours. We can start this talk now.
I think it is also recorded.
Yes.
It is also recorded. Hello.
A very good morning to all of you. It's indeed a pleasure to be here as a speaker in this ACE conference. Wonderful conference. Today, I'm going to tell you how to handle unclaimed embryos, their legal and ethical aspects. I am Dr. Narendra Malhotra, the past president of ASAR, and with my team at the Global Rainbow Healthcare India and ART Rainbow IVF Agra, I bring you greetings from the city of Taj. So what do we do? After IVF, some struggle with what to do with the leftover embryos. There's so many left sometimes. Records of the UK fertility watchdog, the Human Fertilization Embryology Authority, shows that there are 1687260 embryos transferred since 1991, and almost the double of them have been destroyed. In the period from 1 July to 2014 to 30th June 2015, 1 year, 84,000 embryos were transferred and 1,72,184 embryos were destroyed. So are we making extra embryos? And if we are making, then what to do with it? So is there an alternative proposal to the destruction of abandoned human embryos is what we want to know. Now, what constitutes of abandonment? Abandonment is very important to describe legally before we start throw these embryos. So storage facilities may deem an embryo to be unclaimed if at least 5 years have passed since the creation of that embryo. Diligent efforts have been made to contact the participants without any success, and the participants acknowledged in the previously executed written record that they have been informed about the possibility that their embryos will be deemed unclaimed if they do not come back and claim or pay for its maintenance. Now, the recent developments which have happened are that the legal and the ethical debate surrounding the storage and destruction of frozen embryos or mass destruction, because there is a lack of law in Britain, United States, everywhere. So different countries have adopted different approaches to deal with the leftover embryos. In Britain, unclaimed embryos must be destroyed within 5 years after creation with absent instruction from the parent donor. If the parent donor wants extended storage, yes, then they can. So this British law came into being from August 1, 1991. 5 years to the day, thousands of embryos were destroyed, and there was always a controversy that you have destroyed potential life in these embryos. Now, these countries have divergent policies, and they're struggling to how to create an effective embryo disposition legislation because of the complex ethical and moral issues involved in it. It is undecided and unknown whether mandatory disposal, indefinite storage, forced implantation into other women, public opinion, clinical agreement, what should be done to this. Written agreements, of course, is very, very necessary. Although these agreements provide some contingencies, unforeseen contingent may arise and lawsuits may still occur. What does the French law say? French law came into being 29 July 1994. Restitution of embryo to the couple who underwent MAP. For embryos existing before implementation of this law, the restitution is not forbidden after a period of more than 5 years. Thus, for embryos, the period 5 years already recommended by the National Advisory Committee of Ethics and Law does not appear to be such strict criteria as in UK. For embryos frozen after the legislation, it still remains uncertain whether the restitution will be allowed after the storage of 5 years if the couple still desires parenthood. The UK law imposes now 10 years maximum of eggs, sperms, and embryos. The time restriction was introduced in 1991. However, the Parliament recognized that maximum storage period would be unfair to certain patients. Some patients may require even more prolonged, particularly cancer patients who are undergoing treatment, and their embryos on request could be stored even for more. Frozen in time, clarifying the IVF laws were the headlines of many, many newspapers and news things. More than 120,000 human embryos are now lying in storage in Australia. What to do about them? Over the past decade, Victoria alone, over 20,000 embryos were discarded as a result of mandatory storage limits set by the law. So enhancing reproductive opportunity project to find out whether IVF patient felt they were able to make the decision on what to do with stored embryos or not. So this was done for these. New South Wales, the ART procedures, the law distinguishes gametes and embryos for personal use and donated gametes. Donated gametes collected after 2010 may be stored for a maximum period of 15 years in Australia. And after that, South Australia has different laws in different areas, not to be stored more than 15 years. So what is the way forward? The existing limits on storage were designed to draw a line so that the patients have mandatory and they can extend to some period. However, wider use issue is whether categorizing some patients as more deserving is justified or not. Cancer patients, should we store beyond 10 years or not? because the motherhood in cancer patients has been deferred. So in modern world, the autonomy choice, the less worry about safety, storing genetic material long time, the whole rationale feels to be outdated. What does our Indian law or ethics say? Now, India, we still don't have a law. We have the ART law pending in the parliament. We have the surrogacy law pending in the parliament. However, this has led to a growth of unutilized pool in India as well, the embryos. Former Miss World, Diana Hayden, at 42 gave new hope that you could have stored your embryos or your oocytes before and then got pregnant when you want to. So the freezing oocytes and preserving fertility became very popular in India. Now we have the national guideline for accreditation, supervision and regulation of ART clinics in India. And this provides guidelines for storage and destruction of embryos also. The scenario is where there is a conflict or a divorce in event of the absence of a consent by the couple is yet to knock on the doors of Indian. So Indian courts have not yet faced this criteria. So we don't have any legal court ruling over these. The failure to make payments despite remainders, let the embryos perish, conflict of divorce, these problems are yet to arise in India, especially in the legal courts. However, there is a need of concrete legislation as Indians are very close to their biological material and have conservative mindset in terms of progeny. Thus, they avoid any clinic patient dispute. We need clear, concrete laws. So, no contact with the clear written disposition, no contact written or verbal with the disposition, no contact written with the states to do not discard are the clinical scenarios. And in this, the ASRM has come out with the ethics committee. No contact with clear written disposition, you can dispose these embryos. No contact or written or verbal, the best way to ensure that the patient choice is respected regarding the disposition of cryopreserved embryos is to ask the patient to state their intention in writing for cryopreservation at the time of the IVF cycle. No contact and written disposition, states do not discard. In no situation, however, should unclaimed embryos be used for research or reproductive purpose for other patients unless a prior consent of disposition has been documented. This is very, very important for unclaimed embryos. The ethical issue is personhood, moral status of the embryo, extra embryos, safety methods, public policies. What affects this? Culture, religion, developmental, where IVF and infertility process and develop, parents' feeling and beliefs, personal feeling and belief, how to make the decision make easier. You have a checklist which you make them sign. Are they abandoned? Check your program, check the ASRM guidelines, check the Indian guidelines. Do not unintentionally trigger abandonment. Just say, no one has come, so let's say what you do and what you hard choices. Take proper consents at the time of first IVF cycle, that if we get extra embryos, what has to be done with it if you don't come back. Parental rights, duties, clear advance directives, defined abandonment clause, defined authority. The newer challenge is that the couple are left heartbroken and furious after a sperm donor has backflipped and insisted that the embryos be destroyed. Now, this possibility is rare, but it can arise. So then the abnormal embryos. So if they do we need to test them? Now, here is a fantastic example. Just in this pandemic, a baby was born from 27-year-old stored embryo, and this is probably the future. Now, this happened on October 14, 1992, a few months before Bill Clinton was elected. These embryos were frozen. In February 2020, just as the COVID pandemic began, 20-year-old Tina Gibson, a Tennessee woman who was struggling to find these embryos, were implanted into her. And October 26, 2020 came Molly, a 6-pound, 13-ounce baby, who broke the record of the longest frozen embryo to give to her birth child. The embryo created her sister also, Ima, the previous record holder for 24 years, but this is now. So this will tell us that live births and normal live births can occur even after 27 years. So who makes this choice is the patient, you, the courts, the society, and whatever. And cryobank facilities are running out of place. We have so many banks which are full of thousands and thousands of embryo. So we need a directive The ART clinics need a directive on defining what is unclaimed embryo, what can be used for research, what embryo can be given for adoption, and how to dispose the embryo. I thank you very much and leave you with this thoughts and leave you with coming out with ideas to give for the ART law on what all of you do to the embryo, unclaimed embryos, and what we should be doing. Thank you, Ace, for inviting me here to talk on a very controversial topic which needs to be addressed top priority by all of us. Thank you very much.
Raju, thank you. Thank you very much. It's a very nice lecture. Really, it is a problem. And some infertility couple, they also aged one, the embryo, frozen embryo. What should be given? Whether it's to be given to them or not is also important. Now, we're going to another topic. Shivani Shazdev. Nana, do you want to talk anything? Nana? No, Shivani Shazdev, go.
Yes, Dr. Geeta wrote.
Yes. Yes.
We are waiting for Dr. Shivani's talk. It was a wonderful talk and insight by Dr. Malhotra. We are also worried what to do with so many embryos and
yes, that's very important.
Very, very important. Yes, so let us hear to Dr. Shivani now.
Shivani Shazdev, everybody knows, she's MD, DNBA, MRCOG, Director of SCI Healthcare, fellow member of Imperial College, founder, Secretary, Delhi State Chapter of ISAR, Secretary, Delhi State Chapter of ISPAT, General Secretary, INSTAR, ex-Vice President, Delhi Gynae Forum, South, Vice Chairperson of Women Doctors Wing, IMA, South Delhi. Now, show her talk. Her talk will be on surrogacy, the current status in India, and update on 2019 bill, as now the clause of close relative is replaced by willing women plus some clinical aspect of surrogacy. Let us see our lecture. Dr.
Warm welcome to everybody in ACE, and thank you so much to Dr. Gautam for giving me this wonderful opportunity. Thank you so much to the entire team of ACE. I will be speaking on surrogacy in India, the recent updates. The reason I'm speaking on this is because I get asked so many questions. People are so unsure. Is the bill passed? Is surrogacy allowed? Are we doing something illegal? So just to clarify all the doubts, I will be giving you the updates about what has been going on in this field and what is the current status. So one of the best quotes that perhaps is applicable to surrogacy is this one by Maya Angelou: "Be a rainbow in somebody else's cloud." As we all know, there are two types of surrogacy. One is traditional and one is gestational. So traditional is when the surrogate mother's own eggs are used, and gestational is when the embryo is completely unrelated to the surrogate mother. And all the modifications of surrogacy that have been passed, only and only gestational surrogacy is allowed in India. So what is the framework right now under which surrogacy is done? First of all, it is the ICMR guidelines. These guidelines came first in the year 2002. They were updated in 2005, and then they have seen multiple, dozens of updates. So you always have to keep checking the website for what is the current guideline. Next, we have the Law Commission Report 228. Then we have the Supreme Court judgment, Baby Manji Yamada versus Union of India in the year 2008. The PCPNDT Act notification of 2014. Along with that, there was also a proposed ART bill 2014 and 2019. Then there is the Ministry of Home Affairs, or MHA, ICMR, and DHR. DHR is Department of Health Research, which has also given notifications for surrogacy. And DHR, in fact, has also given notification for cryo-shipped embryos. What is the current status for them?
And what is sub judice means that this case is not yet decided. It is still going on in the Supreme Court. That is Jayashree Ward versus Union of India. So this is a lawyer from Maharashtra who has filed a case saying that embryos are shipping of embryos is like you are shipping human beings. I mean, she has compared it to very nasty terms like trafficking. So this is what is going on right now in the Supreme Court of India with regards to surrogacy. The court has clubbed it with Jan Bella's case, and Justice Gogoi was there. And right now, of course, it is going to the case is everything is at a standstill. Then we have the Surrogacy Regulation Bill 2016 and 2019. So what you should know was Minister of Health and Family Welfare, Dr. Harshvardhan, in the Lok Sabha on the 2019 July 15. It was passed on August 5th, but then it was referred to the Rajya Sabha Select Committee both in 2017 and also in 2019 because there were huge number of objections to the bill. So currently, what is the notification under which we are doing surrogacy? This is October 2015. This was about provisions of the Act. All the ART clinics or centers, IVF clinics or centers, surrogacy clinics or centers, PCPNDT Act. So this is the notification which talks about surrogacy center registration. And as present, as of today, 2021, the surrogacy contract between the parties, which is recognized by the Supreme Court in Baby Manji Yamada versus Union of India, and the ART clinic guidelines, these are the two main guiding forces of all surrogacy agreements. In terms of compensation, these are the terms which is used: altruistic, compensated, and commercial. So right now in India, we are doing all three kinds of surrogacy. Although there is a proposal to ban commercial surrogacy, it is not banned yet. So altruistic would mean that there is no finances given to the surrogate mother in any form or any respect, except if you see altruistic surrogacy in England, in UK, or in Canada, or in some other parts of the world also, they are allowed to compensate the surrogate mother. So in the UK, the maximum compensation is £15,000. In Canada, it is $28,000, but it can be extended even more than that. So there are certain countries where they say altruistic, but they are giving compensation to the surrogate mother. The second one is compensated, which will mean that only reasonable expenses during pregnancy and postnatal care will be reimbursed. So in this, you can also add loss of wages, but overall it is the payment that you make is more of a compensation. And there's in commercial surrogacy, that is apart from reasonable expenses during pregnancy and postnatal care, which are reimbursed, the surrogate can get compensated for the pain and the effort she takes in the process of doing surrogacy. So practically, how does it work? The intended parents first contact a clinic for infertility treatment. The investigations are done, tests are done, and medically we know that surrogacy is indicated. So the clinic will send the request then to an ART bank or to a law firm that we have a patient for surrogacy, kindly arrange a surrogate mother. Then the surrogate mother will be recruited, her counseling, the contract is signed between the ART bank or the law firm and the surrogate mother. Tests are done, psychological assessment is done, police verification, background checks, affidavits are made, her insurance policy has to be taken out in her name. Nominee means who is going to be responsible that God forbid something happens to the babies. So the intended parents have to give two nominees, and for the surrogate mother also, if she's doing surrogacy, who is going to look after her children. So we need to have some family members with us as nominees. Then there is a meeting between the parties, the ICMR contract, the paperwork, the medical treatment, and finally the embryo transfer and the pregnancy test. So initially, the 228th Law Commission report on the need for legislation to regulate assisted reproductive technology clinics as well as the rights and obligations of party in a surrogacy had said that surrogacy agreement should contain reimbursement of all the reasonable expenses to carry a child to full term. It was nowhere recommended that it will be close relative or that no compensation at all will be allowed. They say that it is not for commercial purposes, but compensation is definitely allowed here. Then after this law commission report came some guidelines by Ministry of Home Affairs. So this came in 2012, 2013. At that time, a lot of cases of international surrogacy were going on. And these guidelines were, for the first time, they said that the man and woman have to be married for at least 2 years. There has to be a letter from the foreign country which says that the babies are going to be recognized. And indeed, many of the countries have these letters to say that surrogacy in India, if the baby is born, then as per their guidelines, they will recognize it and give legal status to the child. So this is one of the sample letters I've put here from the British High Commission. Then after this came the ART bill, which was put out for public discussion. And along with that, there was a notification which came out from the Department of Health Research, DHR. Literally just came out at 8 p.m. in the evening, and we had to suspend all the cases from the next day. So this was a very, very difficult time in the world of surrogacy, this 2015, 2016. First of all, there was this notification from DHR, which may be that all the foreign cases of surrogacy have to be stopped, and cases prior to issue of this letter may have been taken by the ART clinic. And in these cases, the authorities will decide it on a case-to-case basis. This led to massive panic whether the patients will be able to take their babies back home or not, because they said that it will be decided on case-to-case basis. So at that time, there were a lot of cases filed. There was cases filed by ISAR, by Instar, by ART Bank, by the IMA sought a clarification. 500 surrogate mothers representation was made to the court, and following all this, in November, then a notification also came out for embryos. So you see the point number 1 near the bottom of the letter, and point number 2, the surrogacy clinic, ART clinic, IVF clinic offering surrogacy service will not import human embryo for surrogacy services. And the point 1 is that the import of embryo is prohibited except for research purposes. So if any of you are wondering about import of embryos, this is the notification for you, which is currently in effect. And right now, there is, of course, a modification that we can write to ICMR and we can request on a case-to-case basis, but there is no clarity. I mean, the notification says that both import and export actually are banned. Then the surrogacy regulation bill came 2016, and this said we will establish a surrogacy board, and there will be state authorities, national authorities, appropriate authorities, and only Indian citizen, that means Indian passport holder and marriage for at least 5 years. And the age group was defined between 23 to 50 for female, 26 to 55 for male, and single child norm was imposed that we should not have any child except a physically or mentally handicapped child. And it will be completely altruistic, so no commercial element, no payment will be allowed. And not only that, but the surrogate mother has to be a close relative and has to be between the age of 25 to 35 and has to be do surrogacy only once and carry a child which is genetically related to the intending couple, means no concept of egg donation or sperm donation. And these certificates for the couple, essentiality, eligibility, I mean, many rules came, but the most strict rules were that the punishment, I mean, any even clerical error here is punished by imprisonment for a term which should not be less than 10 years and fine which may extend up to 10 lakh rupees. This is unheard of, these kind of punishments. Maintain the records for 25 years, etc. So following this harsh bill, a lot of us wrote representation. As a general secretary of Instar, we sent a representation, and this is the letter where I was invited to the Rajya Sabha Secretariat, and we gave a presentation. So what exactly is surrogacy? Why is it done? I mean, these are the various reasons why surrogacy is done in India. So we have multiple failed IVF, 4%, and thin or abnormal endometrium, absence of uterus, so many indications for surrogacy. We said these are the guidelines that we are stating, that the surrogate mother, to prevent exploitation, she has to be compensated, even if it's an ectopic pregnancy, hysterectomy, or any eventuality. There has to be a minimum standard of compensation. And after all this, now the select committee report was published, and the surrogacy regulation bill to 2020. So this is the actual bill, which is the latest which has come. And in this, it says that although it is altruistic surrogacy, but along with that, there are other prescribed expenses which are incurred on the surrogate mother, and the insurance is all given. So the current bill is allowing incurred expenses, although it is under the title of, it has now become a birth affidavit. Secondly, the insurance has been defined that insurance has to be for 36 months, for 3 years. The intended couple, now that clause of Indian citizen is gone. Not necessarily that they have an Indian passport. PIOs and NRIs can also do surrogacy once this is applicable. And not only that, single women are also going to be allowed to do surrogacy under this. And here that genetically related to the parent clause is also gone. So it says that the embryo is not genetically related to the surrogate mother. So you can use donor gametes. And a willing woman. So the clause of close relative is also gone. Here it says that any woman who is willing, provided that the intended couple and both the women have to approach the appropriate authority, and the appropriate authority will then give you the permission to do. Then we have the ART bill. So just summarizing, the intended couple age over the time, it has seen so many changes. Now, finally, close relative is replaced by willing woman. Intended couple is Indian origin. Single woman probably allowed. Embryo, donor gametes are allowed. Insurance cover is mandated for 36 months. The problem is that the clause of that very harsh punishment is persisting, and commercial surrogacy is banned, but some compensation is allowed under altruistic. And that clause of one child norm, that the parent should not have any biological child, that still exists. So surrogacy is legitimate, my friends, because no Indian law is prohibiting it. The Supreme Court judgment is the highest authority that we have to follow. And right now we are doing commercial, compensated, altruistic, all kinds of surrogacy. I do my best because I'm counting on you, counting on me. And some really positive news to end the presentation. There is a lot of positivity from our courts where surrogate mothers, the intended parents, women have been given leave for surrogacy. In fact, it is said that to distinguish between the surrogate mother and natural mother would result in an insult. And the Maharashtra High Court has even reversed a previous decision where the leave was not allowed. So many high courts have given maternity leave for surrogacy. And in fact, the central government has said that this order for paid maternity leave should be widely publicized. So this is a very positive step. So many private companies, Amazon, Google, Amazon sees no difference whether you're birthing mother or adoptive mother. Diego India and Microsoft India, so many companies have come forward to give leave for surrogacy. And this slide borrowed from Dr. Jitendra and Hitesh, but before doing any treatment, make sure all your forms are signed as per this chart. And एक बेटी भाग्य से होती है, एक बेटा भाग्य से होता है, पर बेटी तो सौभाग्य से होती है. And this is our initiative for Nukkad Nataks to make people aware what is surrogacy and how it is done and how it helps women with infertility. So thank you everybody for giving me this wonderful opportunity for being here. Thank you to the ACE team.
Dr. Shivani. That was a wonderful talk. And really, it was like an eye-opener for all the people who are attending it, that yes, we are still doing surrogacy. It is not banned as people think, and all the important conclusions that you gave were really important. We now introduce Dr.
Hello.
Rajesh. Yep.
Yeah.
Dr. Rajesh Sharma.
No, ma'am, this is the last talk of this session.
Dr. Rajesh Sharma is not coming?
No, ma'am.
Okay, okay, fine.
Not in program.
Okay.
Okay, so it was a wonderful session. Thanks, Gautam, for conducting it. And thanks, Dr. Geeta. It was a wonderful experience.
Hello. Really, it's a very wonderful talk. Particularly in surrogacy, there will be lots of questions, but it is not virtual, just recorded talk. So we cannot have this question on surrogacy. Anyway, it is nice, and I thank both of us, thank the organizer for giving us the opportunity to chair the session. And it is nice to meet Naina, though it is virtual. Naina, to meet you after a long time, though it is virtual. Thank you. Thank you all. Thank you. Hey, on the Hello.
Yes, ma'am, you are audible.
No, is it the last talk?
Yes, ma'am. Yes, ma'am.
Dr. Sharma is not coming. Mane,
No,
this
no,
talk
no,
is not recorded.
updated program, mass Dr. Sharma is not there in updated program.
So we stop here.
Yes, yes.
And
Next
there
is
will be no question and answer because it is only recorded talk, isn't
yes,
it?
yes, ma'am. Yes, ma'am. So
Because it will be
next
fine if it was not
okay.
recorded. There should be lots of question and answer.
Yes, I think so.
Yeah. Anyway, then thank you very much and stop it here. Okay?
Yes, ma'am. Yes, ma'am. Thank you. Ma'am, you are not audible. Please unmute yourself. Dr. Neha. Hello.
Yes, sir.
Yes, now you are audible.
Yes. Mine has not yet started, right?
Actually, session E3 will be start at 12:50.
Okay.
Yes.
So I'll just mute. Can somebody, whom I'm talking to?
I'm Atul. Atul this
Atul,
side.
can you give me a call whenever it starts? I'm logging, I've logged in, but
Okay.
I'm working right now.
Okay, I will give you the call. Your session, your talk is starting at 1:05, right?
Yes, 1-5. I will be
Okay.
there.
I will give you the call 10 minutes before.
Yeah, 10 minutes before. Thank
Okay.
you so
Thank
much.
you. Thank you.
Okay.
he can get paid, isn't it? That is the beauty of being a research fellow in UK or America, probably.
Live stream now.
Live stream, okay. Is Gautam going to introduce? Hello.
Hello. Hello. Good afternoon, everybody. I'm Gautam Roy,
yes,
the hall coordinator of this hall, and I'll be with you for this session afterwards. So our next session will be on fetal medicine. So may I introduce our chairperson, Dr. Sudeep Basu. Dr. Sudeep Basu is a visiting consultant of Amri Mukundapur and Fortis Hospital, Kolkata, past secretary of ISAR Bengal, Kolkata, executive committee member of IFS. So now may I request Sir Dr. Sudeep Basu to hand over the proceedings.
Sure.
Thank you. Thank you.
Good afternoon, everybody. Thanks for joining for this interesting session on fetal medicine, and I welcome you all to Kolkata City of Joy. It is a pity that we cannot meet together and have a good hilsa fish or misti doi, which the non-Bengali people always crave. But hopefully when the COVID pandemic is over, hopefully, if it is over, then I invite you personally to come to Calcutta and join us. But till then, I will enjoy this session on fetal medicine. The first speaker is very well known, reputed fetal medicine specialist, Dr. Kusagoti Ghosh. And he is going to speak on screening for aneuploidy in the first trimester. Professor Kusagoti Ghosh obviously has got almost all the degrees which is available in Obs and Gynae. He is the current professor of Obs and Gynae, Ramakrishna Mission Seva Pratishthan, VIMS. He is also director of Institute of Fetal Medicine, Alipur, Kolkata. And he has been a consultant at two different hospitals. He was the president of Society of Fetal Medicine, Calcutta chapter. Obviously, he is a clinical examiner for the graduations and postgraduate examinations, past president of Bengal Obs and Gynae Society, and past chair of the AICC Archaeology India Zone. Now, personally, I've been very thankful to God because Kushada never tried his hand in infertility. Whatever subject he does, he goes to the extreme and beat everybody. So when his endoscopic surgery, he trains people in endoscopic surgery. And now he's a fetal medicine. He is one of the leading fetal medicine consultant in Calcutta. And thank you, Kushada, not trying infertility. I'm sure if you do, we'll be all running out of job. Thank you very much. This is your session now. Please.
Thank you, Sudeep, for such accolades, which I'm sure I don't deserve. But anyway, thank you for the introduction, kind introduction. It's a mutual respect that we have for everybody, irrespective of whatever age or whatever our degrees are. The topic that I've been asked to talk on is screening for fetal aneuploidies in first trimester. When we talk of aneuploidies, we basically talk about Down syndrome because that is the commonest aneuploidy at live birth. Down syndrome is because of trisomy 21. Most of them are chubby, smiling, lovely babies, but the problem is they are mentally retarded, and therefore it's a challenge to bring them up. The confirmation of whether the fetus is having a Down syndrome or not can only be obtained by having a fetal sampling, either by amniocentesis or by chorionic villus sampling. Both are invasive, and so the question of screening came in so that we can select a high-risk population where we can do the confirmatory test. In 1970s, historically, screening was based on maternal age because it was found that after the age of 35 maternal age, the incidence of Down syndrome dramatically increases. And all patients above the age of 35 are offered amniocentesis at that point of time. But this method can only detect Down syndrome up to the extent of 30%, and 70% of Down syndromes were missed. Since age-related approach was not an efficient method, search was on for methods to screen all women, which led to the universal screening of the whole obstetric population. There was an immense and intense search regarding different biochemical and USG markers for Down syndrome that could be used in addition to maternal age. And what followed thereafter was a period of so-called discovery of various biochemical and ultrasound markers for Down syndrome. In ultrasound screening, for example, we tried to note about chorioplexus cyst, about echogenic bowel, etc. Serum screening about double test, triple test, etc. Combined screening where there is a mixture of ultrasound as well as biochemistry. And very lately, we now have the genetic screening. Now, when we come to biochemical protocols for fetal aneuploidy screening, we have a plethora of names: integrated test, serum integrated test, combined test, quadruple test, triple test, double test, sequential test, screening, whatever. The list is long. And debates followed, and everyone claimed that their new markers were superior than the others. And so there was a trial which was conducted, which is called the Surus trial in 1999. It was conducted by NICE in UK, and it sort of compared one against the other against a benchmark of 5% amniocentesis rate. And there are two things which came out from this Surus trial. One thing is how screening should not be done, and secondly is how screening should be done. Now, what are the screenings that we should be avoiding? Age alone as a screening method, where the sensitivity is only 30%. LMP-based only screening protocol, because LMP is inaccurate in around 15% of cases. Doing triple test, doing NT alone, doing double marker alone are not recommended because the sensitivity is low. Integrated screen is good, but it is cumbersome. And sequential screen, where we do two screens at two different points, there is a huge dropout rate. So these are the screenings which should not be done. The current recommendation according to Surus about what should be done are two types of screening tests. One is a combined test, which is also called FTS, which is done between 11 and 14 weeks. And the other one is a quadruple test for people who miss that deadline. Whatever method we use, accurate estimation of gestational age is extremely important, because all the software calculations are based on gestation-specific MOM value, which is multiple or median value, rather than on absolute value of PAPE or beta HCG nanogram per DL. First trimester screening, or FTS as it is called, or a combined screening, same thing, is done between 11 and 14 weeks, i.e. the CRL would be between 45 millimeter and 84 millimeter. So there is a 3 weeks window. After CRL, ground rump length, what we do is a nuchal translucency measurement, which is done as per the FMF criteria, Fetal Medicine Foundation criteria. An ultrasound scan is extremely important before we do any sort of screening. More important than diagnosing Down syndrome is the viability of the pregnancy, dating the pregnancy, multiple pregnancy, and chorionicity, and obviously 10 to 12 major anomalies which can be diagnosed in early trimester scan. This goes beyond Down syndrome screening. In the first trimester screening, we do the CRL, the nuchal translucency value, and then we measure PAP-A and free beta HCG value. The other parameters apart from that, which also are considered in the screening and increases sensitivity, if we include the maternal age, the maternal weight, history of Down syndrome in the past, exogenous HCG injections, twin, if it is there, the chorionicity, and history of bleeding PV and diabetes. So practically what is done is an ultrasound is done after counseling. The CRL and the NT are measured. Blood is drawn in gel tubes or recently in dry bead spots, or called DBS, on DBS paper. The requisition form is filled up with all the clinical parameters which I mentioned just now, that is the date of birth, weight, etc. And then the report comes in after 2 or 3 days now, but sometimes maybe in Calcutta it comes in the next day. So the patient population is divided into two groups after the screening: high risk and low risk, at a cutoff value of 1 in 250. If it is high risk, then normally recommendation is to go for amniocentesis or CVS. If it is low risk, the pregnancy is continued after counseling. Now, you have to remember that there is uncertainty about the screening with the report, because low risk is not zero risk. So there could be Down syndrome, though very rare, in the low risk population as well. And also corollary, that in high risk patient, it does not mean that the baby is Down syndrome, and therefore we should never terminate the pregnancy only based on the screening report. Now, as human beings we try to push the boundaries even further, and to increase the sensitivity of the pickup rate of Down syndrome, and to reduce the false positive, which is to reduce the amnio rate. People started adding more biochemical annihilates. So we came with the first trimester quad test, where AFP is added along with 3-beta HCG, PLGF, and PAPA, and the penta screening came up where inhibin was added to that. But studies have shown that the incremental increase in the pickup rate does not justify the cost involved, and therefore we are still sticking to, in India, to the age-old fetal first trimester screening test for Down syndrome, which we mentioned before, with a cutoff of 1 in 250. Now, then a new group came up in about 5-6 years ago, which was called the intermediate risk, and that threw us all into utter confusion. What they have done is they have reclassified the low risk population, people who had lower than 1 in 250 risk, into two categories. One is a low risk, and the other one is an intermediate risk between 1 in 250 and 1 in 1000. And that constituted about 25% of the population. Now, once this came up, there was a huge controversy regarding whether she should be done or not. The proponents of the intermediate group risk, they say that there can be a possibility of Down syndrome in the intermediate group, however small it may be, and we should not miss them. But the problem that arose was what to do with this intermediate risk group. Should we do further triaging with further ultrasound to look for nasal bone, tricuspid regurgitation, ductus venosus, A-wave, etc.? Or should we offer them CVS or amniocentesis? Or should we take an easy way out and offer an NIPS? And there are still others who say that let us stick to the old 250 above and below, consider them as low risk, do an anomaly scan, fetal echo, and carry on from there. People who are against the intermediate risk group say that there are no standard cutoff values or guidelines. Different papers say different things, 1 in 100, 1 in 500, 1 in 1000. That causes anxiety in the patient when the population is about 25%, which is very high. It takes a lot of counseling time of healthcare professionals, doctors, etc. And the cost effectiveness, that is the incremental cost of diagnosing one very rare Down syndrome in that intermediate group, is not justified. And some people even have gone a bit further to say this is a backdoor indication for NIPS for commercial interests. And if people are really worried about Down syndrome, why not do an universal NIPS, which has a sensitivity of 99%, rather than going for FTS? But whatever said and done, none of the national guidelines in any country, UK, USA, Australia, New Zealand, or European countries, have recommended intermediate risk in the national aneuploidy screening program. So question is, should we be reporting such an intermediate risk category in aneuploidy screening at all? The consensus is not there, but the literature says it is better avoided. Now let us come to the last few slides about the genetic screening. So far about biochemical screening we spoke, now genetic screening. This is a highly effective screening method, which is called Down syndrome, which is called NIPS, but it is not diagnostic. Compared to FTS and quadruple test, NIPS has a very high sensitivity and very low false positive. So the amnio rate is low. This was first reported by Lowe et al. In 1997, the presence of cell-free DNA in maternal plasma. The cell-free DNA comes from syncytial trophoblast of the placenta and is a reservoir, the maternal plasma reservoir of this fetal cell-free DNA. The possible sources of error of NIPS are early gestational age, where the sensitivity of trophoblast fraction is low, maternal obesity, multiple pregnancy, discordant for trisomy 21, where one fetus may be trisomy 21, the other is normal. There is a confusion. Confined placental mosaicism, maternal copy number variations, and donor egg IVF, where there are 3 cell lines. The international policy statements and guidelines are there starting from 2012, 2020. And the current position based on those guidelines are that NIPS is a screening test. It is better called NIPS rather than NIPT. It can be done at any point after 10 weeks of gestation. It is costlier than FTS. And so NIPS cannot be for universal screening in a country like India. There is a possibility of low fetal fraction, approximately 3%. And this is a problem because we may have to repeat the sample where the low fetal fraction can again resurface. In women who can afford, one may do NIPS instead of FTS after counseling because this is the best counseling screening method. But it is not a good idea to do NIPS in already patients who are biochemically positive, screen positive for FTS, for Down syndrome. It is like doing a second screening test in an already screen positive population. So the take-home messages, ladies and gentlemen, are that counseling before screening is a must because there are a lot of nuances before and after counseling and decision-taking process. We must do an 11 to 14 weeks ultrasound scan because there are a lot many benefits of scan apart from screening only for Down syndrome. We should never do any screening without an ultrasound scan. The age-old first trimester screening, whereby we measure the CRL, the NT, exclude anomalies, and take blood for PAPI and free beta HCG and combine with age to find a cutoff value of 1 in 250. Any risk more than 1 in 250 is considered as high risk, and anything less than that would be considered as low risk. It is better to avoid the intermediate risk category. We normally do amniocentesis in high risk group, and we avoid NIPS in screen positive population. But yes, we may do NIPS instead of FTS as a primary screening in affordable people. And we should never, ever forget the 11 to 14 week scan and counseling at every step of screening for fetal aneuploidy. Ladies and gentlemen, in our understanding about screening for fetal aneuploidies, we have come a long way, but we still have a way to go. Thank you.
Thank you, Kusada. The first talk is wonderfully done. And just one question from me. Just a minute, I just start the video. When I first came back in 2007, at that time, we used to do the first trimester screening because obviously that's the way we have been trained in UK. In last 12 to 13 years, 14 years, there is an upward trend and lots of people in the cities are doing it. But still, I find it very difficult to convince the consultant in the district to do this basic test. This is not because it is not available. I don't think this is because the patient just cannot afford, but also the lack of awareness from the consultant side, who probably just too busy to see the patient and deliver the patients at the time. Now, as a fetal medicine consultant, have you thought about increasing this awareness and convincing more and more consultants in the district to ask for this basic test?
Yes, of course. I mean, these are very pertinent questions, Sudeep, that you have raised, because yes, awareness as such is very low. In fact, the screening penetration would be maximum 1 to 2% of the obstetric population, and it is mainly concentrated in the cities. The problem is the Down syndrome risk is 1 in 700 or 1 in 600. And for an individual consultant who is doing a private practice to get a Down syndrome screening, sometimes they may be practicing for years together without actually having delivered a Down syndrome. So that's why the awareness is not there, probably. But people who have seen in the rural setup also, once they have delivered a Down syndrome baby and they have gone into a soup, then they always advise. So what I normally tell, but yes, we have done lots of seminars and symposiums and etc., especially in the rural areas. So what I normally suggest to all doctors is that whether the patient gets it done or not, it is up to them, but it is the onus for us, on us, that to advise. So always I say that always in the prescription, we must write thalassemia screening and we must write Down syndrome screening in one form or the other, either FTS, or if the NT facility is not there, we can actually postpone it slightly to quadruple test between 16 and 20 weeks. But at least we should be writing something and referring. Otherwise, by chance, if something happens, then they would say, I was not told. So if we say like this, I think the awareness will increase, and the awareness has increased.
Right. Thank you very much. Thank you again for sharing your time and the lecture with us. So we move on to the second lecture, if possible. Can you go to yes. So our second speaker is Dr. Neha Gupta, who is a fetal medicine consultant as well as obstetrician. She has worked in the Kailas Hospital, Noida, December 2017 to present. She has got his diploma in fetal medicine from fetal medicine department in Barcelona 2021. And she was a consultant fetal medicine department, KP Hospital, Noida. And she has done her fellowship in fetal medicine in 2014. And also she is attending consulting in Medanta Gurgaon. She has done her PGCP senior residency from PGI in Chandigarh, and Kushada also Chandigarh PGI product. So I can see the trend is there. And she has done her post-graduations from IGMC Simla. Thank you very much, Neha. Can you kindly start the lecture, please?
Yes, I'll just share my screen. So very good afternoon, everyone. I'm Dr. Neha Gupta. I'm consultant fetal medicine in Noida. And I will be talking on these new ultrasound soft markers in the first trimester. And I thank the organizers for giving me this opportunity. And my work has already been much simplified by Ghosh sir. So as I begin, trisomy 21. So the outline, I will be considering these following topics: introduction, what is the statistics, what constitutes an effective screening test, what are these additional markers, what are the advantage of these additional markers, and ultimately the take-home message. Now, sadly enough, the first reference of Down syndrome was in this paper, that is ethnic observations on an ethnic classification of idiots by John Langdon Down in 1866. And he used the term Mongoloids and Mongolism. And this term was dropped in 1965. And in 1975, NIH USA recommended the term Down syndrome. The statistics are still alarming in India. Out of 800 children that are born, one is that of Down syndrome, and the survival rate is really low, about 44%. And we have a really good screening methods. Still, we do not have any national kind of a program, and I agree that the awareness is not really that much. So what constitutes an effective screening? Initially, it was based on maternal age, where we used to offer invasive testing to all the women who were 35 years, more than 35 years of age. The downfall was that the detection rate was only 30% when you use this approach. And we already know that no age is immune. It's 1 in 1,000 at the age of 25, while it is 1 in 250 at the age of 35. And similarly, triple screening is no longer recommended, and quadruple screening test, which has an accuracy of only 70%, is not really that good enough. So the combined first trimester screening is an effective strategy, and this is what we are following. And that combined screening, at the minimum, what we need to do is based on maternal age, nuchal translucency, free beta HCG, and PAPE. That's the dual marker. The screening, the detection rate for this is about 85 to 95%, with a false positive rate of 5%. Now, the most important aspect that we have to take from this is that when we add these additional markers, our detection rate really jumps. months. It takes to 93 to 96%. And most important aspect is that the false positive rate really goes down to 2.5%. So let's talk about these additional markers. The first one is the nasal bone. We all know that the screening is done between 11 to 13 plus 6 weeks when the CRL is between 45 to 84 millimeters. Now, when we have to see the nasal bone, you need to have a mid-sagittal view. The neck should neither be too flexed nor too extended. The magnification should be appropriate such that it should occupy the head, and the upper 1/3 of the thorax should occupy almost whole of the screen. Now, to see the nasal bone, there are 3 lines that you actually need to see. So if you see here, this is the echogenic tip of the nose. The overlying is the skin of the nose, and this is the nasal bone. So when you have to see a nasal bone, this equal to sign needs to be seen. And this image in itself is very much informative, where you can see the palate, the 2 lines of the palate, the thalami and the midbrain, the ICT, the future cisterna magna, and this is the nuchal translucency. So nasal bone is considered present when you see this echogenic line and you see this equal to sign. It is considered as absent when you don't see any equal to sign, or the line below the skin is not as bright as it should be, or more brighter than the overlying skin. And a very important aspect that has to be taken care while seeing the nasal bone, that the neck should not be really too much, because slight tilt of the neck more than 10 degrees or 15 degrees would bring zygoma in appearance, and you will not be clearly able to see the nasal bone. So whenever you see an absent nasal bone, it can be seen in euploid pregnancies about 1 to 3%, and in 60% of trisomy 21 fetuses. Absent nasal bone is more common when the scan is usually done around 11 weeks than at 13 weeks. Sometimes when we see an absent nasal bone at about 11 weeks, we do call the patient again after 1 week, because sometimes they get ossified. In 1 to 3% of the cases, ossified a little later. And when it is associated, the incidence is more common when it is associated with an increased MT. The other marker that we have is ductus venosus. It's a very small vessel that connects the umbilical vein to inferior vena cava. So this is the placenta. This is the umbilical vein as it enters from the abdomen into the liver. It turns towards the right side to form the portal vein. And it is connected by this small vessel that is ductus venosus with the inferior vena cava. Now, the ductus venosus helps in preferential shunting of oxygenated blood to the fetal brain. And 20% of the oxygenated blood bypasses the liver. So whenever when we see the ductus venosus, as said, that these are seen between, these markers are done between 45 to 84 millimeters of the CRL. The thorax need to be magnified. So the magnification really needs to be appropriate. So this region, the thoracic region, should be magnified so that it covers almost whole of the screen. And when you switch on the color Doppler, the umbilical vein, the heart, the IPC should be clearly visible. Then the next step is that we switch on the pulse Doppler, and the gate. The size of the gate should be less than 1 millimeters, and it is placed in this region of aliasing. And the insunation of angle, this is the line, and this is the gate. This is the angle of insunation, should be less than 30 degrees. Filter set is at a low frequency, and the speed is to be adjusted as such so that I can see 5 to 6 waveforms. So whenever you see a ductus wave, so the normal pattern is like this, and when the A wave is reversed, this is an abnormal pattern, reversed A wave. So the ductus venosus waveform has 3 parts. The first part, the first up, is this S wave, which corresponds to the ventricular systole, the D wave, which corresponds to the diastole, and the A wave, that is the atrial systole. So whenever we are seeing the ductus venosus, this A wave should be above the baseline, and when it is reversed, it is considered as abnormal. The other thing that you have to take care is that it's a very small area where you're placing where here you have the IVC, you have the hepatic veins. If it is not placed on the DV, you can have contamination from different vessels. Like in this one, this is contamination from the umbilical vein where you can see this ductus venosus, but this line here is basically contamination from the umbilical vein. So you have to keep the gate less than 1 millimeters. The other over here, this is a very frequent pattern because very close enough over here is the hepatic vein. So what I am seeing here is not the reversed A way. Basically what I'm seeing here is contamination from the hepatic vein. So whenever you see an abnormal ductus venosus between 11 to 13 weeks, it can be seen in 3% of the euploid fetuses and about 65% of the trisomy 21 fetuses and 55% of T18 or T13 fetuses. What more important thing we have to consider is that whenever you see an abnormal ductus, it is not just aneuploidies, but these are a marker for cardiac defects as well as sudden fetal demise. So whenever you see an abnormal ductus, you have to do a evaluation of the fetal heart as well. The third marker that I would discuss is the tricuspid regurgitation. Now, in this case, same CRL, it is done when the CRL is between 845 to 84 millimeters. Take care that the fetus is not really moving. The focus is on the apical four-chamber view of the heart, and it should be really magnified so that it covers almost 2/3 of the screen. The color flow mapping should not be used. The gate, the size of the gate should be about 3 millimeters, and the angle of insonation, and it is kept over the tricuspid valve, and the size of the gate should be 3 millimeters, and the angle of insonation should be less than 30 degrees. The waveform, the speed is so adjusted that you are able to see at least 5 to 6 waveforms. And here you measure the heart rate and you see whether there is a regurgitation or not. And you should assess the tricuspid valve at least 3 times. So when you place, this is a normal pattern, the above one. Now, when I see the flow over here, this is the tricuspid regurgitation, and the flow is more than 60 centimeters per second. So this is what the tricuspid regurgitation is. If you see over here, this is not a tricuspid regurgitation, because here, this is actually the reflection from the flow through the aortic valve. And the most important thing is that here, the speed is less than 60 centimeters per second. And this is also not regurgitation. This is basically the click of the valve that we are seeing. So whenever we see an abnormal regurgitation, usually it is seen at earlier gestations around 11 weeks, because it is said that the 3 cusps of the tricuspid valve, they don't coapt really together, and it's almost a leaky valve. And if you see it later, maybe after 13 weeks or when we do an early anomaly scan, it spontaneously disappears, or when you have an increased NT. So it is also a marker for chromosomal abnormalities, but more importantly, a marker for a cardiac structural abnormalities in the heart. So whenever you see a tricuspid regurgitation, do examine the heart for these major defects. One of the most important aspects or the benefits of the addition of these markers is that the most important thing, that the detection rate is improved and the false positive rate is halved. The second most important aspect is that whenever we do a screening, though the SIR said that the intermediate risk should not be used, but we are still using intermediate risks because 13% of the people with intermediate risk can have Down syndrome. So there are 3 categories: high risk, intermediate risk, and the low risk. Now, whenever we do a screening, which is based on maternal age, nuchal translucency and dual marker, if it is low risk, that is less than 1 in 1,000, where majority of the population will be, we consider it as a low risk and we refer the patient to call at around 20 weeks for the level 2 scan. And if it is a high risk, you offer, we keep a cutoff of more than 1 in 250, you offer an invasive testing. But in patients where we see that the quality of the scan is really not that good, and here the extended genetic sonogram involving all these additional markers is recommended to the patient. Similarly, in the intermediate category, which the risks are based only on the NT and the dual marker, we do recommend doing an extended genetic sonogram, and then we assess the risks on this. If the risks are low, We follow them up at 20 weeks for level 2. If the risks are high, when we do an extended genital sonogram, we do an invasive testing and an intermediate category. And when we see in the baby, it's looking fine, we do offer NIPT to these patients. So my take home message is that combined first trimester screening is must. At the minimum, we should involve maternal age, nuchal translucency, and dual marker. Additional markers improves the detection rate. So if you have the expertise, you should do these markers. And the most importantly, there is a reduction in the false positive rate to about 2.5%. And these additional markers, they are actually helpful and can be used in contingent screening. And whenever you see an abnormal TR or an abnormal ductus, do look at the heart and perform an early fetal cardiogram, because these increases the risk of congenital cardiac defect. So thank you. Stop share.
Okay, thank you. It is wonderful to listen to your simplifications, how we should pick up these additional soft markers. Can I ask you one question?
Yes, sir.
Nowadays, do we look at the stomach and double bubble sign or?
Sorry?
Nowadays, do we look into the stomach for the double bubble sign, or the golf ball echogenicity in the heart is not called golf ball nowadays, isn't it? But do we look up into the heart and find out are any echogenic spots there or not?
Echogenic foci you're talking about?
Yes, yeah.
Sir, in the first trimester screening, echogenic foci is not considered in the risk calculation. But if we see it, suppose I'm doing an NT scan at around 12, it. And so that, but it's not, if the screening is all low risk and the heart is looking all fine to me, I just counsel the patients that there is an additional marker present. But my counseling and screening will be based on these markers only, that is NT, nasal bone, TR, and DV and heart rate. So I don't include that in my risk assessment, but I do make a note that yes, in the first trimester screening, an echogenic foci is present.
That's great. Kushada, I don't ask any question.
No, it's okay. What she has done is absolutely okay.
Okay.
Very well said.
That's great. Thank you very much. Thank you. Can we move on to the next speaker, please? Shumana Hawk. Dr. Shumana Hawk. Okay. Dr. Shumana Hawk is a consultant in fetal medicine in Apollo Hospital, Indira IVF, Miracle Clinic, Kolkata Global IVF, and Asmika IVF. She is also got her fetal medicine certificate from UK, and she has got the certificate of competence, NT specialist, and certificate of competence 18 to 23 weeks scan. So the stage is yours, Shumana.
Hello, I am Dr. Shumona Haq, consultant fetal medicine practicing in Kolkata, and today I'm going to talk about fetal reduction in monochorionic pregnancy. So selective reduction in monochorionic pregnancy can be carried out by occlusion of the umbilical cord vessel through endoscopic laser, through ultrasound-guided bipolar forceps, or radiofrequency ablation. Injection of KCL can be used in higher order pregnancy with monochorionics, but in this case, the whole monochorionic unit will be demised. So I will discuss about 2 cases with monochorionic pregnancy who came for reduction to us. So case 1, here is a 35-year-old married woman. For 13 years, she is married with first degree subfertility, and she opted for IVF pregnancy with donor egg. 2 blastocysts were transferred. Monochorionic diamniotic gestation was diagnosed during the first trimester screening at 12 weeks. A discordance in CRL and sac size were noted during this time. The first trimester screening was negative for aneuploidy, but due to the discordance in CRL, patient was reviewed again at 14 weeks. At 14 weeks, there was significant risk discordance in the estimated fetal weight, which was about 32%, a slight increase in the Likert volume, in the bigger twin was noticed, and a decrease in liquor volume in the smaller twin was noted. The fetal bladder of both the twins were visualized. When she was reviewed at 16 weeks, there was plan for interstitial laser procedure if required. So the growth discordance this time was about 43%. Frank increase in the liquor volume was noted in the normal twin, with decrease in the liquor volume in the smaller twin. The fetal bladder was visible. Umbilical artery Doppler of the smaller twin showed absent end diastolic flow and selective intrauterine growth restriction with twin-to-twin transfusion syndrome was diagnosed. So here, if you see, these are the two sacs. We see in the smaller sac, the liquor volume is decreased, and in the bigger sac, the liquor volume is increased. The bladder of the smaller twin was not visualized. These are the paravesical vessels, and in the bigger twin, the bladder was nicely visualized. Umbilical artery Doppler showed absent end diastolic flow in the smaller twin, whereas it was present in the bigger twin. So when both the fetuses were compared, by biometry, the smaller twin was about 13 weeks, 5 days. This was about 16 weeks of gestation. And the estimated fetal weight was also very less compared to the bigger twin. It was about 87 grams, whereas the bigger twin measured about 152 grams. The discordance was 43%. So fetal reduction was done using interstitial laser. Under aseptic condition, 2% lignocaine was used for local anesthesia. Under constant ultrasound guidance, 18-gauge long spinal needle was introduced into the abdomen of the smaller twin, and paravesical vessels were aimed. 600 micron laser wire was introduced through the spinal needle after removal of the stellate. 25-watt diode laser was used for ablation of the paravesical vessels. Asystole was noted in the target twin. The co-twin was active after the procedure, and a heart rate of 152 beats per minute was noted. Special thanks to Dr. renowned fetal medicine consultant from Apollo, Delhi, who mentored the first intrafetal laser procedure in Kolkata at the fetal medicine department at Apollo Hospital. So this is the video of the twins after the reduction. So here we see the smaller twin almost shifted to one corner of the uterus with decreased liquor. The abdomen of the smaller twin is echogenic due to the laser procedure which has just taken place. There is no cardiac activity and the twin is inactive. Then we see the bigger twin, which is very active and moving constantly. And here we see that the cardiac activity is visible in the bigger twin. So why reduction of one of the twin was necessary? Why not leave it as it was? In monochorionic twins, death of one twin is associated with acute hemorrhage from the co-twin into the feto-placental unit of the dead twin. As a result, there is 15% risk of death of the co-twin, and 25% of the survivors have severe neurological injuries. This was a precious IVF pregnancy and required intervention in order to give the best chance to the healthy fetus. Now we come to the case 2. 29-year-old woman married for 10 years, had first degree subfertility, and she opted for IVF after repeated failure of the medical treatment and IUI. 2 blastocysts were transferred. An early scan at 6 weeks done elsewhere showed twin gestation. She came to us at 12 weeks for the first trimester screening. So there was a surprise. 4 heartbeats were visualized, indicating 4 live fetuses. A close introspection showed 4 amniotic sac and 2 placentas. Dichorionic quadra-amniotic fetuses with monochorionic triplets were diagnosed. So then we counseled the couple. The couple was counseled regarding the complications which may arise, in this case, both due to the higher order pregnancy and due to monochorionics. The higher order pregnancy is associated with maternal complications such as preeclampsia, GDM, anemia, antepartum hemorrhage, postpartum hemorrhage, and fetal complications such as birth defects, early miscarriage, preterm birth, and IUFD. Again, monochorionic gestation is associated with selective IUGR, twin-to-twin transfusion syndrome, as these two were discussed in the earlier case, twin anemia polycythemia syndrome, and early fetal demise causing death or neurological injury of the co-twin. So after much consideration, the couple opted for fetal reduction, precisely the reduction of the monochorionic triplets, that is reduction of quadruplets into a singleton pregnancy. So under constant ultrasound guidance, intracardiac injection of 1 ml 10% KCl was given to one of the monochorionic triplets, which was most approachable. After some time, asystole was observed in the target fetus, and after some time, bradycardia was noted in one of the other monochorionics. The patient was reviewed the next day. The next day, asystole was noted in all 3 monochorionic triplets. The single fetus with separate placenta was active and had a regular heartbeat of 152 beats per minute. So this is the video before the reduction. So here we see a fetus in a separate sac with posterior placenta, as you see over here. This is in a separate sac. And this is a monochorionic unit with the anterior placenta. Here we see 3 fetuses separated by very thin interfetal membrane. But this is under the same placenta. And this is a monochorionic unit. After reduction, I have put color over here. And this is the monochorionic unit as I had showed earlier. This is the anterior placenta. Here we see 2 fetuses and both of them are not taking color. Both of them are not active. This is the 3rd monochorionic fetus in a separate plane. There is no cardiac activity visualized in both these fetuses. As you can see, for a long time, we are just making it, we are just clarifying whether the demise of the fetuses has taken place. And this is the 3rd fetus. So no cardiac activity over here, and it is not taking any color. Then we go to the fetus in the separate, under the separate placenta. This is the fetus with the posterior placenta. There's blood flow through the umbilical cord. Here you can see. And here's the heartbeat. So it is taking up the color and it is active. So this quadruplet was reduced to singleton pregnancy after the couple opted for reduction of the monochorionic triplets. So to sum it up, monochorionic gestation should be seen by experts who are experienced to handle the complications and the outcomes of such pregnancies. It is essential for women with monochorionic pregnancy to go for frequent ultrasound follow-ups, preferably every 2 weeks till term. Fetal reduction in case of complicated monochorionic pregnancy or higher order pregnancy with monochorionic unit may improve the pregnancy outcome. Thank you very much. Thank you, ACE, for giving me the opportunity.
That is a wonderful, Shona, a job well done. And obviously, this type of facilities are now available in Calcutta, and we're very proud of you. One question that when you use the laser catheter for this laser, is it the same type of laser which the urologist use, or is a different kind of laser? Can you hear me? Shona? Hello? Shona?
Sir, she is not here. It was a recorded
Oh,
session.
okay, okay. Is she here or not? Hello?
No, sir. No, sir. No, sir.
So we move on to the next one, please. So can we introduce the last speaker? So it is my privilege to introduce Dr. Ritu Khanna, who is the director of Khanna Medical Center Fertility Clinic, and she is a fertility specialist and endoscopic surgeon. And she had a training in various centers of India and also in Belgium. She has got so many credentials in her name, it will be very difficult to go through the credentials within a short span of time. So we invite her for the next lecture. And Ritu, the stage is yours.
Good afternoon, everyone. And thank you to the organizers, Dr. Ratna Chattopadhyay and Dr. Gautam Kastabi, for giving me this opportunity to be here. So on to iatrogenic twin pregnancies. 1 in 8 couples experience difficulty in conceiving. And so there's an increasing demand of IVF. And due to the maternal age, the genetic relatedness, the gestational carrier risks, and also the lifestyle and genetic abnormalities. And during the last 25 years, the development of infertility treatment has been remarkable. And until now, more than 1 billion babies are born as a result of assisted reproductive techniques. Twins after ART, undesirable complication of ovulation induction or ovulation enhancement. But why is it so much of concern to us? Because more than 90% of the triplets are affected by at least one obstetric or perinatal complication, most common of which is the preterm birth, and quadruplets have the risk of this prematurity to almost as much as 100%. So 2 common complications could be the preterm and the IOGR, and therefore a high risk for a lot of perinatal and morbidity and mortality. They also have higher incidences of respiratory distress and also the associated risk of a preterm like cerebral palsy, retinopathy, bronchopulmonary dysplasia, and those of the fetal growth restriction of polycythemia, hyperglycemia, and necrotizing enterocolitis. But the story doesn't end here. There's an increased risk of cerebral palsy also 8 times greater in the twins and 47 times greater in the triplet pregnancy than in the singletons. Maternal consequences are also towards a high morbidity. And there are associated complications like the hypertensive disorders, could be anemia, could be gestational diabetes, and premature contractions, labors, and so on. The physical, the emotional, and the financial stress increases the incidence of depression and the anxiety disorders among mothers who are rearing the twins and high order multiples. And also the incidence of the behavioral problems is increased in children with multiple births compared with the children from the singleton motherhoods. So is the natural pregnancy, multiple gestation, something different from the IVF? These groups are of a significantly older age, and therefore the gestational hypertension and gestational diabetes is much more significant. Therefore, this requires special attention. Also, the cesarean rupture of membranes is 9.8%, and the premature rupture of membranes is as high as 9.8% in this group. Therefore, the outcome of ART twin pregnancy is worse than that of the ART singletons, which further emphasizes the importance of the attempts to minimize the risk for iatrogenic-induced multiple pregnancies. But what could be the factors which contribute to increased risk of this multiple gestation? It's an increased urgency which leads the couples to pursue this aggressive treatment involving the use of exogenous gonadotrophins or to accept the risk associated with the transfer of greater number of embryos. Also, the inadequacy or absence of health insurance coverage for IVF may encourage some to pursue it at a less costly alternative. Another strategy when the health insurance coverage is inadequate to increase the number of embryos transfer in one or few IVF cycles. So therefore, finally, there is a lot of competitive pressure which drives the clinicians to do the IVF in earlier treatment to produce and maintain high pregnancy rates for the clinical advertising purposes. But what could be yet associated? It could be the ovarian stimulation, which is used for IUI, which could increase large number of follicles, and also the simultaneous fertilization of the several eggs. Not only this, but the number of embryos transferred is the most important correlating with the multiple birth rate. When the embryo criteria was used in selection of the embryos for transfer, the ongoing pregnancy rate was 63% and twin rate 57, with 2 top quality, but it went down to 58 and 21% with 1 top quality embryo. So avoidance of the twin births might be achieved by transferring 1 top quality embryo at a time. But also, if you go into the studies report that majority of the patient desire or at least may accept the twin pregnancy as the most favorable outcome. Also, when there are no cryopreservation facilities available, they tend to transfer the more number of embryos. So what could be the rational strategies to reduce the impact of iatrogenic multiple pregnancies? It could be reducing the number of multiple pregnancies by the ovulation induction, stimulation strategies, which could be thought of, and also the ART transferring of no more than 1 embryo, therefore reducing multiple births and optimizing the perinatal care. So regulating the prescriptions of ovulation drugs in the hope that the better stimulation could be controlled by trained experts could decrease the incidence of iatrogenic multiple pregnancies. So always do a proper baseline scan, look at the reserves, see the responses that you're going to get by the intra-ovarian flow, look at the AMH also, and accordingly just plan which protocol do you want to go in for stimulation. But yes, use milder stimulation protocols. The low-dose gonadotropin stimulation is one strategy to manage the serious condition. Also, when we are into the controlled ovarian stimulation, with or without IVI, still we could follow some strategies, and they are avoiding the insemination when more than 2 or 3 ripe follicles are expected to ovulate on planning an IUI, or converting this ovulation induction cycle to an ART cycle, and of course give all options to the patient and not to use ovulation induction at all, or prefer infertile couples to more complex, risky and costly ART treatments. So because the number of transferred embryos is entirely in the hands of attending physician, need for a shift from multiple to single embryo is very, very important. So elective single embryo transfer would result in an acceptable ongoing pregnancy rate with at least 1 top quality embryos. We have various scoring systems through the pre-implantation development, which are important in identifying the most viable embryo, the pronuclear morphology, embryo development rate, and also we could always select the single embryo best transfer which needs to be done. But the question is whether such an embryo could be identified as early as the zygote stage, or whether the further development to early cleavage stages or to the blastocyst is necessary and improve the selection rate. Compared to the results of ART with own gametes, the pregnancy and delivery rates with the ovum donation are high. However, an increased risk for obstetric complications like preeclampsia could be there, which is why it's indicated avoid twins in this particular group of patients. So do a very, very good counseling to both the partners, and also stress upon the role of cryopreservation, the risk of twin pregnancy, and explaining the good results obtained with a single embryo transfer combined with frozen thaw embryo transfer cycles, which easily convince most couples to accept this novel strategy. So single elective embryo transfer is advocated, and all the countries, they have their own guidelines. Sweden says yes, single embryo transfer. In Belgium also, the single embryo transfer, except when the patient age and previous ART experiences clearly justify the transfer of more than 1 embryos. So by transfer of a blastocyst rather than a single cleavage embryo, in certain programs, it could be, yes, very, very beneficial. WHO has recommended, in addition to the successful delivery rate, the objective of ART will be reduction in the multiple delivery rate to below 10%. So in this era of the epidemic of the iatrogenic multiple pregnancies, single embryo transfer is an effective method to reduce the twin rate after ART. There are so many RCTs which included in review, and 13 compared with the cleavage stage transfers and 2 compared blastocyst transfer. One study also compared both. In a single fresh IVF cycle, single embryo transfer is associated with a lower live birth rate than the double embryo transfer. Although this strategy yields a lower pregnancy rate than a double embryo transfer in a fresh, this difference is almost completely overcome by an additional frozen single embryo transfer cycle. Now, embryo transfer practice in United States, yes, achieved by a single blastocyst transfer less than 35 years of age. There are ASRM guidelines which say if the patient is less than 35, embryo transfer and no more than 2 embryos. If the patient is 35 to 37, 2 cleavage stage embryos, and no more than 3 cleavage stage embryos, no more than 2 blastocysts. If it's 38 to 40, then 3 cleavage stage or 2 blastocysts, no more than 4 cleavage or 3 blastocysts. And if it's 41 to 42, no more than 5 cleavage stage or 3 blastocysts should be transferred. So when the donor is less than 35, single embryo transfer should be strongly considered. And in frozen embryo transfer cycles, the number of good quality thaw embryos transferred should not exceed the recommended limit or the number of fresh embryos. But yes, beyond transfer of ASRM transfer guidelines, there are cleavage stage embryos which are safer to transfer in more than 43 years old by transfer of 5 to 8 cleavage stage embryos were also identified. But the story is not ending here, because the outcomes is related to the zygosity and the chorionicity, and the most common explanation for the increased zygotic splitting is the iatrogenic conceptions. It's exposure of the dona pellucida to the biochemical or the mechanical trauma, which leads to herniation of the blastocyst and thus splitting the zygote. Now, if it could occur between the 2 days, split could occur in 3 to 8 days, 9 to 12, or more than 12 days. It could result in a dichorionic, diamniotic, monochorionic, diamniotic, monochorionic, monoamniotic, or a conjoined twins. So what is an option there now? It's a selective fetal reduction. So with multiple pregnancies involving 4 or more fetuses, multifetal pregnancy reduction could reduce the perinatal mortality and the morbidity. Previously, the reduction of the triplets to twins was considered a social rather than a medical issue. It is very important now that the couple should receive all information on the expected outcome before making any decisions, and all these things should be explained to them. So the physician should counsel their patients carefully on the risks and the benefits of single embryo transfer. It should be seriously considered for the good prognosis of these patients, and also the cryopreservation protocols that are available should also be explained to them. So the rationale is for the use of ovulation stimulation is to increase the number of embryo oocytes available for fertilization, and thus to improve the chance of pregnancy without compromising on the oocyte quality. So the goals of any ovarian stimulation should be an ideal outcome, that's a single live birth at a term, and also subsequently minimizing complications and risk of a multiple pregnancy. So balancing the risk factors to the overall pregnancy rate. Life waves, like the waves are of 4 oceans, the troubles are for life. So absence of both makes it uninteresting. Thank you so much for a very patient hearing.
Hello. That's great, Gautam.
Thank you, sir. Thank you, Sudeep, sir.
I think we have just finished in time.
Yeah.
So we finish the session here and we go back to the next session. Thank you very much. Thank you.
Thank you, Sudeep, sir, and thank you to all our speakers for this session. It was a very interesting and informative session. Thanks a lot. Now we are moving to our next session, which is the next session. The chairpersons will be Dr. Radhika Kundala, and Dr. Pallavi Pasricha. Both are with us. Dr. Radhika is. Can I have a better picture of this CV? Atul, can you hear me? Atul. Hello.
Yes, sir. Yes, sir. Yes, sir.
It is not clear. Hello.
It's clear from my end, sir.
It's Dr. Radhika's CV.
Yes.
Dr. Radhika is a renowned doctor. The CV is not clear over here. Can you read it for me, Rahul? Atul? Hello?
Is Dr. Radhika? Hello? Yes.
Hello?
Yes. Are you hearing?
Am I audible to you?
Yes, sir.
Hello?
Hello? Is it audible for me?
Some technical glitch over here. Hello?
Hello? I can hear you, sir. I can hear you, sir.
Hello?
Hello?
Hello, Atul. Hello?
Hello, I can hear you, sir.
Hello?
I think there is some technical glitch with Dr. Gautam Roy. So, can we move on to next, Dr. Chairperson? First chairperson of the session, Dr. Radhika. She is MBBS, AFMC Pune, DNB Obstetrics and Gynecology, FNB Reproductive Medicine. And next chairperson of the session is Dr. Pallavi Parshia, MBBS, DNB Obstetrics and FNB Reproductive Medicine, fertility consultant and gynecologist, Counterine Hospital, Panchkula, Haryana. Thank you, ma'am. Over to you.
A very good morning, all of you. Over to the next session. The speaker is Dr. Jatin Shah. He would be speaking about selecting the correct oocytes to get out the optimum embryos for an optimum outcome. So over to you, sir.
Thank you, Dr. Radhika, Dr. Pallavi. Thank you all the organizing members of ACE. It's indeed a pleasure and a privilege to be here today. And I'm going to talk on a very interesting topic, and that is how a clinician should focus on getting the best and the most competent oocytes so that in turn the embryologist can generate better and top quality embryos for excellent cumulative live birth rate. Now, before we talk about this, we need to understand that why is oocyte competency so important? And you can clearly see that the oocyte is the major determinant of embryo developmental competence. It not only delivers half the chromosomal complement, but also delivers a lot of the mitochondrial genome to the embryo. And we know now that more and more oocyte competence is also related to mitochondrial competence, which in turn gives us the best live birth rates. And remember that unlike the paternal genome, the maternal genome carries a heavy footprint of parental aging. To get the most competent oocytes, you need to get more oocyte numbers. And that is very, very important. And we know today that almost 40 to 50% of our patients are poor responders. And if you look at our aims of ovarian stimulation, our aim today is not to get 5 or 6 oocytes, but rather to get as many as possible, even as many as 20, 25, 28 oocytes, so that you have enough top quality embryos for vitrification, and therefore you have a high cumulative live birth. But is there a correlation between number of oocytes and top quality embryos and oocyte competence? And you can see here this data from 2019, almost 300,000 IVF cycles, clearly showing that the group with the most oocytes aspirated had the most top quality embryos on day 2 or day 3. And you can see here that the moderate cutoff number of mature oocytes was, for example, you needed more than equal to 3 oocytes for obtaining more than equal to 1 top quality embryo. So you can see if you get 3 oocytes, you would be able to achieve at least 1 top quality embryo, and so on. So as the number of mature oocytes increases, so will the proportion of top quality embryos. And that brings us to dosing. So do not underdose your patients. Even normal responders, it's very important that don't convert a potential normal responder into a Poseidon 1 or 2. So what you need to do is select the correct initial dose. And clearly you can see here that the standard starting dose for all patients should be 200 or 225 IU. Please do not begin with 100 or 150 getting scared of OHSS, because that's a thing of the past. With the antagonist protocol, with an agonist trigger, you can even retrieve 100 oocytes and not have any hyperstimulation. So please keep a starting dose fixed at 225 across all categories of normal responders. What about poor responders? We know that in poor responders, every additional oocyte that you get will contribute to the pregnancy rate, and you need some form of pretreatment with either estradiol or the antagonist or norethisterone or OC pills, which I don't like too much, and I'll show you why. But better to use estradiol valerate or an antagonist so that you get a uniform and synchronous cohort of follicles, and each and every follicle that you get yields a top quality metaphase 2 oocyte. Antagonist pretreatment, especially popular over the past 2 or 3 years. You just need to give antagonist on days 2, 3, and 4, and then begin stimulation from day 5, and then add on the antagonist later when your follicles reach a particular size. But what is the advantage? You can see here significant increase in the number of oocytes. You can see from 9.9 goes up to almost 14, statistically significant increase in the number of oocytes. And this is very important, especially in the poor responders group, because if you can get 5 instead of 3 metaphase 2s, you definitely have a higher chance of getting 2 top quality embryos instead of 1 top quality embryo. And many reasons why not to use the OC pills, and clearly we have so much of evidence over the years, the most recent being 2018, showing a higher miscarriage rate whenever prolonged OC pill pretreatment was done. So all the people out there doing batch IVF, please be wary of this. Many a times you wonder why you didn't get a good outcome. Many of you don't like the agonist trigger. This is the reason, is that the OC pill pretreatment is the culprit usually and doesn't give you a good outcome, especially when you give an agonist trigger to some patients. ongoing war for the last 4 decades, agonist or antagonist, and most of us switched to the antagonist about a decade ago, thinking that it is safer across all categories, but we forgot that the safety aspect was only for the high responders, and that the agonist still has a lot of advantages, which still makes it a protocol of first choice, especially for poor responders and almost 70 to 80% of your normal responders. And why? For the embryologists out there, you can see this data that does the use of the agonist or antagonist have any impact on oocyte and embryo quality? Clearly, with the agonist, you get higher number of oocytes, more metaphase 2 oocytes, lower proportion of oocytes with cytoplasmic abnormalities, and you get higher number of fertilized oocytes, and you get higher number of zygotes with a normal pronuclear morphology. Also, success rate wise, 38% versus 28% when you compare the agonist to the antagonist. Now, these may be marginal differences, but they have a huge impact in your difficult category of poor responder patients. And to prove the point further, we did our own study. Same patient underwent first an antagonist cycle and then an agonist cycle with HbHMG 300, and the antagonist was, of course, with the conventional doses. Clearly, you get a higher number of metaphase 2s because you have a more synchronous cohort whenever you use the down regulation. But more importantly, almost double the percentage of top quality embryos with the long agonist HMG protocol. So clearly, this protocol still has a very important role to play. And believe this study we did was only in Poseidon's 3 and 4. So you can imagine that in poor responders, this was the difference in outcome, which makes all the difference between success and failure for these patients. What about Poseidon's 3 and 4 and agonist protocols? Do we have any other corroborative evidence? And you have this huge study from 2018, again showing that in young patients with a reduced ovarian reserve, that's your Poseidon group 3, the agonist protocol gives you almost twice the live birth rate as compared to the conventional antagonist protocol. What about normal responders? We know that in poor responders, yes, the agonist would be better. And we have this huge study from 2017, again, had a very good comparison of fixed versus flexible day start antagonist, OC-pill pretreatment versus no OC-pill pretreatment. And clearly they found that in the general population, pregnancy rates were in fact lower with the antagonist protocol. Also, the agonist protocol yielded significantly more oocytes, and this is very important for poor and most normal responders too. Whenever you do a flexible antagonist start, that is at 14 millimeters instead of a fixed day 6 start, and you have used OC-pill pretreatment, your pregnancy rates will be much lower than the agonist protocol. So if you want pregnancy rates on par, very important that do not use OC-pill pretreatment and have a fixed day start antagonist for all patients with regular menstrual cycles. So we are not talking about the PCOs and the high responders where you continue with the flexible start because you don't know when she will start responding. But for all other regular cycle patients, it's best to have a fixed day start antagonist. And that brings us to the high responders, and we all familiar with, yes, you must give antagonist protocol, you must use the agonist trigger, and you must do a freeze-all to make it absolutely safe and successful for this group. But again, be wary that if you have given OC pills in the preceding month, you will have excessive suppression of LH at the start of stimulation in these high responders. And subsequently, when you use the agonist trigger, you will not have enough of endogenous FSH-LH to give you a good LH peak. And therefore, almost half your cycles would end up with a suboptimal response, by which I mean you have 30 follicles, but you get just 20 oocytes. You have 20 oocytes, but you have just 8 metaphase 2s, and so on. And that is what the OC pill should be avoided for. What about choice of gonadotropins? In the high responders, we've all been taught that you need to give only FSH, but we have still facing a lot of problems with mitochondrial defects in PCO oocytes, and these give you a high incidence of early miscarriage. We now have a new trial, the Megaset HR trial, which compared HPHMG, that is, which contains HCG-driven LH activity versus conventional REC-FSH, and they showed that, in fact, the pregnancy rates were better with HPHMG, but most importantly, the early pregnancy loss was almost half of what you get with REC-FSH. So besides being genetically normal embryos, because the study only transferred PGT-tested euploid embryos, and yet the early pregnancy loss was significantly less in the HPHMG group. Clearly, this shows a huge advantage on the mitochondrial efficacy and competence of the oocytes which are generated in PCO patients. So you would get fewer oocytes, 7 fewer oocytes on an average, translating into 5 fewer metaphase 2s, 4 fewer 2 PN zygotes, 3 fewer blastocysts. But when you finally compare top quality blastocysts, they are the same and there is no difference. And that is why you can see the early pregnancy losses are almost half, even in the cumulative frozen group and in the fresh and frozen put together. And more importantly, the cumulative live birth rate, which at the end of 6 months, counting all fresh and frozen transfers, was the same in both arms. But this was achieved with 43 fewer transfer procedures in the HMG group and using 65 fewer PGT tested euploid embryos, which again brings to the point that everything and every miscarriage is not related to genetics, especially in high responders. Please be more and more aware of mitochondrial defects, and maybe HCG driven LH activity helps to restore some mitochondrial competence for these patients. Many a times you get more follicles, less oocytes, more oocytes, less M2s, more M2s, less top quality embryos, and that is why the trigger is so important. And the rationale of the dual trigger is that we know when you give an agonist trigger, you induce a very physiological peak of both FSH and LH, unlike HCG trigger, which only simulates LH activity. And you can see here, whenever you have a lower percentage of oocytes, the dual trigger will help to significantly improve all your outcomes. So also when you have a lower proportion of metaphase 2 oocytes, when you use a dual trigger instead of just HCG, you have a significant improvement in all your parameters related to the final IVF outcome. Here you can see even in poor ovarian responders, when a dual trigger was used, significantly higher fertilization rate, clinical pregnancy rate, live birth rate, reduced abortion and miscarriage rates again. So all this fine tuning is very important to make sure that you give competent oocytes to the embryologist. Even in normal responding patients, the dual trigger gives you statistically significant higher number of top quality oocytes, competent oocytes and top quality embryos. What about supplements? We all keep talking and hearing a lot about supplements. What about transdermal testosterone gel? We all know that as age advances, there is a reduction in testosterone levels in most women, and that these androgen receptor expression is important at every stage of follicular development, be it the primordial or the preantral or the antral or the final ovulatory follicle. And it's very important to have a good level of androgens at each of these stages. We have a lot of papers and evidence now which shows that transdermal testosterone helps in improving the number of oocytes, number of metaphase 2, that is competent oocytes, and the number of top quality embryos in poor responders, especially your Poseidons 3 and 4, where you would have adequate, because your 4 wand, you already know they have a diminished ovarian reserve. So a pre-treatment with one of the androgens would be useful. Very important area, because we hear so much about coenzyme Q and how it can help to improve oocyte competence. Coenzyme Q, we know that there was a meta-analysis in 2020 which said that there is limited evidence in support of supplemental oral antioxidants, and that there is not enough evidence to advise that, okay, give it to all the patients. But we also have data now to show that pre-treatment with coenzyme Q10, because the meta-analysis was for all IVF patients in general, but if we talk of only poor ovarian responders, which is 50% of our patients, there is evidence, especially for group 3 and 4, that pre-treatment with 60 days of coenzyme Q will result in significantly lower gonadotropin requirements, higher number of competent oocytes, more top quality embryos available for cryopreservation, and therefore higher cumulative live birth rate. Vitamin D supplementation also very important, often neglected and forgotten. We have enough data to show that there is a significantly lower live birth rate when there is vitamin D deficiency as compared to those with adequate vitamin D levels. And so also zinc supplementation in the pre-follicular pre-stimulation month or so is important to help you get more competent oocytes. Very interesting area. All of us know of myo-inositol in PCOS, and I don't need to tell you about that. But what about inositol in normal patients? In normal responders, in poor responders, do we have any evidence for its use? And we have this large study here from 2017, which showed that oocyte and embryo quality and clinical pregnancy rates significantly higher in the myo-inositol group as compared to the control group. You also had significantly reduced miscarriage rates in the myo-inositol group. Proportion of top quality grade 1 embryos was significantly higher. Proportion of GV oocytes was significantly lower, and the amount of REC-FSH required was significantly lower with myo-inositol pretreatment in normal responders and poor responders. Leave aside the high responder group. And finally, of course, we have newer things on the horizon, ovarian activation. We know that you could inject autologous PRP into the ovaries, especially for patients with a very, very low poor ovarian reserve who are just not ready for oocyte donation. And we have data coming in now of the first few studies. And you can clearly see here clinical pregnancy rate and live birth rates at 33 and 40% after the PRP was injected versus 10% and 14% in the control group. So this definitely brings us a huge ray of hope, especially for these poor responders. What about external factors which can affect the morphodynamic behavior of the human embryo and not result in a top quality embryo? Don't overdose. When I said that give 225 to everyone, I did not say give 300 or 450, because overdosing is known to cause slower embryo development and also can cause fragile zona pellucida and can not often not give you the best outcome for your patient. We also know that BMI, we all know about high BMI and obesity, but even underweight females have been shown to have significantly slower cleavage in the early cleavage state as compared to normal women. Also smokers, women who are smoking, they have significantly later cleavage in most of their embryo events. Also in PCOS, of course, we all know that there could be slower early embryo development, slower pronuclear breakdown, and lower number of top quality embryos, again, because of a lot of mitochondrial defects in this group of patients. Then, of course, you have the various other factors, such as the laboratory factors, but of course, I'm talking to a lot of embryologists today, and they are all familiar with the laboratory essentials to make sure. And one paper that all of you must go and read is the Cairo Consensus Group 2020. Very fantastic heading. There is only one thing that is truly important in an IVF laboratory, and that is everything. So you must make sure that the embryologist is well versed with daily calibrations, the importance of temperature maintenance, pH fluctuations, low oxygen cultures, online filters, whenever you change a cylinder and so on. Calibration of the ICSI micromanipulation stage, very important, because the oocytes are often out for 10 minutes, 15 minutes, if all of them are in the same dish. And it is important to be aware of all these factors. And of course, it's a whole lecture in itself, but it's important that you go back and read these consensus guidelines on IVF culture conditions by the Cairo Consensus Group. But what I really wanted to highlight today is that we often tend, and especially in India, there is a trend to do ICSI for all compared to the West. In Europe, its ratio is 60 to 40. 60 is ICSI, 40 is IVF. In India, somehow 95% of clinics prefer to do ICSI for all. Although we know that there is so much evidence that ICSI does not offer any advantage, no clear benefit, fewer live births than IVF, lower blastulation rates with ICSI, and higher pregnancy rates with IVF, especially in non-male factors. So please remember that to generate top quality embryos, you also need to be very individualized in your approach to every patient and not do ICSI for all just because it's more convenient to you. We often say, oh, if you have less oocytes or if the woman is about 35, then ICSI is better. It's quite the contrary. If you see here, advanced maternal age women, IVF compared to ICSI, IVF in fact gave better metaphase to metazygotes, higher blastulation rate, and a higher live birth rate as compared to ICSI. So we need to rethink and be really individualized here and not just apply ICSI for each and every patient, because we know that with ICSI, there will be a lot of time consumption. It requires a highly skilled embryologist. There are a lot of temperature and pH fluctuations because the oocytes are outside on the stage for a long time. There is also exposure to chemicals such as hyaluronidase and PVP, which does not happen in conventional IVF. And of course, to generate top quality embryos, we spoke so much about the female partner. We also need to remember that male oxidative stress infertility is now recognized very importantly to be responsible for almost 50% of idiopathic male factor unexplained infertility, and some form of antioxidant treatment is important for the men as well, especially for your oligoasthenoteratozoospermics, so that you get top quality embryos, you try to reduce the DNA fragmentation and get much better outcomes for this group of patients. And finally, before I end, if you get a bad oocyte and you don't get a competent oocyte, is it game over? Don't lose heart. It isn't so. And there's a wonderful study here from 2015. We know what do we mean by dysmorphic oocytes, those which have a dark cytoplasm, granular cytoplasm. We often have these comments written on the dishes by the embryologists that abnormal zona, increased perivitelline space, and so on. And we think, oh my God, she was such an important patient and now I'm not going to get a pregnancy. But don't despair. We know that the overall fertilization rate may be significantly lower, but embryo quality in this study in both the groups was similar. So they showed that despite so-called apparently dysmorphic oocytes on day 1, it doesn't necessarily translate into a failed IVF cycle. In fact, there were some abnormalities like a dark cytoplasm, abnormal polar body, and cytoplasmic vacuoles, which actually were correlated with a higher percentage of top quality embryos and pregnancy rates. So with that, of course, acknowledgements to my team, always in order. And thank you once again. Very grateful to Dr. Gautam Khastagir, Dr. Ratna, all the organizing members of ACE 21 for this opportunity today. Thank you so much.
Thank you, Jatin sir. That was an elaborate talk, almost touching every aspect. And we all know Dr. Jatin Shah is a renowned name, not only in Mumbai and India, but across the world. And sir, I would like to ask one question. What do you feel about the double stimulation in cases to get more number of oocytes? Because this is that luteal phase stimulation yields better oocyte quality-wise also. So what is your take on a double stimulation?
Yeah, so that's a very good question, because I've probably done a huge series of dual stimulations now, almost reaching 100 cases. And we've had excellent results, because as I totally agree with it, that the follicular phase stimulation compared to the luteal phase stimulation, for some reason, the luteal phase stimulation generates more oocytes and gives you a higher percentage of top quality embryos in 60% of very poor respondents. So it's definitely a huge ray of hope. But because today I had just
So if you would
18
say,
minutes,
how do you go for a double stimulation? Do you use meprate, medroxyprogesterone, or you use antagonist?
no, so there are 2 or 3 different ways of doing it. One is you give antagonist in both the follicular phase and the luteal phase. That was the conventional way, what Ubaldi reported. Then there were a lot of studies that you don't need to give any antagonist in the luteal phase because there's no endogenous LH left for a surge. So you just use it in the follicular phase and don't give anything in the luteal phase, which I've done as well. And the latest is now you start meprate or medroxyprogesterone acetate from day 2 and continue it till the second trigger is given. So you have a choice of all 3. As of now, I stick to the follicular phase cetrorelix, and I avoid any cetrorelix in the luteal phase. The important point here is to use HMG as much as possible. So you must use a combination of REC FSH and HMG in both the phases. That gives the best outcome.
Okay. And sir, what is your take on growth hormone as an adjuvant for getting a better oocyte yield?
I tried it about 10 years ago. I was not really happy with the experience or the success rates. And recently, I think there's a huge meta-analysis just 3 years ago by Rob Norman, and on 128 patients where it was used, and he clearly showed that there is no improvement in any outcomes. So as of now, we don't have evidence to support its use.
Thank you so much, sir. Dr. Radhika, you want to ask any question to sir?
This is a nice talk. It's like including everything.
Yeah.
Wonderful talk.
Thank you. If I had 5 more minutes, I would have written the whole dual stimulation also.
Yes, sir.
But anyway, time was a
We
short.
have time, sir.
No, now
Dr.
it's okay. Now
Dr. Jyoti is not presenting.
Pallavi covered everything, so it's fine.
Okay, sir. Okay.
Thank you, Jatin sir. Thank you. Thanks a lot.
Thank you for inviting me. Thank you so much.
Thank you, Pallavi ma'am. Thank you, Dr. Radhika. So Dr. Jyoti is not available. So with your permission, our chairpersons, we are ending this session, and there will be a break right now, and we'll get back to you at 12:30 sharp. I mean 2:30 sharp. 2:30 sharp. Sorry. Okay. Thanks a lot. Thank you all.
Yeah, thank you.
Hello, good afternoon, sir. And yes, good afternoon, sir.
Yes, yes, Atul.
Yes, sir. So you can test now if you want to share a screen.
No, I thought you have the slides, no? Like, or should I share it?
Yes, you can try it now.
In fact, so I said you're giving the CV slide right now.
Yes, yes, yes.
One second. So the first slide you are putting it, no? I don't have to keep, no?
Dr. Gotumukala Achyuta Ramaraju.
Is it fine, sir?
Yeah, that's fine. Now I share the slides. One.
Yes, yes.
2:30. I will give you a countdown like 3, 2, 1.
So it's clear, no?
Yes, yes, perfect visual, sir.
So what happens is so I stop the share.
Yes, yes. For now.
వీడియో సైట్ లో ఉందని చెప్పారు కదండి వీడియో సైట్ లో ఉందన్నారు కదండి వీడియో సైట్స్
Gautam sir, we will be do live in just 2 minutes. Hello.
Hello.
Yes, Gautam sir, we will be do live in just two
Okay,
minutes.
fine.
And just we have only one chairperson till now. I am trying to contacting other one as well. Sanchit, we are going live in after my countdown. So Sanchit, Sanchit, are you listening me?
Yes, sir. Yes, sir.
So we will go live now. So just do it live now.
Okay, sir. So live is here. Live.
Dr. Roy, please start. Dr. Gautam Roy. Dr. Gautam Roy, please start. So we can't hear you, Dr. Gautam Roy.
Good afternoon, everybody. Hello. Am I audible?
Yes.
Hello.
Yes.
Hello.
You are audible, sir. Go on.
Hello.
Hello. Can you hear me, sir?
Yeah. Good
Yes.
afternoon. Good afternoon once again. We are having a very informative session since the morning. So we are now starting our next session, which will be on endometriosis and adenomyosis. So can I have the CV of our chairperson? The chairperson will be Dr. Biman Chakraborty, Dr. Siddhartha Chatterjee, and Dr. Sunita Sharma. It's again not clear. Hello. Hello, Atul.
Yes, sir.
Hello.
Yes, sir.
Atul, can you hear me?
Yes, sir. So I request Chairperson Dr. Viman Chakravarti, please take over the session.
Hello.
Dr. Viman Chakravarti, please take over the session. Dr. Viman. So here is the first speaker with us, Dr. Ramaraju.
Dr. Gotumukala Achyuta Ramaraju.
I request you, Dr. Ramaraju, please start your presentation.
First of all, greetings from Visakhapatnam. And for me, West Bengal always has a happy place. And my association with some of the society talks, even though they're infrequent, are fascinating. And I was very happy to receive this invitation about the role of endometriosis and infertility. In this 15 to 18 minutes talk, I'll be taking you through the journey of endometriosis and how, as an embryologist, with changing times and changing technology and the role of artificial intelligence, the embryologists should transform themselves as knowledge workers. If they don't transform themselves into knowledge workers, then there might be a situation where technology will replace you. Because as I shown in the preliminary video, the time lapse is integrated with artificial intelligence, and the embryo assessment has been taken away from the embryologist for the present, and interpreting the information has been taken away. But the basic fundamentals of the pathophysiology of reproduction, if that knowledge is there, then you become a knowledge worker and you'll be able to compete your skills with the technology skills. That is what I wanted to show in this lecture. And as we go through this lecture, endometriosis affects every part of the reproduction. We only think it affects only the ovary. It affects folliculogenesis and early embryonic development. And depending on the stage of the endometriosis, it affects that. Then it affects the uterine receptivity and the uteroplacental interface, more so at stage 3, where the implantation date is low. And then it affects the placental developmental formation and the fetal developmental formation during the pregnancy. So endometriosis starts from the ovary, goes to the uterus, goes to the baby, and produces inefficiency of reproduction. So unless we understand this dynamics, our management might be an incomplete management, and then we might not get an optimum result. A lot of times you might be wondering, why did my boss did a surgery? Or why did my boss did not do a surgery? When you get in your collection tube endometriotic fluid, there are benefits of surgical treatment and there are risks of the surgical treatment. And here, when in this beautiful graph, you see, I'll be speaking about if you do a surgery of endometrioma prior to assisted reproduction, one is you have create a surgical risk of bleeding. You impair the ovarian reserves and sometimes with excess use of cautery, you might give or you might receive as embryologist less number of oocytes, incomplete surgery, and then also there is a learning curve by the gynecologist and a potential delay of assisted reproduction. But if you don't do it also, there are negative aspects. The disease progresses. They can be, as the cyst increases, there can be follicular contamination of the endometrioma, the complication of infection at the time of egg pickup, the need for higher dose of gonadotrophins, the need for cycle cancellation, and difficult oocyte retrieval. So when it comes to endometriosis, never judge anything that this is the perfect way, because it's a risk-benefit analysis that the clinician does it. And as your knowledge goes in, if you're able to give feedbacks in the thing, then we might produce a better result to the patient who is the primary person. And one should be aware of staging of endometriosis, so that what happens is when the result does not come in, there's no blame game between the clinician, the embryologist, the lab, because we know if it's an advanced stage, we should expect moderate pregnancy. If it's an earlier stage, we should expect better stimulation protocol. So understanding endometriosis staging is an important for embryologists, and more so, as you see in the next slide, there is an important concept which one should, even though the data is not there, you can also, from the embryology lab, if you're dealing with an endometriosis oocyte retrieval, you should look at the patient, what age was she, when was she operated, and what was the recurrence rate. Then you know that you have a combination of a prolonged marital life, you have a pathology which reflects information which is older information, and this endometriosis fertility index gives a graph of the natural fertility and also makes you understand and look at the oocyte from a scientific point of view. And if somebody has more curiosity, looking at the endometriosis fertility index score and in turn look at the oocyte quality, that becomes an interesting study which does not involve extra investment or extra time, but the curiosity of the embryologist, which in turn adds value to the scientific community. The role of laparoscopy in endometriosis are two things. A primary laparoscopy, which is called the staging and the treatment laparoscopy. And if there is a recurrence of endometrioma, the role of second laparoscopy comes only in two situations, where you do a second laparoscopy for pain management, or the endometriosis is producing a rectal problem or a ureteric problem, that means the symptomatic endometrioma. And mind you, the current data does not show a second laparoscopy improves fertility. So always look at whether the patient has a primary laparoscopy or multiple laparoscopies. That in turn affects what type of genetic material you get in the laboratory and what is the intensity of the problem, and then analyze your results when you're looking at the endometriosis from an embryologist perspective. If you are looking at surgery, and then if it is an older woman, then you have age as a factor, then male factor, ovarian reserves, and tubal status. If all these are perfect, then there's a role for primary surgery. The most important thing in endometriosis, which the current literature has evolved over time, is a concept called time to pregnancy. And the role of conservative management comes in only when these criteria are met. That means the woman is young, there's no male factor, the ovarian reserves are adequate, and the tubal status is perfect. That's the only place surgery plays a role. All other places, the concepts and evolving are moving to assisted reproduction and a child as early as possible, which I'll mention in the next slide. The most important, like I mentioned, is time to conception. How long from the time she has come in, from the diagnosis of a problem to a child in endometriosis, the time to conception is important because the more you delay, the more the advanced disease comes in and more the chances come down with associated adenomyosis. So always remember how long was the problem diagnosed and then do a failure analysis in those patients, which will make a lot of sense as you analyze your data. Then the next thing is, we always think endometriosis only at the oocyte level, but it also has effect at the sperm level in a normal situation, at the oocyte level, at the junctional zone, at the embryo transfer level, and I will come from the embryo transfer level. And if there is an endometriosis and a deviation of uterus, your colleague or the gynecologist might have difficulty in embryo transfer. So discussing with the with the clinician that there is a potential issue of transfer difficulty, so that a precaution saves a difficult situation. Because as embryologists and clinicians, the embryologist will be doing an analysis part. The clinician might be coming from an OP or an egg pickup and then try to do an embryo transfer. Your feedback of the type of uterus anticipating might add value to the clinician if the clinician is receptive to your ideas, because reproductive medicine is one field where if the results are there, the credit goes to the team, but not to the team leader. The team leader is only the face of the organization. That's the most important thing. And when it comes to uterus, as more and more information is coming in, the role of junctional zone plays a major role. This is the junctional zone. Earlier, it was not visible in conventional ultrasound, and only in adenomyosis cases, you are able to look at gross junctional zone thickness of 10 millimeters and above. But now data is coming in. A large junctional zone will also impair the implantation. And the embryo quality will depend on the sperm and the oocyte and the age. So in a natural conception, you have the role of IL-6 in the peritoneal fluid, but in terms of reproductive medicine or in the IVF lab, if you're looking at an IUI, you should look at that both the sperm, ovary, and the uterus are affected by endometriosis. So when you analyze the results or select a patient for an IUI, remember that the IL-6 might impair the pregnancy outcome. And the role of conservative treatments are there only for grade 1 or stage 1 and stage 2 endometriosis. Stage 3 and stage 4 need a quicker solutions and a more efficient solutions. Those should be done. Similarly, apart from the mechanical disturbances, the interleukins also affect the E1 levels, and not much study has been done. Only recently, the role of aromatase inhibitors are coming in, and the role of follicular fluid steroidogenesis is coming in, where they found that the endometriotic follicular fluid has a slightly different profile compared to a non-endometriotic follicular fluid in the area of steroidogenesis, and potentially they might become markers in future. So the message is it affects the sperm, and that will affect you when you're doing an IUI process. It affects the stimulation protocol at the molecular level, both in terms of function and also in number, and also in terms of age. It also affects the endometrial receptivity, but the work is very, very preliminary and more work is bound to come. An ERA test in endometrial receptivity for endometriosis, there is a lot of misunderstanding. The reason is ERA is a good test, but it will assess only the endometriosis and the role of progesterone and the size of the implantation window, but not every gene that is associated with endometriosis. So remember, when you're doing an ERA test for endometrial receptivity, look at it's only telling about the window of implantation, but not about the upregulated or downregulated genes of endometriosis or endometriosis pathology. That's a message I want you to remember. The other thing is, this is a beautiful slide in 4 colors, the orange, the green, the light blue. And this is from the classic Lancet article, where they have introduced a concept called emergency IVF. That means don't waste time. Then remember, time to conception is important. And there they suggested infertility workup in endometriotic pregnant, measure the ovarian reserves. If the reserves are lower, advise IVF. And then if the reserves are adequate, then the role of seminal analysis comes in, and there's no male factor, then the assessment of tube comes in. And then once you are able to fulfill this reddish orange column, then only the role of surgery comes in. But there it comes with the caveat that you can wait between 6 to 18 months for a spontaneous pregnancy. And if there's no pregnancy, you have to take action. So the green things are the criteria for surgery. The below mark of 6 to 18 months is how long can you wait? And even though there is a male factor or ovarian reserves, the exception for rule of not a surgery is a severe pelvic pain, hydrosalpinx, and large endometrioma. Once you have decreased reserves or abnormal analysis, abnormal tube, or after surgery she has finished 6 to 18 months, there is a role for ovarian suppression and then going for assisted reproduction. This we have been following for the last 10 years, and I'll show you the article. I want every member to read this article, which was published in Lancet in 2010, Endometriosis and Infertility, Pathophysiology, and it is highly quoted, and it gives a beautiful experience and understanding. What are the impact of endometriosis? On stage 1 and 2, not much change. Stage 3 and 4, it impacts assisted reproduction by producing less oocytes, lesser implantation, lesser carry-home baby rate. But the data shows assisted reproductive procedures does not increase the incidence of endometriosis. A newer concept that is being proposed is, as more career women comes in, the role of fertility preservation, its role comes in bilateral endometrioma in young women with a previous surgery not planning a pregnancy. Like oncofertility, fertility of the endometriosis patient of oocytes is an important concept and should be discussed if the woman is not planning a pregnancy and a career woman. But the pregnancy rates are good, provided you do it in the right time. And I thank you for giving me an opportunity. And I'm not sure whether the questions are now or at the end of the session. Either way, I will be delighted to answer any questions that are there. And I thank the chairmen and the organizing committee for giving me this opportunity to participate. And the Association of Clinical Embryologists, I admire that organization of the wonderful conferences they do. And I feel happy. And if I can do anything to them in any way, they can feel free to ask me. Thank you very much.
Dr. Siddharth Chatterjee and Dr. Viman Chakravarti are the chairpersons, so they can ask anything, or should I move on to the next speaker?
Audible.
Yes, sir. Yes, sir. Perfect.
I am audible. Okay, because I could not introduce Dr. Raju at the beginning because I could not get the connection was not there. I'm sorry for that, Dr. Raju, but it was a wonderful talk.
No, sir.
And I thoroughly enjoyed it. I am a clinician and I have been working in gynae obstetrics for the last 60 years. Now, when I was a medical student or in the house staff, we used to see endometriosis. And we used to say there is a disease of the Eastern world. Nowadays, every third patient is a endometriosis. Any idea? This
Sir, I'm not able to hear your last line, sir.
How is it that disease which was so very rare at one time in India, now this is one of the most frequent gynecological conditions bothering the gynecologists?
I would answer this in two ways, sir. One thing is pregnancy has a protective effect partly. Second thing is the age of marriage has been shifted by a decade in the last 1 decade.
I agree.
The second thing is environmental roles are being investigated as a potential cause, and we look at our Howrah Bridge or the Vizag beaches. We have a lot of plastic contamination, much more. And the amount of food we eat, either in the fish or the rice and the water, has higher amount of organophosphorus compounds and chemicals, which are phytoestrogens, and we never bother to do research on that. The fact is, age has changed, diagnostic modalities have improved, but at the same time, the environment in which we live has changed. All can cause the problem, or one is the cause and other are the cofactors. But ultimately, it's the woman that is suffering.
Thank you, Dr. Adu. Very nicely said. Now, in asymptomatic patient, not very severe symptoms, do you advocate laparoscopy only for diagnosis purposes? Because laparoscopy is the gold standard, but it has its hazards also.
Like if an unmarried girl comes in,
yeah,
and she is 16 years and she has endometriosis, then I do two things. The first thing is I do a transrectal ultrasound, not the transvaginal, because their taboo issues are there. And the transrectal ultrasound, apart from ovarian assessment and extent of endometriosis, I also count the number of follicles and also see whether there's any sigmoid colon or rectal involvement during the transrectal ultrasound. If my job was inefficient in doing that, that's the time only I ask for an MRI, which specifically saying I need the sigmoid and the ovary relation pathology, much more sections, because I'm worried about, am I underestimating the thing? The second thing is, I would like to check an AMH level. If the AMH level is adequate, then I would give it, and I would also do instantly, which may not be a very accurate, but I use the IoT score and a combination of CA125 and the family history. And then I would like to look back at the end of 6 months. If she's fine, I would like to leave alone, but say that if you're not going to marry for 10 years, then the role of oocyte preservation is there. But if your reserves are adequate, read this literature, and wherever you are there, because people travel with jobs. If you're delaying your marriage when you're asymptomatic and your AMH is changing, go for fertility preservation in a good center where you can go back and do an IVF in that particular center and don't think about transferring them.
Thank you very much. Do you give a lot of stress on the image, whether because at that age of 16 or 17?
I don't do the surgery, but what happens is, but I tell all the information. Then I say that if it is more than 6 centimeters and is asymptomatic, then I say that I discuss with the father and the mother, and I also look for rectovaginal endometriosis, and I also ask for the family history. But I tell them endometriosis is here for life. But you'll have only one chance to do a good surgery. And that chance, we should optimally use it at the right time. And that's a balance of a clinician's decision rather than the child's decision, or it's a combination of clinician and parent's decision rather than child's decision. That's how I feel.
Can we move on to the next speaker?
Yes, I think Dr. Chatterjee might have something to ask. Chatterjee?
In fact, hello, am I audible?
Yes, yes.
Yes, ma'am. Yes, sir.
Hello.
Yes, you are audible. Please introduce Dr. Nina.
I think we can proceed to the next speaker, then we can discuss thereafter
Yes.
about this issue. Please proceed to the next speaker.
Our next speaker is Dr. Nina Malhotra, MD, DNB, RCOG, and Professor and Head of Unit, Art Center, Department of Obstetrics and Gynae, AIMS, Delhi. So the stage is yours, ma'am. Please start.
Can I ask to be unmuted? Yeah. Am I audible and then my slides are seen?
Yes, ma'am. Yes, ma'am. Please
Yeah.
continue.
Very good afternoon. Thank you very much, the organizers, Dr. Gautam, and all the team ACE for having me here. And I think I would begin my lecture. Before that, I would have to express my gratitude and thanks to Dr. Ramaraju for being such a good friend and being there. And of course, at this time also going ahead of me in presenting and setting the floor ready for endometriosis, because he's done half of my job, because I talk on impact of endometriomas on the ovarian reserve and in the pregnancy outcomes. So I would not waste much time and move ahead. We know that this is a difficult problem, as Dr. Ramaraju has already pointed out, very challenging situations, because we get women coming with infertility and more so with pain, and then we are really confused. And of course, we know what is endometrioma. Endometrioma is nothing but a collection of this endometriotic chocolate fluid within the ovaries. As I will not go much in detail about describing how endometriomas develop and how they form. And we know that when women suffer infertility with endometriosis, the reasons are very many, right? From the anatomy to the ovarian dysfunctions to the tubes. And of course, what's very pertinent, I think something that we cannot correct, is that accelerated depletion of follicles and low quality of embryos, which Dr. Ramaraju has very beautifully pointed out, where we've started feeling there is now a need of offering them fertility preservation, i.e. oocyte banking for them. But then coming on just on the endometrioma and the ovarian physiology, how does it really matter? Does it affect fertility? Yes. The ovarian reserves are lower in these girls, in these women. There is ischemia, there's damage, and of course, the toxic nature of the fluid. And what's very important, we may be getting lesser quantity, but the quality lowers, and so does the embryo implantation potential. Now, I think there are a lot of papers with this from the Human Reproduction Update. It's a beautiful review article which clearly tells us what really goes wrong at the molecular level. Not only is this endometrioma causing a stretch, which is a mechanical stretch, but it's releasing the ferric ions inside are causing the release of toxic ions, which cause a lot of oxidative stress. And not only that, there is a burnout effect to the tune that there are unfavorable events which occur all along the healthy tissue which is surrounding. So it's not just the immediate vicinity of the endometrioma, the ovarian tissue gets disturbed, but it's by far reaching with all these factors that are coming into play. So then what are our concerns? Certainly we know that the ovarian reserves are getting diminished. So what happens to the ovarian reserve markers? And we know that we are relying totally on the very reliable anti-Mullerian hormone and antral follicle counts. So let's look at what are the trends in young girls when they have endometriomas pre and prior and post surgery. And I think this paper really covers very beautifully the influence of what happens. And in the nutshell, what this data showed was when these girls or these young women had unilateral endometriomas, if you look at the graph, their AMH are almost similar or were paralleling those which are of women without endometriomas. However, if they were bilateral, you can see how dramatic is the fall, i.e. to say that AMH does get dramatically affected if they are bilateral in their positions. What about antral follicle counts? Yes, we know that the antral follicle counts will be depleted. There will be surgical insults, but then with the distortion of the ovary, which is being occupied by the endometriomas, do we still rely on the antral follicle counts? Well, certainly yes. In fact, the accuracy of antral follicle count in predicting the reserve is almost similar to the ovaries which are unaffected or affected. So I think we can still, the only thing is that you have to be very judicious in using your machine. And of course, the practitioner has to be well versed in identifying small endometriomas from the growing follicles. So when we talk of ART, I think certainly what are the factors that we will really think about in consideration of treatment? Needless to say, the age, the reserves, which I have told. Of course, unilateral, bilateral, whether they are there because they spell a prognosis. And of course, very important, whether they've undergone prior surgeries, because that is the one which becomes further challenging. So while we are planning these women for ART, I think these are all the things that we would want to know. What is her workup? What is the disease? Whether she has an associated deep endometriosis or adenomyosis, which will be dwelled later in the session. And of course, we come on to what is the outcome of IVF in terms of pregnancy. So definitely when the follicular genesis is impaired, it is not just the quantity, but also the quality. But what Dr. Ramaraju very rightly pointed out is it's not just the oocyte or the ovary or the endometrioma, the disease per se is also reducing the endometrial receptivity. And we have a lot of data. There is, suppression of the HOXA10 genes and inflammation and all the kinds, which really lead to lower clinical pregnancy rates and even implantation rates, no matter how good you may be in your ART program. So what about the effects on the impact of the endometrioma per se? I think that is even without when you're doing surgeries in the outcome, the systematic review. I think this is one of the very good systematic review, which is not very recent, but it looked at live birth rates and clinical pregnancy rates beside other factors. And they said that women with endometrioma almost had similar outcomes to those who do not have disease, but there were certainly higher cancellation rates. But what was very important is that the surgical management did attribute to further, lowered pregnancy rate. So individualization of women rather than giving them one statement, oh, you stand a poor prognosis, is not the take from this good, review article or systematic review. So when we talk about the options, when we have to really take them for ART and what really affects is, I think medical is really out because we want to give them babies, is should we do surgery prior to an IVF? And I think the surgical options are not very many between ablation or cystectomy and of course sclerotherapy. But then the very important take is, are we really going in for surgery before ART in all patients? Or should we really scope and then start peeling out their ovaries? I think as clinicians and as embryologists all alike, we really walk a tightrope because there is at one point a reserve which gets compromised whatever good surgery should you do. But then at the same time, we know that there will be a need for surgery in a small amount or whatever percentage of patients we do. But keep in mind, whatever you're doing, the recurrence is bound to happen to the tune of 1/3 to 2/3 women will come back. So if the decision is ART, you should be very prompt, do whatever surgery you do, take them to their IVF cycles immediately, because by the time they come back and they take a delay in decisions, I think there is a recurrent endometrioma, further challenging your skills. I'm sure this is a beautiful diagram, which we all would love to say, to do or not to do the surgery. And of course, there are all the downsides and the flip sides and also the advantages. But I think with the advantages, disadvantages, we have realized that ART is the therapeutic option, even for some women where cystectomy, I mean, in those where we know that they are not very big endometriomas, we should proceed ahead. Of course, this is what all the guidelines from most of the societies are saying, that if there are endometriomas, then counsel your woman, because there will definitely be a reduction in the ovarian function and the ovarian reserves. So a better choice would be to proceed for ART rather than to sit on the endometrioma. So, and of course, there is a good amount of data which says that neither aspiration nor cystectomy improves. It's only if there is a hydrosalpinx, and that is one time where you feel that there is an accessibility issue, should you go for a surgery. And I again want to reiterate, this is again the 2021 guideline from endometriosis from the ASHRAE, which says surgery should only be considered in situations where you know there will be a challenge. And that is when we know that the access to the follicles is going to be compromised, or the huge cysts. I didn't think this 5 centimeter would really hold good, because this is 2009, and as of now, we'd probably be judicious. But this is what is in centimeters. But if you feel that it's going to come into your way, then is the reason to do a surgery. Doing a surgery, I don't think I really have to tell between cystectomy is definitely better, because the risk of recurrences are lesser, but we don't have very robust evidence to say cystectomy stands above ablation. All said and done, the AMHs will be compromised, whether you use a laser or you use a harmonic or all of these energy sources. I just thought I would add here, although I really have not done sclerotherapy, but there is some data which is coming from small papers, and again a meta-analysis, which said that between sclerotherapy, there was no difference in the oocyte yield, and was better with cystectomy, but the clinical pregnancy rates were almost similar to women who underwent sclerotherapy. And also a small, numbers of 53 patients, who 13 out of them who had prior surgeries, they found that there were no major complications. But I don't think it's time to really say you can go ahead with this kind of treatment. On the risk of recurrence, yes, remember there will be a fall in AMH, and I think some paper says that there is a fall of up to 1.5 nanograms in decline in AMH, which may be immediate, but some papers said that there will be a recovery which takes up to 6 to 12 weeks to come back, but certainly never to the pre-surgery level. So whatever you do, make sure you counsel your women well. So whenever it is, second surgery is more challenging. So indications for a recurrent endometrioma have to be very, very judiciously thought for, because the brunt to the ovary will be far too major. Now then, when you've taken a decision, does the protocol matter? Because we know we are stimulating the ovaries with a compromise. We know the ovarian reserves are reduced. And so there's a whole lot of literature which says agonist, antagonist. I know that there are proponents who say the long, ultra long, and I think we are again choosy, because there are papers which say that antagonists are equally good. And there are advantages, disadvantages. I won't talk much in detail, but what is there? The ultra long, what was really, taken as the biblical kind of order, has got many disadvantages, because, you need higher dosages to kind of get back these ovaries, which go to dormancy, and you rarely get a higher duration of stimulation. Not much kind of, work here, but there's one meta-analysis which is recent, which says that there was a need where they felt, when they found that studies showed that if you use ultra-long, it did good for those who were stage 4 and stage 3 diseases. So for mild, minimal, just a long protocol would be good enough. And what about antagonists? This is something which we all have to understand, that these women, especially those who had 1 or 2 surgeries, who have the disease per se, will definitely be compromised, in fact, diminished in their ovarian reserve. So I think when I looked around literature and came across those women who had endometriosis after surgery and who had diminished ovarian reserve, what works better? I think this is perhaps the only paper which looked at all the 3 protocols, a retrospective data of good 342 patients, where they even used the antagonist. And what they came across was that the long protocol gave them definitely slightly better, pregnancy rates or the number of embryos, but there was no difference. But what was the big advantage was that the antagonist in such group of patients certainly reduce the cost because they are reducing the time for the stimulation. So let's come on the lab side. That is the challenge, whether you should do ICSI. Again, a very mixed group, which says that yes, if you do ICSI, you are doing away with all the toxic situations and you're kind of letting the sperm enter, and they are saying that there's higher fertilization. So the fertilization failure rates drops. But then some small studies say that just be judicious, not ICSI for all, because they're certainly not an indication. I think this is something which every lab should take a decision, should audit. But as of now, a lot of embryologists would swear to say that in normozoospermic semen parameters, ICSI could absolutely be beneficial, as it would circumvent the fertilization failure risk that could be really, really a disillusionment for the couple and for the lab. Then again, a consideration, should we go in for fresh or frozen? Now that we have a freeze-all policy coming in, I think endometriosis comes way up in the indications when we are talking of freeze-all, because we know that we would get an environment which would be very, very, in sync, because these endometriums are not very nice. They are hostile because of their genetic, kind of effects, and also because of the hormone that goes disarray in these genetic, studies that have shown. So there are a lot of papers now, but then certainly if you have an advanced endometriosis, the benefits of a freeze-all are definitely there. But then they're saying that with caution, and I don't think we'll really be reaching more than 15 oocytes. So again, your own judgment. If I'm truly getting just 2 or 3 oocytes and embryos, I think I have to be judicious and taking a call, and counseling would be very important to make my decisions whether I freeze all or I just put a fresh transfer. So the last bit of my talk is how are the pregnancies. We know that pregnancies may not be very, very different if there are unilateral endometriomas, if the reserves are good, and if they are not non-recurrent. But then when it's a pregnancy, I think we have to have a word of caution. The obstetrician has also to be involved, because we know that whatever said and done, they are at a risk of increased miscarriages. The obstetric outcome is not very happy, because there is lots of data which said that the preterm delivery rates, the placenta previa, are much higher. And of course, what really influences is that these outcomes are worsened because of women who have a severe disease. So perhaps the inflammatory markers are perhaps like the interleukins which are there in the peritoneum. Are they really affecting the placentation, or is it the embryo per se, which is kind of abnormal or not so very good? Who knows? We're really not sure. Of course, the SGA chances are more, and so are the NICU admissions in the babies who are coming from women who have severe endometriosis. So this is something which we have to keep in mind. Now, I think what Dr. Ramaraju said, that, with women who are getting pregnant, we always, and that's what even I thought. So, and I tell them, well, you're pregnant, you should forget the disease, and that's what it is, because you perhaps may not have recurrence. But when I was reviewing data for this recent talk, I realized that the literature is sort of saying that the risk of stimulation does not, there are 2 things important. What women worry is, if I undergo an IVF cycle, will the kind of drugs you give me, will it improve or increase my chance of having an endometrioma? Well, certainly not. And ovarian stimulation does not, increase a chance, even though that we create a transient state of hyperestrogenic state. But then what about whether the pregnancy would actually have an impact? Well, it certainly does not reduce the risk. Another thing is that will my symptoms increase in the deep lesions? No, they will not. And also on the quality of life, it does not. And on the pregnancy, the development of or the occurrence of pregnancy has a very variable, impact on the development of further progress of the disease. What's very important is that women should not be told that pregnancy may be a strategy for managing symptoms and reducing disease progression, as per this article, which is really a beautiful read, must read, by Linas et al., which said that there are fewer beneficial effects than what we previously thought. And I was also under the impression that once you're a pregnancy, you probably get away with the disease, but that's not the case if you read this article. So I'll just end my talk here, that ovarian endometriomas affect fertility certainly, and of course the RT outcome. Well, if they are bilateral, it spells a poor prognosis. Whatever surgery you do, it is a risk. So be very judicious in taking a call. So be good in your surgical skills, because this may perhaps be her first or last chance. Avoid repeat surgeries, but then there are situations where we can't. And of course, decisions to ART should be taken well before you put in a scope. That's very important. And I would just end here that whatever you do, your lab SOPs should be in place, audit your data, and of course, counsel your patients very well on how will be their pregnancy outcomes. So I will thank you all for a patient hearing.
That was a fantastic lecture.
Thank you, sir.
And the references you gave for the younger generation should make their mind wake up. Who will give references to study and tell them they have to search, read 100 articles to find one good article? That's a fact of life we all go through.
Well, I think in that case, I would say Dr. Ramaraju is an inspiration, because, to put one slide, I know he goes through how many articles, and I have had experience of sharing when he offers you his library so generously. Thank you so much, sir.
Thank you, Nina ma'am. Thank you. Thank you, Ramaraju sir. Now, Biman sir and Siddhartha sir, you can ask if you have any questions. Hello?
Yes, am I audible?
Yes. Yes, Siddhartha sir.
Hello?
Yes, sir, we are able to hear you, sir.
Right. The question is the endometrium, when it is there, it is the problem of doing IVF. Is it so? Hello?
Yes, I can hear you. I can hear
Yeah.
your question.
Now,
Yes.
Can you not think some way when we can reduce the endometrium and go for IVF straight away, not putting a scope in? So why can't we think that we can drain the endometrium?
I think I would just say, yes,
Let me finish, please. We can drain the endometrium under ultrasound guidance by putting some sort of needle or some sort of tube inside. So that can reduce the size of endometrium when it is more than 5 or 6 centimeters. And that can be done when we are doing down regulation. And immediately after that, we can go for stimulation. COS. So how is that?
So this is an old school of thought. I think in the present day and age, we should certainly not put in. I think we are putting a stick or a needle into a chocolate agar. So no matter what, you're putting a needle into a chocolate agar.
Transvaginally, no. We are not doing through vaginal route, because that may cause infection.
So, but whatever said and done, you're still putting a needle transabdominally. Even if you put it, you're going into a chocolate agar. So if I can do without that, why should I do it?
We have done at least 25 cases. There is no evidence of infection.
So you're very lucky, because
I'm doing a 2 years follow-up. I didn't publish yet because not much number, only 25 cases. And there is no evidence of infection. And after the drainage, if you can put all under down regulation, the cyst size is not increasing as well. And as soon as the situation is favorable, you can proceed for IVF.
So I would appreciate if you could publish this data.
This is similar to sclerotherapy. This is similar to sclerotherapy that they are doing in Korea. They are putting alcohol, but we are not putting anything inside, because we feel if we put anything inside, that can initiate infection. So it is only simple drainage. And it's a closed drainage, taking all precautions. And that can be done under local anesthesia.
So certainly a very good thought, but then this is really old. I congratulate you, sir, that you've been very lucky, because last year, a year and a half back, we don't do this. I got a patient from a colleague of mine, I don't want to name. So they didn't do it, but inadvertently or temptingly, at the time of the OPU or before the OPU, we really don't know the notes. But
that was transvaginally. That is the problem. Whenever do it transvaginally, that can cause ovarian abscess. And that's why I have seen ovarian abscess following transvaginal aspiration quite a lot. But that's why you are planning abdominal route under ultrasound guidance.
As a matter of fact, but that's what we are really doing by laparoscopy. We are also sucking it out in many cases.
Exactly.
should work.
So I think the thought of Dr. Chatterjee is to avoid putting in a scope, which may be a thought. And
Yeah,
maybe
that
I
is
think
the
it is
thing.
worth
Because
a
we want to
publication.
less
It would be
invasive.
worth a
We want-
publication if you could give us, because
we have already
I didn't come
published
across.
a small number, but we are waiting for a large number to publish.
So I have no
And in
experience on that. I have not done it.
we have
I've not done it.
achieved 2 normal pregnancies as well. But unfortunately, both of them aborted. Anyway, let us proceed to the next. Any other question, any other point of discussion? So next speaker, please.
Okay, thank you, sir. Thank you, madam. Thank you, Neena, madam. The next will be a recorded one, and was Dr. Sadhna Desai. Sadhna Desai. Atul, can you please play the recorded video audio? Thank you.
Friends, before I begin my talk, I would like to thank Dr. Gautam Kastagir and Dr. Ratna Chattopadhyay for inviting me to participate in this conference. I am going to speak today on impact of adenomyosis on ART outcome. As you all know, adenomyosis is a benign but poorly characterized gynecological disorder. It is histologically defined by presence of endometrial glands and stroma present within the uterine myometrium with reactive hyperplasia of surrounding smooth muscles. In the past, the diagnosis of adenomyosis was made at the time of hysterectomy by histopathological examination, and it was mainly associated with multiparicity. However, in recently, because of the availability of high intensity imaging procedures like MRI and 3D sonography, we are finding more and more cases of adenomyosis in infertile women, and its prevalence is thought to be between 7 to 27%. Adenomyosis is also associated sometimes with mild estrogen-dependent benign disorders like endometriosis in 80% of the patient, myoma in 50%, and endometrial hyperplasia is present in 35% of the cases of adenomyosis. The adenomyosis is a heterogeneous condition, and different configuration in the myometrium are described. However, we normally describe adenomyosis either as a diffuse adenomyosis, where the uterus is uniformly enlarged, or focal adenomyosis, which is more seen with endometriosis, and it is also called as adenomyosis involving outer myometrium. So adenomyosis, which is diffuse, is also called as adenomyosis involving the inner myometrium. Now, depending upon the severity of adenomyosis, it is found that the ART outcomes vary. Unfortunately, there is no uniform consensus on what is severe endometriosis and what are the criteria for mild endometriosis. However, ultrasound is a commonly used procedure to make a diagnosis of adenomyosis, and there are 7 features which may be present in the myometrium which could make a diagnosis of adenomyosis, and depending upon the number of the features present in a patient, we grade the adenomyosis by saying it is grade number 1, 2, or 7 scores are given. These are the endometrial strias, asymmetric thickening, myometrial cyst, parallel shadowing, adenomyoma, irregular endomyometrial junction, and endometrial islands. So now, what is this? What is the impact of adenomyosis on ART outcome? Now, when you look at the literature, sir, there are many papers on adenomyosis and its impact on ART. But there are only 4 good systemic reviews and meta-analysis of various studies, and 1 prospective study of 3 years, which is worth quoting because they have studied are on effect of adenomyosis on reproductive outcome as well as pregnancy outcome in women undergoing IVF-ICSI treatment, and compared it to women without adenomyosis undergoing IVF-ICSI treatment, considering the age, BMI, and AMH levels in both the groups, because it will vary otherwise. Now, all these studies show that adenomyosis has a poor impact on the reproductive outcome when the patient undergoes IVF-ET treatment. The women, it is shown that there is decrease in the implantation rate, decrease in the pregnancy rate, increase in the miscarriage rate. And all these studies show that by giving GnRH agonist prior to IVF-ICSI treatment, the success rate or the pregnancy rate improves. So what I want to say that although diagnosis of adenomyosis is easily made by ultrasonography, yet many a times the diagnosis is overlooked when planning an ART treatment by many IVF specialists. And therefore, attention to rule out adenomyosis should be made, especially in women with unexplained infertility and women with repeated implantation failure when they are undergoing IVF treatment. Now let us see what all these studies say. What are the factors which affect the outcome on the adenomyosis, how it affects. First is, it is found that in a study in 2017 by Dimitros found that there were about 375 women who underwent IVF-ET treatment. 72 had adenomyosis. Now those women had a score of 4. Their pregnancy rate compared to no adenomyosis group was 22.9% against 42.7%. But those women who had severe adenomyosis with adenomyotic score of 7, the success rate was only 13%. So it depends upon the severity of the disease. There is one study carried out Mobon in 2012 who studied the impact of junctional zone thickness in women with adenomyosis with ART outcome. And they did MRI to measure this junctional zone thickness. And they found that increasing in the junctional zone caused implantation failure, and therefore it adversely affects the implantation depending upon the thickness of the endometrial myometrial junction. And if it is more than 7 millimeter, it affects the pregnancy rate. It is also found that diffuse adenomyosis has poorer outcome than focal or local adenomyosis. And local adenomyosis can also be treated surgically prior to ART. The last study, which was published recently this year in IBM Online, these workers compared the uterine volume in adenomyosis women and the result in ART outcome. And there were 158 women on whose adenomyosis patients volume they measured, and they found that when the adenomyotic women had larger uterine volume, there was lower birth rate and higher incidence of miscarriage rate. And therefore, it was suggested by the authors that one should reduce the uterine volume before re-embarking FET in the patients. There is also studied large systemic review and meta-analysis of pregnancy outcome and neonatal outcome in patients with adenomyosis when they fall pregnant with ART. And they found there is increase in preterm birth, increase in preeclampsia, increase in fetal malpresentation, placental malpresentation, small for gestational age baby and low birth babies can be found. There is increased incidence of PPH and of course increased incidence of cesarean section. So how does this happen? Why does adenomyosis affects the fertility of the woman? There are two reasons. There may be abnormal uterotubal gamete and embryo transport. This may be because of the enlarged uterus and distorted endometrial cavity. There may be hyperactivity of the myometrium and irregular contraction. And there may be thickness of endometrial myometrial junction due to the hyperperistalsis of the myometrial tissue. But more important than that, it is felt that the ART outcomes are affected by adenomyosis because of disruption of endometrial function and its receptivity. There may be progesterone resistance or decrease in progesterone receptor. There is impaired deciduation, molecular and immunological changes can occur, and there may be chronic inflammatory cellular changes in the ectopic endometrium in the uterus. A study has been carried out in 2011 by Martinez to find out whether adenomyosis is only affects the uterine factor or does it also affect the oocyte and embryo quality. For that, they chose the oocyte recipients and found out the effect of adenomyosis in oocyte recipients who had adenomyosis. When they underwent treatment, they found this, not only the pregnancy rate was less, but there was twofold increase in the miscarriage rate in the recipient, suggesting that it is the uterine factor because the oocyte donors were young patients and the embryo quality was good. So it is mainly the uterus which causes implantation failure. In 2020, in RBM Online, a paper was published which assessed the outcomes of the ART when different protocols were used in women undergoing IVF-ET treatment. And the total 841 women had adenomyosis, against which 2,190 women had no adenomyosis, and they compared the different protocols. So those patients who had short protocol or GnRH antagonist protocol, these patients showed decrease in the clinical pregnancy rate and increase in miscarriage rate in when there was a short protocol compared to the control group. When the ultra-long protocol group was compared with the control group, there was no difference in the clinical pregnancy rate. Similarly, when a long protocol was used, there was no difference in the clinical pregnancy rate, but these women had higher miscarriage rate. So it appears that once one uses ultra-long protocol for the ovarian stimulation in women with adenomyosis undergoing ART, the success rate seems to be good. However, there was one point that the authors found, that those women who were control group and had received ultra-long protocol, these women had prolonged ovarian suppression. So number of oocytes retrieved was less in the control group receiving ultra-long protocol, and the cost was also more compared to the short protocol. So it was thought that maybe when you use ultra-long protocol in women with adenomyosis who have poor ovarian reserve, maybe the success rate may go down. So now, because the availability of the better freezing protocol, it is maybe possible not to do this protocol, but to use a segmental protocol. However, if one is using ultra-long protocol, it is suggested to choose LH containing gonadotropins like HMG or to add RLH to counteract the adverse effect of low LH on ovarian response, because in ultra-long protocol, the LH levels of the pituitary may get very much suppressed, and that may affect the ovarian response to the stimulation with FSH. So it is now recommended that it's better, instead of giving the GnRH ultra-long protocol prior to the ovum pickup, if we freeze the embryo after the ovum pickup and then administer long protocol, 2 to 7 months of GnRH agonist prior to FET, it may temporarily inactivate the adenomyosis, reduce the uterine volume, restore the distorted endometrial function, and cause improvement in pregnancy rate. There are 2 articles published today in literature because this is a new concept, and both these articles say that the clinical pregnancy rate and implantation rates are significantly higher in women pre-treated with GnRH agonists prior to FET. So this is what we are nowadays following for our patient, and I would like to present my 3 cases. We were difficult cases of adenomyosis, and I had the challenge to treat them and make them pregnant. The first case was a 27-year-old girl with history of 3 miscarriages. When she presented to me her uterus on a clinical examination, looked as if she was 28 weeks pregnant. It was that large. And she was told that she will never be able to become a mother at all because of such enlargement of the uterus. After proper counseling, I decided to do ART on her. I used long modified GnRH agonist protocol, took out the eggs, fertilized and froze them, and gave her 4 cycles of GnRH agonist depot preparation, and till her uterus shrunk to about 15 weeks of pregnancy size. So it became about 10 centimeter into 6.1 centimeter. And then I did the embryo transfer. Patient conceived, had twins pregnancy. Patient was taken up for elective cesarean section at 37 weeks because of the fetal malpresentation. Following cesarean section, patient had torrential postpartum hemorrhage. We had to give her 6 packed cell units of blood and 4 fresh frozen plasma. She was put in ICU for several days in a critical condition. So when she went home with her babies, I told her never ever to become pregnant again. However, when the patient was in her lactational amenorrhea, she became pregnant spontaneously. And she never realized, because her uterus was always up to 28 weeks in size, she never realized she was pregnant till she was 7 months pregnant. Then I had no choice but to continue the pregnancy. So at 38 weeks, I took signature for the hysterectomy, consent for hysterectomy, kept an ICU bed for her, made preparation for a lot of blood, and did a cesarean. This time patient had absolutely uneventful postpartum period. She had no bleeding, normal bleeding, and she just went home on 5th day. So it just doesn't explain that every time she would get a postpartum hemorrhage. The second case was a 28-year-old medical doctor. She was married for 1.5 years and she had severe menorrhagia and dysmenorrhea. So sonographically said that she had a myoma in the uterus. So she went to an endoscopic surgeon and got her laparoscopy done. And during laparoscopy, it was found that it was globular irregular adenomyosis infiltrating and associated infiltrating endometriosis, obliterating the pouch of Douglas completely, and the rectum was adherent to the back of the uterus. So the surgery was abandoned. Since the tubes were patent, the 1 or 2 cycles of fertility tablets with IUI was planned, but patient failed to rupture the follicle because of adhesions. She was taken for IVF. Long modified GnRH agonist protocol was given to her. The embryos were frozen and 3 doses of GnRH agonist depot preparations were given and the embryo were transferred. Patient conceived, but she had a miscarriage. Excuse me. So then we again gave her, this time, 4 doses of GnRH agonist depot preparation and transferred her balanced embryo. Patient went to full term and we had a cesarean section at 38 weeks. The third case was most challenging case. She was a 32-year-old woman with 3 IVF failures, came to me for the 4th IVF attempt. Patient had history of laparotomy done for diagnosis of myomatous uterus, and on laparotomy, the gynecologist found that she had adenomyosis, which was having severe adhesions, posterior adenomyoma she had, which was adherent posteriorly to the back of the rectum, and the pouch of Douglas was the adherent to it, and it was not possible to excise this fibroadenoma. So the operation was abandoned. Patient had severe dysmenorrhea and she was very uncomfortable. So this time she went to one of the eminent laparoscopic surgeon, and he decided to do adhesinolysis and remove the fibroadenoma. And in trying to do that, the bowel injury took place and he had to abandon the procedure. Thereafter, patient underwent 3 cycles of IVF, which didn't succeed. When she came to me, her uterus was clinically about 24 weeks in size. Her uterine volume was 391 cc, and the posterior wall adenomyoma, which was compressing endometrium, was 7.2 centimeter in diameter. So this time, after the freezing the embryos, we gave her 4 cycles of the depot preparation of GnRH agonist. However, patient couldn't come to Bombay. She was from out of station because of the COVID pandemic. So she took total 7 doses of GnRH depot preparation. And when she came to me, her uterus volume had reduced to 221 cc and her adenomyoma had reduced to 5.7 centimeter. I did the embryo transfer. For my luck, patient became pregnant, and recently she has delivered at 38 weeks a baby. So this is the picture of the last case. You can see how bad was the endometriosis. The endometrium can hardly be seen because of big fibroadenoma on the left side, and on the right side, after the GnRH depot preparation, how the size has reduced and has helped patient to become pregnant. So in conclusion, I would like to say that women with adenomyosis undergoing ART have lower pregnancy rate and higher miscarriage rate than women undergoing ART without adenomyosis. Adenomyosis is a very heterogeneous disorder with varying extent of lesions. and impact of adenomyosis on reproductive outcome is not always the same and depends on the degree of uterus involvement. Ovarian stimulation with short protocol for IVF ICSI has negative impact on and therefore an either ultra-long and GnRH agonist protocols improve the pregnancy rate, but not in women with poor ovarian reserve. It is suggested to administer ultra-long duration of GnRH agonist suppression prior to FET in order to improve the pregnancy rate. Thank you very much.
Thank you, Madam Sadhna Desai, for a brilliant lecture on adenomyosis. And you have definitely elaborated all the aspects of adenomyosis. So I would think if anybody wants to comment on it, but I think there is no scope to comment on the pioneer in this field of this country, Dr. Sadhna Desai. Thank you.
Thank you, madam. Thank you. So we can proceed to our next speaker, Dr. Sweta Mittal. Hello.
Yeah. Can I share my screen?
Yes, ma'am.
Thank you very much, Ace, for inviting me. And after hearing a brilliant talk from Dr. Sadhna ma'am, we all know that adenomyosis is very tricky, very difficult, and puts us in a lot of difficult decision makings, especially when it comes to surgery. So if we look at the incidence of adenomyosis in about infertile couple, we are looking at about 22% incidence in women less than 40 years undergoing ART. The proposed mechanisms we just very quickly are disturbed peristalsis, sperm transport, altered endometrial receptivity, hypervascularization, impaired implantation, and altered decidualization. So at every level, there is a negative impact what adenomyosis is doing. 30% of women would be clinically asymptomatic, 50% would appear with abnormal uterine bleeding, 30% with dysmenorrhea, menorrhagia, dyspareunia, chronic pelvic pain. And in my clinical practice, of course, I see most of them because they will be landing up with infertility to me. The uterus is globular, it is enlarged antero-posterior, the uterine movements could be very tender, and it could be more than twice the normal size. And we know that we have seen uteruses which just Dr. Sadhna ma'am mentioned was about 28 weeks and 24 weeks. And we absolutely kind of give up on them. And we've seen that, yes, sometimes these women can dramatically, become pregnant and bring a successful outcome. So what is important is the moment we are thinking, because I'm only concentrating from the point of view of surgery, that it is very important to define that are we dealing with focal adenomyosis, which is covering, just less than 25% of the circumference of the lesion, diffuse, which is, surrounded by a normal myometrium, or we are dealing with adenomyoma. Sometimes, yes, it has been occasions in everyone's clinical practice that we started operating on a lesion thinking it is a fibroid, and it turns out to be an adenomyoma. And then we also have seen cystic adenomyomas where there are myometrial cysts, and there could be large cystic adenomyomas of more than 10 centimeters, which have also been reported. Very recently, we operated on a patient with very, very large cystic myomas. And in today's scenario, cystic adenomyomas should always be distinguished from ACUM also, because it is a known entity and more not very common, but yes, we are encountering them. And then last is the non-cystic. So sometimes I think 2D and 3D ultrasounds are very good parameters for us to diagnose adenomyosis, and sometimes help of MRI is required because giving the decision to operate on a patient is very important. So if you see picture D and picture E, they are the ones who are really causing a lot of havoc. And picture H, yes, on hysteroscopically you will see it's like a submucous myoma, but it turns out to be a submucous adenomyoma. So rest of the other pictures, I would say that more or less we would not be operating upon them, and we would be more so depending upon the medical management. So this whole decision between medical and surgical management, as we saw in the last presentation, that patient can go through severe surgical complications, and sometimes giving a long GnRH agonist depot does wonderfully. And yes, as a primary step, especially in infertility, we do resort to possibly doing an IVF or ART and then giving them prolonged down regulation. But there are situations very recently, about 10 days back, where the girl just refused to go through any medical management. She said, I cannot go through ART and I want surgery because this pain is creating a havoc in my life. And also sometimes to make the uterus surgically better, to improve the implantation, it is very important to offer surgery. So once you've decided for surgery, of course, the role of surgery remains quite controversial because the diagnosis was retrospective. You need a good patient selection. The borders are not defined. So that is the most important thing, that complete excision, no matter theoretically how much we see, it becomes very difficult. So to counsel the patient that the excision will happen because we need to preserve the uterus as much as possible for fertility is important. And this excision can never be complete. You may land up, taking out a part of myometrium where you are causing more destruction. So in diffuse adenomyosis, complete removal versus preserving normal uterine contour is difficult. It is a very high risk into entering the cavity. Sometimes adenomyosis will not just come as a piece of cake, but it will be associated with extensive bowel adhesions. So you need to take consent, even up to the consent of colostomy, if you think, or if she's had a previous history of laparotomy or laparoscopy showing stage 4 endometriosis with dense bowel adhesion. So it is very important, and you will have to have a multidisciplinary approach or teams. So you might need even a laparoscopic surgeon with you when you're operating. It's not like myoma where you can easily suture because you get a gritty sensation. So sometimes getting both the layers together is difficult. It cut throughs. And then, of course, the post-op complications of pelvic adhesions or intrauterine adhesions are also high. And then the high risk of uterine rupture during pregnancy or labor. But of course, in such cases, everyone prefers a planned cesarean section. So if you're talking of uterine sparing surgeries, the best would be if you can completely excise. It is more common in adenomyomas, but most of the times you will end up doing partial excision, but the best possible way you can do it. And then there are the non-excisional methods. So complete excision has been reported by a couple of authors, starting from the classical technique, and then you have the U-shaped suturing, the overlapping methods, how we would do it in Bonnie's myomectomy, the triple flap technique, the classic technique, the transverse H incision, wedge resection of uterus, and asymmetric dissection. So just going through few important ones. The classical technique, where you have a longitudinal incision on the uterine wall along the adenomyoma. You do a sharp and blunt dissection of the lesion with scissors or graspers or a diathermy in a similar manner how you're removing a fibroid, and then you suture the uterine wall in a seromuscular layer, 2 or more layers, suturing the endometrial cavity with the absorbable suture. Or what we do is that we do not suture the endometrial cavity, and we just go a little bit above the endometrial cavity, so that the cavity is approximated, and the sutures, they come the same way how you would suture a fibroid uterus which is entering into the cavity. So this is a very good excision, I would say. If you have an isolated adenomyoma, you would be very happy doing this surgery because it would be a complete surgery. In an overlapping technique, transverse incision is made in the adenomyotic tissue, and you actually undermine the lesion, and it is excised with monopolar needle, but with better energy sources like harmonic. I think most of us resort to that. Then again, the remaining seromuscular layers are overlapped and sutured to counteract the lost muscle layer of the uterus. So it's exactly like how a Bonnie's flap would have looked, that you're pulling out the serosal layer. But most of the times, technically these can be very impressive theoretically, but practically they may not be possible. Very commonly we see the Osada's technique where initially he mentioned the laparotomy technique. You are extra peritonealizing the uterus. You are bisecting the uterus in the midline with the scalpel, completely opening it up. You're going up to the cavity. You are putting an index finger in the cavity so that you can remove the adenomyotic tissue above the cavity, and you are keeping a layer below the myometrial layer, below the serosal layer. So you are leaving myometrial layer above the endometrium and a myometrial layer below the serosal layer, and then you are suturing it with couple of sutures. So this is how the excision would be, and then the whole, and there were multiple sutures which were used, multiple interrupted sutures, and then the serosal layer is done. So this is how the exteriorizing of the uterine, the adenomyosis part would be seen when we are talking of Osada's technique. So what Osada's, it was a landmark paper where they suggested that what was the surgical procedure when they suggested to adenomyotic uterus. It was a prospective study with a sample size of 104, where they said a radical excision method by triple flap method. The recurrence rate was only 3.8% over 10 years. And if we can see, spontaneous pregnancies were 4, IVF pregnancies were 12, and out of which 14 went through elective cesarean section. But what was very impressive was the pain relief and the quality of life at the end of 24 months what they had. So there was a dramatic reduction in symptoms, more than half conceived, but there was no rupture and reported, and there were term deliveries in their group. I think what most commonly we all practice are the partial excision, the type 2, which is excision of a diffuse adenomyosis. Either you take a vertical or a transverse incision. So if you're taking a vertical, you invariably would be, going from the middle, from anterior to posterior, unless it's a completely posterior adenomyoma. The clamps would be applied to the edges. And what you need to do is you will inspect the uterine wall and you will look for non-microscopic adenomyotic lesions. Very typically, you will have a hard feeling, a trabecular pattern, what would be seen. And if adenomyosis is extended to the contralateral wall of the uterus, then you will extend the incision. And so it is complete anteroposterior. So you can imagine it is even bigger than a classical cesarean section, what we are doing. So your whole issue, or if you're bothered that how they will do when they are pregnant, yes, is very valid. And then most important is that do not leave any dead spaces. Do not let any blood pockets be formed, and suture them in 2 or 3 layers, depending on what is the depth of, excision, what you have done. So edge technique, I will just straight away go to the picture part. Clinically or practically, I have not been doing the edge-shaped incision. Most of my adenomyosis excisions are more or less anterolateral incisions and trying to undermining below the serosa and a bit of a myometrial layer and trying to excise the maximum possible what we can. But here, 2 transverse incisions are given at the end of the vertical incision. So possibly you get more space to excise. And this is what happens. And at the end of the surgery, you are suturing the transverse incision as well as the vertical incision. So transverse incision on both the sides. And this possibly can give you a bigger area to remove a larger chunk of adenomyosis. The asymmetric method is just asymmetrically incising the uterus longitudinally with a surgical knife. The myometrium is dissected diagonally. It's as if you are hollowing up the cavity. With a transverse incision, the cavity is then open. Again, like Osada's technique, the index finger is inserted into the cavity and you try to remove as much as possible the adenomyotic lesion. And this is how this will look like. This is the Nishida's technique. So these were just the non-excisional techniques which have been mentioned, that instead of going for that, you can think of uterine artery ligation, electrocoagulation of myometrium, high frequency USG, and radio frequency ablation. Well, I do not have clinical experience in the last 3. So if we are comparing laparoscopy versus laparotomy, laparoscopic surgeons will always say that we can do every surgery, under the sky with laparoscopy. Good advantages of laparoscopy. I don't remember, yes, that of lately in the last 1 decade, we have done these surgeries by laparotomy. But if there is a very large focal and diffuse adenomyosis and technical difficulty, then yes, laparotomy can be done for better excision and suturing. Laparoscopy will be we would really need a great expertise. Number one, only laparoscopic surgeons doing level 3 and 4 surgery should attempt adenomyosis surgeries. People who are into level 1 and 2 should not go about operating, because you will land up abandoning this procedure and creating more complications. So this is important. The second shortcoming of laparoscopy is that you cannot palpate the lesion. So the feel of the uterus is not there. You are completely dependent upon the visual picture of that uterus. But advantages are cosmetically better, less operative stress, less post-operative morbidity, less post-operative adhesions, less bleeding as we use powered instruments. So overall, in today's scenario, I think laparoscopy will fare more over laparotomy. The uterine rupture risk is a very, very important risk. So Morimatsu in 2007 suggested that it is to the tune of 6%. However, the overall Osada's group said that it is more than 1% in adenomyosis, vis-a-vis 0.26% in pregnancies following myomectomy. Nishida reported 5 cases of uterine ruptures in 2016. They've performed about 1,349 cases of adenomyomectomy, but uterine rupture was only 2.3% per pregnancy. But they were the cases where uterine cavity was opened. And in 2015, Kodama reported 71 laparoscopic adenomyomectomies, including 1 case of uterine rupture. So in their 1 case, 7.1% was the incidence of uterine rupture. So why there would be more rupture after a surgical intervention? If you have used too much of electrical power, too much of muscle defect, the method of reconstruction was not well, post-op wound infection or hematoma. This is very, very important. The period of conception prior to post-op, pregnancy is important. So now if these patients you are dealing with borderline ovarian reserve, it is better to do an ART, freeze their embryos, and then go ahead with good surgical excision and giving them a gap of about 6 months, and then of course the skill of the surgeon. So complications of adenomyomectomy, I've said uterine rupture in pregnancy, higher incidence of placenta accreta and percreta, and risk of Asherman's syndrome. So this is what most of the times we land up doing. So after releasing the adhesions, we know it's a globular uterus and it was about a 6 centimeters, diffuse adenomyosis. So all of us would give a vasopressin. So once the vasopressin is injected like any other myomectomy case, and then an incision vertical was taken. So I just wanted to show that most of the times the picture will not be very rosy and clean. It will be a piecemeal excision. So in this case, an incision was given from anterior to posterior at full posterior aspect because it was a diffuse adenomyosis, and as much as possible the tissue needs to be removed. That is important. So I think you can use scissors or you can use harmonic. So what we're trying to do here is like a baseball suturing was done, and she's absolutely in a recent post-op period. She just came for suture removal a couple of days back. So what is important is that once the suturing is done, inspect the uterus, and you can also put some adhesion barriers, whatever you like or whatever you have been doing. And this is how after suturing the cavity will look. So most of the times it would be some kind of a partial excision, because you need to maintain the integrity of uterus, and you also need to maintain the myometrial integrity she has to go through pregnancy later on. So just coming to the last part, that surgery is sometimes required for women prior to IVF. The indication is if there is a well-defined adenomyoma more than 5 centimeter, she's going through recurrent miscarriages which are not explained for any other reasons, or she has recurrent implantation failure after IVF. So who will be benefiting? This was a retrospective study which where 102 infertile women underwent laparoscopic adenomyomectomy. The clinical pregnancy rate of women less than 39 years of age was 41%, and more than 39 years was 3.7%. So miscarriage rate was 5 on 6 in the advanced maternal age group. 60% of women less than 39 years with history of prior IVF failure conceived with IVF after surgery. Posterior wall involvement had negative impact on embryo implantation, and 2 patients had placenta accreta and preterm labor, but no cases of uterine rupture. So beneficial effect of surgery on previous IVF failures and age less than 39 years is more so seen. And then you have combined medical and surgical. I'm not discussing this. Dr. Sadhna ma'am already said that we can use agonist. But coming to surgery, the advantage of giving agonist is that you would be reducing the size of the uterus and vascularity. But the disadvantage is, like very recently, I was giving Dynogest to a girl who has adenomyosis. The husband is not ready to go through ART and wants surgery. And very recently, I saw that the size of the adenomyosis has reduced so much. So now I have told her to withhold the drug because excising the lesion would be very, very difficult in the present scenario. So this is the last slide. This is the management algorithm when we are talking of surgery, adenomyosis and infertility. You can give agonist, you can go for urgent IVF, you can do an agonist pre-treatment, or you can do a surgery followed by agonist pre-treatment before doing an IVF and frozen embryo transfer. Thank you so much for patient hearing.
Thank you, Shweta ma'am. Thanks a lot. It was indeed a very informative lecture and presentation. So if anybody has any question, they can ask. Hello?
There is no question in chat box, so we are short of time. Can we move on to the next session, ma'am?
Yeah. Thank you very much.
Thanks a lot. Thanks, everybody.
Excellent. Excellent.
Thank you, Siddhartha sir. Thank you, Viman sir. Thank you. Thanks a lot. So our next session will be on male infertility, and the chairpersons are Dr. S.S. Vasan and Mr. Niladitya Sanyal. Can I have the CV of them, please? Atul, again, the CVs are not readable over here. Can you please help me?
Dr. S.S. Vasan, uroendocrinologist, MBBS, DNB, surgery, DNB, urology, fellowship in andrology and incontinence, Singapore. And the next chairperson is Dr. Niladitya Sanyal, MSc, University of Sheffield, UK, MPhil, WVUHS, stem cells and regenerative medicine. So over to you, chairpersons. Please unmute yourself.
Yeah, good evening and thank you very much for this introduction. I think we have 3 exciting lectures, and I'm sure post this we will hear the 3 lecturers debating on 3 important and crucial aspects of male infertility management. And I will allow Dr. Niladitya Sanyal to introduce all 3 of them and take this forward. Thank you very much.
Thank you. Can I have the first slide for the speaker, please?
My video has been stopped by the co-host. Would you please open the video? Professor Maji, I am telling, my video has been stopped by the host. Will you open?
Check now. I have started.
Yes.
Yes, can be seen. Right. So the first talk is by Professor Arup Kumar Maji. He is the professor and head of the Department of Obstetrics and Gynecology at RG Kaur Medical College in Calcutta. He is an author. One second, it's not very legible, this slide. author besides clinics in obstetrics and beside clinics in gynecology, in charge and principal investigator ICMR and HRRCR RG Medical College and Hospital, President-elect ISO PRB for the year 2023-2024, immediate past President Kolkata chapter of the same, Vice President of Indian Society of Perinatology and Reproductive Biology, President of Bengal Obstetrics and Gynecology Society. He has 28 years of teaching experience in both UG, PG, and DNB courses, and has multiple publications ranging in about 90 to 100 publications. So, sir, the stage is yours.
Will I share my screen?
Yes,
Yes,
please. Share the
please.
screen.
Is it visible, my screen?
Yes,
Yes,
sir.
sir. Please do slideshow and start.
Yes, it's visible.
First of all, I am very grateful to the organizer for giving me very important topics and very difficult topics of the endocrinology of the male reproduction. Because till the day the endocrinology of the male reproduction knowledge is limited, and the management of the male compatibility in restricted to the gamete, handling of the gamete, and also the male contraception. There is no such hormonal contraceptive like the female, which is very fruitful in case of male partner. Endocrinal control of the spermatogenesis is not so clear like that of the oogenesis. It is evident from the fact that medical induction of ovulation is a successful therapeutic option, so is female contraception also. Whereas the medical induction of the spermatogenesis and male contraception using hormone are not, and the medical induction is not so useful for the spermatogenesis, and also the male contraception is still not in the market in the hormonal pill like female. Now, like the estradiol in female, the testosterone is the master hormone. Whatever may be, it is true that testosterone is the master hormone which control the whole of the spermatogenesis, and it is responsible for the spermatogenesis and also the maintenance of the libido, maintenance of the male secondary sexual character and the masculine character. Now, before going to the endocrinology proper, I will just review here on the anatomy and physiology of the spermatogenesis. All of you will know the sperm is actually produced in the seminiferous tubules. It goes through the retitestis to the epididymis and to the vas, and from the vas it goes. There is seminal vesicle mixed with the secretion of the phenytoin, and seminal vesicle composition is actually from the main part of the semen. From the ejaculatory duct, it goes through the male urethra. So this is the basic anatomy and physiology. Main part of the semen is actually comes from the accessory glands, like the ejaculatory in the seminal vesicle, and also the prostate secretion and the bulbo urethra. Now coming to the structure cross-section of the testis, you will see testis has two distinct components: the seminiferous tubules and the Leydig cells. And Leydig cells lie in the connective tissue outside the seminiferous tubule, and Leydig cell is the source of the testosterone. So Leydig cell has to testosterone has to go inside that testis seminiferous fluid, but there is a little vasculature and blood vessels inside the testis. Mainly it has to depend on the diffusion mechanism. During embryogenesis, there is approximately 3 lakhs of spermatogonia in each gonad after migration of the germ cells to the genital disc. By puberty, the number becomes 600 million mitosis, and in adult life, there is production of the 100 to 200 million sperm each day, and more than 1 trillion in reproductive lifespan. And in contrast to the female, where the number of eggs are the limited, and 20 weeks of pregnancy, there is the maximum number of the oocyte. It is about the 6 to 7 million, or there is a arrest occurs in the prophagic diplotin stage, prophase 1 diplotin stage, and next there is the atrophic occurs, and usually the after the reproductive years, there is basically the no oocyte remains inside there. It is at the age of the menopause. But male have father children reportedly in age 90. That is the basic difference of the male and the female oogenesis and the spermatogenesis. Spermatozoa are produced from the primary germ cell situated in the wall of the seminiferous tubule through multiple steps. Stem cells form spermatogonia by the mitosis. Each diploid spermatogonia from primary oocyte, that is the diploid cells of the 46 by mitosis, from which two secondary spermatocytes are formed by phase 1 meiosis. Each secondary spermatocyte in turn by final meiosis produces two haploid spermatids containing 23 chromosomes. Large spermatid is matured in the compact spermatozoa, the process called the spermiogenesis, by which demonstration of the nucleus, a condensation of the nucleus, formation of the flagellum, and development of the acrosome occur. But these, behind these, the hormones has the main role. I am coming to the main topics. The new cohort of the spermatozoa goes into the mature spermatozoa every 16 days, and process of the spermatogenesis, that is from the spermatogonia to mature spermatozoa, takes about 64 days. And but total it is another 10 to 15 days, even more may occur for the maturity of the spermatozoa in the epididymis. The spermiation is the process through which the mature spermatozoa release into the lumen of the seminiferous tubule. After releasing into lumen, sperms enter into the epididymis, where more maturation takes place and acquire progressive motility during the 3 to 5 days, even more, reversing through tortuous structure of the or reaching to the vas. Final maturation or capacitation occur after ejaculation into the female genital tract. So this is the simple flow chart how the spermatozoa is formed, spermatogenesis, total spermatogenesis. And if you see the from the spermatogonia, the spermatocytes is formed. From one spermatocyte, two secondary spermatocytes is formed. So each secondary spermatocyte, the two spermatids is formed. And from the spermatid to the spermatozoa is the formed. And an interesting thing is that the gonadotropins, actually there is the gonadotropin, both gonadotropins has the FSH, probably it is initiates the spermatogenesis and maintains the spermatogenesis, and testosterone has main role throughout the spermatogenesis, and high level of the concentration of the testosterone is needed for the maturity of the spermatogenesis, even in the epididymis. But problem is that it has been found the serum testosterone is found in majority of the cases of the male spermatogenesis is normal. It is the problem in the testicular level. Their high testosterone level is needed, and probably there is a paracrine regulation we do not know. And hormones involved in the male reproductive male is the gonadotropin releasing hormone, which controls the pituitary to liberate the FSH and LH. And another important is the testosterone secreted by the Leydig cells, and another is the estradiol, because the estradiol and testosterone ratio is very important. And inhibin B, it controls it inhibits the follicular stimulating hormone. And prolactin, eupolactinemia in euthyroidism is for the normal spermatogenesis. If you see here, the hypothalamus, from the hypothalamus, there is the pulsating releasing of the gonadotropin, which in turn from the anterior pituitary releases the both FSH and LH. And FSH acts on the Sertoli cell. FSH acts on the Sertoli cell. Sertoli cell is equivalent to the granular cells of the female, and Sertoli cells produces the androgen binding globulin and the inhibin. Main inhibin is the inhibin B in case of male, and Leydig cell produces under control of the LH the testosterone. But Leydig cell lies outside the cell, So, and the Sertoli cell lies inside the cell, and the Leydig cell had to depend for the transport of the testosterone to the Sertoli cell, and Sertoli cell is under control of the FSH, and Leydig cell is under control of the LH. So both FSH and LH are needed for the spermatogenesis. These ABH androgen binding globulin by the action of the FSH from the Sertoli cell is combined with the testosterone. It carries the testosterone inside the lumen, but the terminal phase of the spermatogenesis occurs and the maturation of the spermatogenesis occurs. LH acts on the Leydig cell to synthesize testosterone. So this is the summary. The 5 to 10 milligram per day. Inhibin and androgen binding globulin are produced by the Sertoli cells which are under control of the FSH. FSH indirectly supports the activity of the LH by formation of the LH receptors on the Leydig cell. On the other hand, also the LH from the receptor of the androgen over the Sertoli cell, by which the androgen is carried by the androgen binding globulin inside the cell. Testosterone goes both into circulation and seminiferous tubules, and testosterone bind with the ABG to be carried to the luminal wall for spermatogenesis. Leydig cells lie outside the tubule, so testosterone can be carried from Leydig cell to inside the lumen at the site of the spermatogenesis, which is dependent on ABG production by Sertoli cell, which is under control of the FSH secretion. FSH is crucial for the initiation and maintenance of the spermatogenesis, and testosterone in high concentration is essential for major part of the spermatogenesis and maturation of the sperm, even in the epidermis. And inhibin B gives a negative feedback mechanism to FSH secretion and testosterone for LH secretion, both through the hypothalamus and pituitary lobes. If inhibin B, inhibin A is insignificant in male, I have already told. And hence both FSH are essential for the spermatogenesis for qualitative and quantitative sperm production. Besides, there are autocrine and the periodic regulatory mechanism involving the local growth factor, peptides, and so on. It should be emphasized that probably that is the autocrine and the periodic regulatory mechanism is very important for the spermatogenesis. The knowledge about which was lacking. And androgen deficiency in the aging male. If you go to the androgen deficiency in the aging male, it is not exactly like the female, because the female there is a menopause, while androgen and in male also the androgen symptom, but all men do not suffer from the andropause symptom. These are like the female, the decreased libido with or without erectile dysfunction, reduced strength, energy or stamina, depressed mood, insomnia, lower quality of life, lethargy, changes in the cognitive function, osteopenia, osteoporosis, central obesity, metabolic syndrome, diabetes, increased metabolic. These are all the andropause syndrome. But all men do not suffer from all the problems and the problem of the androgen stability. So, is there any role of the testosterone therapy in the female, the estrogen therapy in the postmenopause? And it has been Endocrine Society 2000 recommend that in absence of the pituitary or testicular disease, testosterone stability is restricted to the persistent low serum testosterone level, persistent, and if there is a really symptom, that testosterone can be given in the aging male. Now the clinical application, that is the important part, why we are studying about the male hormone reproduction. The two aspects of the clinical part important, or the management of the male fertility and development of the male hormonal contraceptive, these two area, and endocrinal causes of the male fertility causes, important causes are the hypogonadotropic hypogonadism, hypothyroidism, and hyperprolactinemia and diabetes. But if you go through the literature, you will see the endocrinal cause of the male fertility is very little less and in practice. But there are some cases, and if you can detect that, the management treatment is very successful. Now, what is about the hypothalamic pituitary disorder causing the male fertility? That is the gonadotropin releasing hormone or gonadotropin deficiency. One important thing is the idiopathic isolated gonadotropin deficiency and Coleman syndrome, and where the gonadotropin releasing hormone is indicated. And hypothalamic and the pituitary tumor, here more management is the treatment of the tumor, not the gonadotropin. And hyperprolactinemia, that is the hypogonadotropic hypogonadism. The hyperprolactinemia causes the hypogonadotropic hypogonadism and causes the defect in the spermatogenesis. Here, the main treatment is the prolactin, not the gonadotropin releasing hormone. Drugs, the maybe which is the iatrogenic drug cause the male susceptibility. The steroid, estrogen, gonadotropin releasing GnRH analogs, androgens, which may cause the male susceptibility acting to the hypothalamic pituitary disorder. Besides these, the critical illness of the injury, chronic illness, malnutrition, and infections, they all cause the hypogonadotropin. So the treatment is necessary in case of male susceptibility. Obesity is an important cause of the hypogonadotropin. As the weight increases, the male testosterone level becomes less as the weight increases. Pituitary tumor, the macroadenoma is the common in male androgen deficiency and the important, and it is found in clinical practice, and management is successful, it can be done successfully. Now, if you see the hormones in the different clinical situation in case of male susceptibility, you see the FSH becomes high when there is a azoospermia or oligospermia and small testis clinically on clinical semen analysis and also the examination of the testis. The diagnosis is the primary testicular failure, that is the severe tubular malaise. And when the FSH normal level, but there is a azoospermia, but normal testicular level, the number one diagnosis is the bilateral genital tract obstruction, and second is the Sertoli cell only syndrome, because Sertoli the ABG is produced, so he controls the FSH, that is the FSH become normal. But definitely there will be the androgen deficiency. And in case of hypogonadism, what will happen? There will be the lower or undetectable FSH or LH, and testosterone becomes low. Other evidences of the androgen is evident. And in case of androgen receptor defect, there will be LH is high because LH tries to liberate the testosterone more, so testosterone will be high. But testosterone cannot act properly and may not be converted into the testosterone, more testosterone due to the androgen receptor defect. Now, the principles of the medical management in case of male susceptibility. The unfortunate thing is that most infertile male are eugonadotropin, and but many have seminopathy. It is about 50% cases. No causes, not known why the semen and why the sperms are abnormal. And so, and if you want to give the long-term treatment is needed, because I have shown you for spermatogenesis to occur about 75 to 80 days, even 90 days may needed. So if to see the impact of the treatment which I have started today, you will have to see evaluate after 3 months. To get effect, you will have to wait at least for 3 months. And another important concern is about the HMG dose, the very frequent dose, HCG more frequent dose, and GnRH the dose that is the cumbersome for giving the continuous unit, about 1 to 2 years may be needed. That is practically is not possible, and efficacy is also not good. And if you, so what are the indications of the drug? Generally, HCG, HMG, it is absolutely hypogonadotropin, not for the pituitary tumor, not for the hyperprolactinemia. Thyroxine, there is the hypothyroidism, and also the bromocriptine and the cabergoline is a good result in case of hyperprolactinemia. It improves the prolactin level, sperm quality, and potency. And in hyperprolactinemia, what happens? Both vixen, the libido, there may be loss of libido and also the impairment of the spermatogenesis. And bromocriptine, if it is the hyperprolactinemia is the cause, the result is good. And aromatase inhibitor is indicated in high estradiol and testosterone level. But because what happens is actually when the testosterone is converted into the estradiol by the aromatase enzyme. So testosterone is becoming washed out, converted in the estradiol. So aromatase, the indications of the aromatase indication is the where the estradiol and testosterone is ratio is more. Now, what are the indications of the testosterone? It is in the in androgen deficiency, which is actually the clinically the cases number of cases less, and also the idiopathic male infertility. It has been tried the testosterone. Testosterone is done by two regime. One is the oral low dose. The conception is that it will increase the libido and increase the spermatogenesis. And injection testosterone high dose for short period, because the high dose will give the inhibitory action of hypothalamic action. So there will be the less production of the testosterone, and when it is withdrawal, there will be the rebound phenomenon may increase the endogenous testosterone and enhances the spermatogenesis. But in testosterone related seminopathy, I have already mentioned that it is thought that it is not the absolute deficiency of the testosterone. It is the defect of the utilization of the testosterone locally, that is the defective parotid ligation, which is responsible for impaired spermatogenesis. And in practice, in majority of the patient of the male fertility, male subfertility, the testosterone is almost normal, and no evidence that androgen therapy is effective in the idiopathic male infertility. Now, clomiphene is used for the long decades after decades. It is mainly used in the idiopathic male infertility, empirically used at 25 milligram once daily continuously up to 9 months. Many prefer to 5 days gap. Semen parameters are not improved, but it is said that pregnancy rate is claimed to be, there are many publications, the pregnancy rates claimed to be improved, and it acts by estrogen agonist and the partial antagonist. It increases the serum FSH level and testosterone level in male, but evidence of using the clomiphene cited is insufficient. And gonadotropin has been tried extensively in idiopathic seminopathy, but the result is not satisfactory. And HCG, it is the single drug that can be used, the HCG gonadotropin, but not the HMG. And HCG effective in adult onset hypogonadotrophic hyperemesis. It is given in a dose of 2000 5000 IU thrice daily for 6 to 12 months and may need up to 24 months. And treatment should start HCG alone. But HCG combined with HMG or pure FSH, it is given in case of congenital hypogonadotrophic hypotension, and also the adult onset not responding to the HCG alone. It is combined with the HMG or HCG 75 to 100 unit thrice weekly. It is less amount. Duration may be needed up to 6 to 12 months. Results of the exogenous FSH using directly is conflicting. GnRH is given in a hypogonadotrophic hypotension, not related with the hyperprolactinemia. Hypothalamic or pituitary is when
Sir, it's time up. Can you conclude now?
just this is the
Okay.
hormonal method of the male contraception. Various drugs have been tried for the male version because spermatogenesis is dependent on the gonadotropin, and the co-administration of the androgenes is needed for the deficiency of the androgen, for the loss of the digit. And hormones studied for the androgen alone, androgen and progesterone, estrogen and testosterone is the gonadotropin releasing hormone. And testosterone alone is not so useful because of the side effect, but it may be the androgen progesterone combination, the ideal male field, where progesterone component suppresses the pituitary gonadotropin release and androgen component maintains the libido and sexuality. Probably in future that will come in the market, the androgen progesterone component. So to conclude, of the whole of the endocrinal control of the spermatogenesis is not so clear like that of the oogenesis, and it is evident from the fact the medical induction of the ovulation is a successful therapeutic option, where the medical induction of the spermatogenesis is not so also in case of hormonal method of the contraception. Though gonadotropin is essential for spermatogenesis, probably it is the local parotid regulation has strong impact to the production of the to a good fertilizer spermatogenita, the knowledge about which is limited. More research is needed to know the parotid regulation of the spermatogenesis, and more research is needed to know about the endocrinal control of the spermatogenesis and role in the male soil. Thank you all. Thank you for your patient hearing. Thank you of the chairpersons, Dr. Niladri and Dr. Bhasan. Both are the very renowned persons. Thank you.
Thank you so much, sir. It was really insightful. And I guess we are running a little short of time. So can we take the questions at the end of the entire session? Can we have the next speaker, please? So our next speaker is Dr. Keshav Rokhit. He's a gynecologist and he's a member of FOXY, ISAR and BOGS. He's presented a lot of papers on reproductive physiology in international national conferences and journals. And his papers on male fertility has been widely acknowledged at Aspire 2016 at Indonesia, AIMS, Jodhpur, AIMS, Patna, and IPG MER, Kolkata. He's acquired his mastery on male fertility under the patronage of reputed scholars of IRM, Kolkata, and Boston University in the US. So, Dr. Rokhit, the stage is yours, sir.
Welcome delegates to the ACE 2021. I am Dr. Keshav Rokhit from Arjikar Medical College, Kolkata. Good afternoon. My today's topic is micronutrients in male infertility. Now, what are the incidents of the male infertility? It has been shown that the global infertility rate is 20%. Amongst which the male factor accounts for 48%, according to the European Association of Urology 2040. The micronutrients, which are essential for maintaining the health of the sperm, plays a major role for maintaining infertility. So these micronutrients, there are mainly two components. One is the vitamins and another one is the minerals. This is ACE 2021. So the vitamins are also ACE, that is vitamin A, vitamin C, and vitamin E. Minor contribution is by the methylcobalamin and the folic acid. Amongst minerals, there are two most important minerals which contribute to the maintaining the health of the spermatozoa, that is zinc and the selenium. Last but not the least, I must mention the contribution of other antioxidants, and they are arginine, lycopene, L-carnitine, coenzyme Q10, glutathione, N-acetylcysteine, and astaxanthin. Currently, there are two possible associations with male infertility. There is 30 to 80% of male infertility. It has been shown that there is a higher level of reactive oxygen species or ROS. And also in few other cases, it has been shown there are some errors in energy metabolism in mitochondria. Now, what is this reactive oxygen species or the ROS? ROS are highly reactive oxidizing agents. They are free radicals containing one or more unpaired electrons. It may be hydroxyl ion or the superoxide anion or nitric oxide or H2O2. Normally, healthy sperms produce ROS, which is essential for physiological functioning of sperms. But when it is produced in excessive amounts as generated by the abnormal sperms, sperm precursor cells, and the activated leukocytes, or it may be some systemic diseases like diabetes, varicocele, excessive smoking or alcohol consumption, or elevated temperatures and improper sperm preparation during ART procedures, it may produce excess ROS, and that is detrimental. Now, this high level of ROS causes oxidative damage to spermatozoa. It may affect the nucleus, the DNA of the nucleus, or the mitochondria, or the sperm plasma membrane. Now, how do you measure this ROS, the amount of damage it causes? So there must be some markers. They are the protein carbonyl or the MDA, that is malon dialdehyde, which measures the lipid peroxidation, or it may be the 8-hydroxy-2-deoxyguanosine, or which measures the amount of damage it causes to the DNA. Now, oxidative damages are lipid peroxidation of the sperm plasma membrane, resulting in defective fusion events and reduced motility. There may be some changes in mitochondrial membrane potential affecting the ATP production. Also, there may be nuclear DNA damage resulting in failed fertilization or abnormal fertilization. And last of all, there's programmed cell death or apoptosis. Now, as you can see in this picture, an healthy spermatozoa is maintained by ROS and antioxidants. They are like a common balance. Evenly balanced, they are helpful for the spermatozoa. But if the ROS is more, antioxidants are less, then it leads to oxidative stress, which is detrimental to the spermatozoa. It causes lipid peroxidation or DNA damage or apoptosis. Now, regarding our topic, micronutrients, that is the vitamins which are essential. First comes the vitamin A or retinol. It is a hormone-like growth factor with antioxidant properties. Mechanism of action currently unknown, but it improves the semen parameters. Next comes the vitamin C or the ascorbic acid. It has got some antioxidant properties. When vitamin C loses one electron, that is, it undergoes oxidation, it is very stable now. It allows to gain electrons from a more aggressive free radicals. And it gets reduced, but the recycling is done via the NADPH pathway or the glutathione pathway. Excess vitamin C is detrimental to the sperm. It breaks down the lipid cell membrane. It acts as a genotoxin, with causing the increased DNA damage. The recommended daily allowance is 75 milligram, but when it is more than 1 gram per day, it causes toxicity. As a high level of vitamin C has a pro-oxidant effect, it may lead to kidney stone formation. Doses 200 milligram per day. The sperm motility, morphology, and viability all significantly increased. But the average sperm count, though doubled, but it is not statistically significant. Vitamin C prevents DNA damage, protects the sperm plasma membrane from lipid peroxidation. It recycles vitamin E. Administration of vitamin C and vitamin E for 2 months. 200 milligram per day, it improves sperm count and motility significantly, as shown by Kodemo in the year 1997. And the recommended dose is up to 1000 milligram per day. Next comes vitamin E or the tocopherols. Of many, alpha tocopherol is very important for the healthy life of spermatozoa. It has got a chain-breaking antioxidant effect which prevents lipid peroxidation. Some pro-oxidant effect of alpha tocopherol has also been noted, but it is not that harmful. The RDA is 15 milligram. Now comes the toxicity. When it is 200 to 800 milligram per day, it causes gastrointestinal distress. When it is 800 to 1200 milligram per day, it causes antiplatelet effect with bleeding diathesis, thrombophlebitis, and gonadal dysfunction. Doses 200 milligram per day, it reduces the MDA level with 1 month's therapy, as shown by GEVA. With 300 milligram per day, it also reduces the MDA level in 6 months therapy. Along with that, it improves the sperm motility. This had been shown by Suleiman. Vitamin E protects the sperm plasma membrane by suppressing the lipid peroxidation. This has been shown by Aitken and Clarkson in the year 1989. Its inclusion during sperm cryopreservation, it preserves the sperm motility, shown by Askari in the year 1994. Its dose is up to 800 milligram per day. Now you can see in this slide, there are some studies with results which shows how the vitamin C and vitamin E acts and is helpful for the patient. Keskis, in his study in the 2003, showed 54 men, 3 months treatment. First group, vitamin E given 400 milligram per day, and along with that, selenium 225 microgram per day. And a second group, B vitamins were given. Only 20 patients completed the study. And in first group, there is reduction in the MDA, but an improved sperm motility, and second group, no change. Suleiman in the year 1996 showed in astenospermic males with normal female partner, first group vitamin E given, second group placebo given for 6 months. In the first group, there is reduction in the MDA level with sperm motility increased, with naturally then pregnancy rate also increased. Rolf in the year 99 shown that in 31 astenospermic male, first group high dose of vitamin C and E given and second group placebo given for 2 months, but there is no change in semen parameters. Greco in 2005 showed in 64 infertile male with more than 15% DNA fragmentation. First group 1 gram vitamin C and vitamin E given, second group placebo given for 2 months. There is no difference in sperm parameters. And in the first group, there is reduction in the DNA fragmentation. And after ICSI, it has been shown that there is an increased pregnancy rate. Minor contribution has also been caused by the methylcobalamin, which is important for cellular replication, that is DNA and RNA synthesis. And if deficient, there is reduction in the sperm count and motility. Also, folic acid has got a role in the RNA and DNA synthesis during spermatogenesis. It has got some antioxidant properties with special benefit in the tobacco users. But what are these drawbacks of these antioxidant trials? So many trials are going on, but what are the main drawbacks? That is the lack of appropriate inclusion criteria, lack of appropriate controls, and the insufficient sample size, as you have already seen. Now comes the minerals. Amongst them, zinc is very important. It is an essential micromineral. It is a metalloprotein cofactor for DNA binding with copper and zinc superoxide dismutase involved in the repair of damaged DNA. Zinc deficiency associated with hypogonadism, testicular and seminiferous tubular atrophy, and inadequate development of secondary sexual characters. Zinc levels generally lower in males with diminished sperm count and testosterone levels and compromise immune function. The dose is 200 milligram twice daily for 3 months in the astenospermic male, and it has been shown that there is increased sperm parameters with improvement in also the seminal antioxidant capacity. The RDA is 11 milligram per day. But toxicity causes when there is an excess zinc absorption more than 15 milligram per day, it may cause interfere with the copper and iron absorption, cholesterol metabolism, and anosmia. Zinc has got anti-apoptotic and antioxidant effect. It has a cofactor in more than 80 enzymes involved in DNA transcription and RNA translation. Along with folic acid, it has been shown by OMU in the year 2008 that it has significant improvement in sperm progressive motility, fertilizing capacity. And if there is deficiency in zinc, it leads to flagellar abnormality. The recommended dose is 24 to 500 milligram per day. Next comes selenium. It is an essential micronutrient and important antioxidant. It is a cofactor for reduction of antioxidant enzymes like glutathione peroxidase, GPX4. If there is deficient, it leads to instability of the meat piece, leading to defective motility. The RDA is 55 microgram per day, maximum 400 microgram per day. So if it is consumed for more than 400 microgram per day, it may lead to cirrhosis, pulmonary edema, and even death. Dose is 70 to 200 microgram per day. And RCT has been shown that 100 microgram per day, there is no change in sperm count, but there is improved sperm motility. Next comes arginine. It is a semi-essential amino acid with functioning in the cell division and wound healing with improved immune function, and also it has got some role in spermatogenesis. It has been shown by Simona that oral arginine 500 milligram per day for 6 to 8 weeks shows improved sperm count, motility. But these results are not obtained when the sperm count is less than 10 million per ml. The RDA is 1 to 15 gram per day. No consensus has yet been reached. And animal sources are dairy products, pork, beef, and veg sources, seeds, soybeans, and nuts. Next comes lycopene. It is a carotenoid antioxidant with highest ROS quenching activity. It plays an important role in cell growth regulation, gene expression, gap junction communication, and protection from lipid peroxidation. A daily dose of 4,000 microgram of lycopene per day, it reduces DNA oxidation by 75%, lipid peroxidation by 80%, and DNA fragmentation by 40%. It has been found in tomato and watermelons. L-carnitine, it is a main energetic substrate in the epididymis. It helps in maturation of spermatozoa. It actively participates in transportation of long-chain fatty acids into the mitochondrial matrix for beta oxidation. It has been shown in the next slide how carnitine shuttle helps in production of ATP. There is significant improvement in sperm concentration and motility when observed in idiopathic male infertility following 3 months oral therapy of levocarnitine with a dose of 3 gram per day. So the recommended dose is 1 to 3 gram per day. You can see in this picture that fatty acids, how from the cytoplasm, it goes through the intermembrane space via the enzyme carnitine translocase and then goes inside the mitochondrial matrix where by the beta oxidation, acetyl-CoA is formed, which via Krebs cycle leads to ATP generation. Next comes coenzyme Q10. It is a mitochondrial bioenergizer, antioxidant, prevents lipid peroxidation. It reduced form is known as ubiquinol. It is also a membrane stabilizer with maximum concentration in the midpiece. It is a regulator of mitochondrial permeability. Reduction in coenzyme Q level observed in idiopathic or varicocele-associated asthenospermia. Improvement in sperm kinetic features were observed by a placebo-controlled double-blind randomized trial. Recommended dose is up to 600 milligram per day. You can see in this picture coenzyme Q, especially the ubiquinol, how it removes the ROS, and also there is a ATP generation and how it is helpful for mitochondrial function. Next comes glutathione. It is an endogenous antioxidant released by epidermis, which neutralize the damaging effects of superoxide anions, thus preventing lipid peroxidation. 2 interesting studies were done by Lenzi in the year 1993. He has shown glutathione 600 microgram by intramuscular route on alternate day given for 2 months in 20 infertile males with oxidative stress, that is with past genitourinary infection or varicocele. He has shown there is no significant change in sperm count, but there is significant improvement in sperm motility and morphology. Next year, he continued the study in the year 94. He has shown there is improvement on all routine sperm parameters with significant reduction in sperm MDA concentration. Next comes N-acetylcysteine or NAC, which is a precursor to glutathione. Dose is 600 milligram per day, and it along with vitamin and mineral supplements when used for 3 months, it has got some conflicting results. As shown by Paradiso in the year 2008, there is increased sperm count, but SIFT-C in the year 2009 shown only there is some improvement in motility. Lastly, astaxanthin is a carotenoid extract from algae, which is a potent antioxidant with significant reduction in the seminal ROS levels and improves sperm motility. With all this knowledge, now we are a bit puzzled which one to use and which one not to use. But as rightly said by Agarwal in the year 2004, that the combination of all the antioxidants may be more useful in the treatment of idiopathic male infertility. This idea has also been shared some years later by the Cochrane review by Shoel et al. That there is improvement in pregnancy and childbirth rate following nutraceutical therapy. So, I am showing you there are various trials already done, but in this trial, I should mention Last one, that is the Benefit trial, where vitamin C, vitamin E, selenium, lycopene, folate, garlic oil, zinc, all has been used for 3 months. And it has been seen that there is an improvement in the IVF ICSI conceptions. With these active antioxidants, there is 38.5% rise in the pregnancy rate versus the 16% placebo. So, after all this hearing, I think the take-home message is the combination of the antioxidants is helpful for a good spermatozoa, for maintaining the healthful life of good spermatozoa. Thank you for the patient hearing and
So can we move on to the next speaker, Dr. Kedar Gangla?
Yes, please. So our next speaker is Dr. Gangla, and Dr. Gangla needs no introduction at all, to be honest.
So let's proceed, Nityanand.
Yeah.
Hello.
So yes, sir.
Sanyal, I
Please
think
go on, sir.
let's
Yeah.
start.
Yeah.
Okay.
Yes,
Okay.
please.
Okay. Thank you at the onset for inviting me for giving this talk on male infertility and ART. Presently, I am the Honorary Secretary of ISAR, and we know that the male infertility is caused by the local conditions like varicocele, genitourinary infection, trauma, infection, or lifestyle, which is coming up in a very big way. Pesticides, radiation, mobile usage, smoking, stress, systemic conditions like diabetes, cancer, medication can all affect. So lifestyle association has been associated with in a J-shaped form relationship, especially if tobacco and alcohol consumption can actually be kind of poisonous to the sperm. No, not to forget the obesity part of it, which causes decrease in the testosterone production and increase estrogen production and leading to hypogonadism. When you look at the patient, when you do a physical examination, you go on for the investigation with the semen analysis, WHO 2010. If required, DNA fragmentation and oxidative stress measurement, blood test as suggested by the first speaker. You do the blood test only when the sperm count is less than 5 million. Genetic test again less than 5 million. Radiological test if you want to rule out any other abnormalities in the pelvis. So you do a standardized laboratory. This word is very important, called standardization of the laboratory of 2010. And any abnormal report should not be treated immediately. At least you should have 2 reports 4 weeks apart, with minimum abstinence of 3 to 7 days. So when you start a treatment, you should take a call after 3 months. The one spermatogenetic cycle is of 63 days to 72 days. And from testes to outside world, it could be 12 to 21 days. We know the normal sperm count now has been taken as 15 millions with progressive motility of 32% and morphologically normal sperm as 4%. When the sperm count is more than 15 million, one is considered male is normal. With less than 15 million, go for hormonal evaluation. If the testosterone is less than 300, one needs evaluation. If the count is less than 5 million, go for hormonal evaluation, genetic evaluation, or the count is azoospermia, look at the fructose. If it's fructose positive, it's a non-obstructive azoospermia. If it's fructose negative, it's non-obstructive azoospermia. So these tests will tell you about the structure of the sperm, but will not tell the ability of a function of the sperm to fertilize the oocyte and to develop a normal growth. And hence, total motile sperm count, which includes the volume, the count, and percentage motility divided by 100. In this case, it is come 20 million. In a pre-wash sample, if the total motile sperm count is more than 5 million, you can give a trial of IUI. If it's 1 to 5 million, it's IVF. If it's less than 1 million, one should be taking the patient for ICSI. Genetic testing, less than 5 million count, patient with recurrent IVF ICSI failure, recurrent pregnancy loss, or family history of genetic abnormality. Sperm function test to be done only for patients to look at total external spermia to see the motility of the sperm, or DNA fragmentation in all patients with abnormal semen analysis or failed IVF for unexplained reasons. So, patient with advanced function for advanced sperm function test, repeated IVF failure, abortions, low fertilization rate, varicocele, diabetes, systemic disorders. So, hyposmolar test differentiate between the dead versus live sperm, and DNA fragmentation test helps you to identify which sperm is more potential to give a fertilization than the other one. And in a routine semen analysis, it is not possible to pick up the DNA fragmentation, and hence this less DNA or more DNA fragmented sperm may in an ICSI cycle do the fertilization, but the process of implantation or early abortion will increase. So if the DFI is more than 30, then it is a damaged sperm with a low fertility potential. Now let's look at the summary of the treatment which will help to reduce the sperm DNA fragment. Short abstinence, very good simple method. Oral antioxidant 66%. Swim up 33%. Look at testicular sperm. One of the best source is testicular sperm. So when you look at lifestyle, look at all these parameters, especially frequency of ejaculation, diabetes, psychological stress. Treatment options can be androgens if there is a hypogonadism. Otherwise, androgens have no role. If the count is less than 5 million, the FSH is normal. One can try treating with anti-estrogenic therapy or aromatase inhibitors or gonadotrophins. Surgical therapies can be microsurgical varicocelectomy, subinguinal approach is the best, or tubal or a vasovasal anastomosis in a patient with undergone a vasectomy will give the best results. The speaker just now told about the antioxidants and sperm vitalizers. So if you have a sperm with no DNA damage, fertilization failure will happen, or there will be an abnormal offspring. If you give antioxidant therapy, it will produce a normal offspring. So when you go for ART for male infertility, there was a paper talked about 118 patients with 34% sperms damage. They were told to ejaculate for 7 days with no lifestyle, no drugs. The abnormality from 34% fell down to 26%. 80% showed improved quantity. This is what I call as, in the tell my patient, is grandma's recipe for having regular pregnancy. So ejaculatory abstinence more than 2 days, IUI results are less because the time spent by the sperm in the reproductive system is less, and hence they don't get damaged very easily to ROS. So abstinence of less than 2 days is the best for conception. So count less than 5 million, you do medical surgical therapy, repeat semen analysis after 2 to 3 months. Wow, there is an improvement. You do a controlled ovarian hyperstimulation with gonadotrophin and try for 3 cycles of IUI. There is no improvement, go for IVF fixing. So most important thing is IUI is better than a natural intercourse. Gonadotrophin stimulation producing 2 to 3 follicles with IUI will give you better pregnancy rate. Swim up percent density gradient both produce same results. And the post-wash count should be at least about 0.8 million will give you some better chance of conception. The laboratory aspects are reduction in the abstinence, collection in the media. Just collect the sample just before the ICSI. Use sperm sorters to increase the ability to produce better sperm. For donor insemination, always remember counseling is required. Investigations are mandatory. HIV, HBCG, SC, VDRL every 6 months. Well-informed consent every time, and preserving those consent forms are very important. It is very important to retrieve the sample from the sperm bank rather than taking from any relative or a friend or from any other source. Semen cryopreservation, especially before chemoradiotherapy or a patient with secondary testicular failure, donor insemination program, or husband not being there at the time of treatment. So freezing is very important. ICSI should be done for total asthenospermia, testicular sperm, high DNA fragmented sperm, or pre-wash sperm count less than 5 million. The testicular sperm can be taken from either epididymis, that is from PISA, or testicular sperm from hydrolysis TISA. So if you're doing a PISA, you are likely to get sperms in about 50% as compared to micro dissection, the micro TISA, which can give an increased edge of getting more chances of sperms. So two approaches for azoospermia. The best is trial TISA. If you get sperm cryopreserve, then go for ICSI and then do again try TISA. Or the other one is going for TISA with OPU. Now what happens in this TISA, if you don't get the sperm, then OPU was unnecessary. So I always prefer the first method, which is the better method. Now success rate of in a non-obstructive azoospermia, testicular sperms are with micro TISA is far better than a single testicular biopsy. What is the role of pre-treatment of a patient with increasing testosterone by giving drugs like aromatase inhibitors or anti-estrogens? Well, it is always gives a good result when the testosterone levels are more than 100 nanograms from the baseline. Again, clinical pregnancy rate from testicular sperms are higher, miscarriage rates are lower, live birth rates are higher. These are the sperm sorters, the magnetic resonance sorter, the microfluidic chips, the one of the best thing which has come in the market now, or using a high magnification to see the morphological abnormality of the sperm, or for asthenospermia, selecting the best motile sperm by using PIXI has added biggest advantages. So male infertility, female age less than 35, 3 cycles of IUI if the count is more than 10 million. After treating with optimization of sperm, 3 cycles, go for IVF. Age of the woman about 35, straight go for cycles or go for IVF. Poor ovarian reserve above the age of 35, please go for IVF. So the most important aspect is the gynecologist has a black box understanding male infertility. It's always better to send the patient for andrologist opinion. Please make sure the treatment is safe for both male and female and for their offspring. And first remember, do no harm. According to me, this is also one of the cause of male infertility. Thank you very much for giving me the opportunity for giving a talk in this prestigious conference. Thank you.
Thank you so much, Dr. Ganglo. Thank you. Thank you, sir. So I think we are at the end of the session here. So if there are any questions, we can probably ask the speakers. So can't see any questions in the.
So anybody would like to ask any questions? Anybody would like to ask any questions?
I think there are any questions, so I guess we can end the session.
Yeah, we can then end the session. Thank you very much.
Thanks a lot.
Thank you, our chairpersons and speakers. Thanks a lot. It was indeed a very pleasant and informative session. Thanks a lot. So now we are moving on to our last session, which is, and I would like to introduce our chairpersons for the last session, Dr. Suranjan Chakraborty and Dr. Divendu Banerjee. Dr. Suranjan Chakraborty is a senior visiting consultant, OBGYN, Amri Hospital, Mukundapur, Mercy Hospital, Woodlands Hospital, Kolkata. Box Managing Committee member 2012-2021, Vice Chairman of SR Bengal 2022, Chairperson of Adolescent Health Committee, Box, and much more credentials are there. So I'm not going into detail over that. And he doesn't need much introduction as well. He is a very renowned person, Sir Suranjan Chakraborty. And now Dr. Divendu Banerjee. Can I have Dr. Divendu Banerjee CV, please? Hello. Can I have Dr. Divendu Banerjee CV, please?
We didn't receive the CVs. So
I think we are already running late, so we can go ahead.
Yes, sir. Yes, sir.
The CV
yes,
is not important.
Please, over to the chairperson. Okay, good evening.
Good evening. We are into our last session of the day, and we are already running late. So instead of wasting time, I would invite our first speaker, Dr. Asha Rao, who will be speaking on the topic of, I would skip the introduction. You can already see the slides, her slide. She will be speaking on the obstetric complications following ART in adenomyosis. Dr. Rao, the virtual floor is yours.
Thank you. Good evening, dear friends. Let me just start sharing my screen.
Everybody, am I audible?
Yes, sir. Everyone.
Okay,
Share this. This one. Outset, let me thank the organizers of ACE team for having given me this invite to be here today and speak on my favorite topic of adenomyosis. Adenomyosis and obstetric outcomes after ART is the topic today. As all of us know, adenomyosis is a disease which is being discussed for more than 150 years. Yet, we have so many difficulties in diagnosis and disputes in management. The disease has been associated with abnormal uterine bleeding and severe dysmenorrhea in more than 40 to 50% of patients. And it was historically diagnosed by histopathology at hysterectomy in Paris women of more than 40 years. But today, more and more, we are seeing it in younger women, and it is being associated with infertility and also reproductive dysfunction. So whenever there is recurrent implantation failure or recurrent pregnancy loss, one has to definitely look for the problem of adenomyosis in these women. So it is not considered typical of women who are fertile and above 40. It is seen in women less than 40 years and also in 20% of infertile women undergoing ART. And this is a beautiful paper by Togas Tulandi et al. Infertility Sterility, which concluded that adenomyosis is associated with decreased rates of successful implantation and increased rates of pregnancy loss, translating into overall significant reduction in live birth rate. And this is a paper by Salim et al. In 2012, which showed that with adenomyosis, the pregnancy rates are less, 22% in adenomyosis versus 47% in non-adenomyotic women, and 11% ongoing pregnancy rates in adenomyosis compared to 45% in non-adenomyotic women, with high miscarriage rate of 50% with adenomyosis and only 28% in non-adenomyotic women. So you can see that the live birth rate is much less because of increased miscarriage rate. This was also studied by Conjuro et al. In the context of egg donation with adenomyosis. And here again, they concluded that the implantation was not less, but the miscarriage rate was significantly higher in adenomyosis group compared to the controls. The obstetric outcomes of adenomyosis after ART have not been discussed very clearly for very many years. But I recently came across wonderful papers, and today all of us know that there is increased miscarriage rate, preterm labor, preeclampsia, IUGR, fetal malpresentations, increased cesarean sections, NICU admissions for the baby, and the mother can have placental problems, postpartum hemorrhage, and occasional chances of cesarean hysterectomies. All this can happen in women with adenomyosis after ART. ART can have its own peculiar problems for fetal and maternal outcomes, but whenever it is associated with adenomyosis, the problems are much more. And this has been beautifully presented and studied by Konstantinos, a meta-analysis in RBM Online in 2021, Horton et al. In Human Reproduction Update in 2019, and also a wonderful paper by BNT group, Ratna Chattopadhyaya and Sunita Sharma in 2018 in RBM Online. It's a wonderful paper which is being much discussed everywhere. And talking about the pathogenesis, adenomyosis disease of junctional zone, and it can be focal or diffuse, and it produces inflammation-like changes in the uterus. And you can see that the factors that are favorable to implantation are decreased, whereas the factors which are adverse to implantation are increased, like macrophages, natural killer cells, beta-catenin, etc. are increased. And there is myohyperplasia, which you can see here, and also hyperperistalsis. And all this can lead to decreased pregnancy rate and decreased poor obstetric outcome. And you can also see that there is a muscular change in morphology from slight localized expansion of the junctional zone to massive myometrial hyperplasia and fibrosis, which changes the plasticity and tonus of the uterus, and it is responsible for the menorrhagia, severe pain, impaired implantation, preterm delivery, etc. So there is myohyperplasia, and this is another wonderful paper by Brosens et al., which has discussed about junctional zone and obstetric outcomes. Here you can see the adenomyotic uterus, the posterior wall with endometrium and the thickened junctional zone. And the same area becomes the placental bed in pregnancy, where the spiral arterioles are traveling. And in normal pregnancy, there is a good vasodilatation as early as 10 weeks of pregnancy with profound placental flow and good pregnancy outcome. Whereas with adenomyosis, this picture you're not able to see here, the spiral arterioles have atherosclerosis, and this produces poor placental flow, can lead to intrauterine growth retardation, preterm delivery, pregnancy losses, PIH, etc. So all this can happen because of the changes in the junctional zone, leading to poor obstetric outcome. Once again, this was also proven by Hashimoto et al. In their beautiful paper, where they have shown that adenomyosis, with its chronic inflammation-like changes, leads to impaired uteroplacental perfusion, leading to miscarriages, preterm delivery, placental malposition, preeclampsia, and small for gestational age infant. Again, papers by Talluri and Tremelin, the pregnancy rate was 23% in adenomyotic women compared to 44% in non-adenomyotic women. And when they gave ultra-long down regulation to these women prior to ART, it improved the live births. And another paper by Zhuang et al., which showed that gravid women with adenomyosis were associated with increased risk of preterm delivery and PPROM. And there are 7 studies which have discussed beautifully the various problems of obstetric outcomes in adenomyosis from 2006 to 2020. Zhuang et al., Machimoro, Hashimoto, Tamura, Shin et al., Yamaguchi et al. Have discussed beautifully the problems, the adverse obstetric problems because of adenomyosis, like preterm birth, small for gestational infant, preeclampsia, PPH, etc. And this is a wonderful where they have discussed about paper which has discussed discussed beautifully about the obstetrics. For heaven's sake, learn 3D ultrasound and diagnose adenomyosis in early stage like this: endometrium, myometrium, the junctional zone, the early infiltration of junctional zone, the focal adenomyosis. This is when you should diagnose adenomyosis so that you can suppress a disease prior to ART, and you will get beautiful results and much better obstetric outcome. When they come to your doorstep seeking pregnancy, women with recurrent miscarriage, women with the preterm delivery, if they have adenomyosis, how do you help them? Surgery is being discussed from 1952. Today you have wonderful medications, and also ART can be done in a combined way or individually, but we do not have proper guidelines, which is the best and which is the best time that the patient has to approach the doctor, and which is the best time for the scientist to intervene. We need more RCTs and more guidelines. The best medications today are, Danazol was a wonderful medication in the yesteryears. Today we have GnRH, Dynogest, aromatase inhibitors, intrauterine system with progestogen. Uterine artery embolization in HIFU, we do not use frequently for women with infertility, more often women with gynec problems. GnRH agonist is our friend in the infertility clinic. When you use it for 3 to 6 cycles pre-ART, it optimizes the ART outcomes. It reduces the expression of aromatase cytochrome P450 in the endometrium of women with adenomyosis and endometriosis, decreases the expression of nitric oxide synthesis. It reduces the inflammation, which happens because of adenomyosis. And with the usage of 2 to 6 months, the mean uterine volume significantly reduced from 180 ml to 86 ml in the paper by Zhu et al. So if you can do a volume reduction by medication, where is the need for surgery for volume reduction? New et al. With long down regulation, ultra long down regulation, found that there is a better pregnancy rate, ongoing pregnancy rate, and decreased obstetric complications in patients with ART with adenomyosis. These are very many papers studied by Tasaku, Harada et al. And these are beautiful papers by Park et al., where they found very good implantation rate and ongoing pregnancy rate with pre-ART GnRH. In women without GnRH analog suppression prior to ART, the ongoing pregnancy rate was 21%, whereas it was 48% in women with pre-ART suppression with GnRH analog. It is fantastic. And once again, papers by Senakova et al., which shows that the rate of euploid miscarriage is increased in the setting of adenomyosis. And if you use pre-ART GnRH suppression, there is boosting of implantation, and there is also improvement in post-implantation pregnancy health. That means better pregnancy rates and less chance of preterm delivery and adverse effects. This is one of our own patients who had prior pregnancy losses. And during ART, we saw that, and that happened elsewhere. We diagnosed adenomyosis, suppressed her with 11.25 GnRH analog. You can see that at the end of 12 weeks, there is a very good suppression of the adenomyotic nodule. And we did an embryo transfer at 14 weeks. She conceived twins and had very good outcome. This is another patient with prior ART failure and prior preterm delivery elsewhere. She had a 4.7 centimeter adenomyoma, which was suppressed by long GnRH analog, followed by ART and embryo transfer, and the child is 2 years today. So with a very good obstetric outcome. This is a beautiful paper from China, Siaku et al. In 2020, uterine volume and obstetric outcome during frozen embryo transfer. According to this group, if the uterine volume is less than 98 cc, your results are much better, obstetric outcome is much better. This is in group A compared to group B, where the uterine volume is more than 98 ml. Here you can see in group A with the less than 98 cc volume, the miscarriage rates were only 13%, whereas in the group B with the higher volume, it is 38%. Late miscarriage, it was only 2% here and 12% in increased uterine volume. Preterm delivery rate also was almost okay. Live birth rate were 43% in women with lower uterine volume compared to only 25% in women with more than 98 cc volume. So it's very important to have a reduction in uterine volume prior to frozen embryo transfer or ART to get a good obstetric outcome. Dynogist, though it is popular drug for pelvic pain and dyspareunia, it is not so good for controlling menorrhagia and for reduction of uterine volume. This is a paper by Matsushima et al. Where they have shown that with GnRH analogs for 16 weeks, the uterine volume came down from 307 cc to 177 cc. Whereas with low-dose estrogen progesterone and Dynogist, you can see there was no difference in volume at all. So volume reduction is the best with GnRH analog and not so good with other medications. Aromatase inhibitors are wonderful drugs. You can use it 2.5 milligram per day for 8 to 12 weeks for good reduction in symptoms of adenomyosis as well as reduction in the volume of adenomyoma. Combined use of aromatase inhibitors plus GnRH analog can give you a reduction in uterine volume up to 60% as observed by Kimura et al. In our clinic also, we have started using GnRH analog last year and we are very happy about the uterine volume reduction. This is a paper by Abubakar Elashar where you can see that GnRH analog is the pink and green is the letrozole group. The volume reduction is almost equal. Letrozole is much less expensive than GnRH analog. And with the aromatase inhibitors, the estradiol reduction happens within 24 hours. So you can get a rapid reduction in uterine volume by using aromatase inhibitors along with GnRH analog. This is one of our patients who had a 12-week size uterus with a large adenomyoma of 7 centimeters, 7.5 centimeters with previous 2 miscarriages. So she also had a low AMH with a normal sperm parameter. We went ahead and did a oocyte retrieval and embryo freezing, vitrification. This was last year during the COVID year. She came in February 2020. And after vitrification, we gave her 2 doses of 11.25 plus another dose of 3.75. And we also gave her norethistone 5 milligram to prevent bone loss along with letrozole 2.5 milligram. And her uterine volume, which was more than 344 cc, came down to 204 cc from February to October, where she underwent a frozen embryo transfer and she conceived. And this is a uterus in early pregnancy. You can see the big adenomyosis. We were all worried about preterm labor. She went off very well, and the baby is 2 months now. Conceived last year, October, and delivered now 2 months back. She did very well. Mirena also can be used along with GnRH analog for volume reduction.
Can you conclude?
Yeah, sure. So who will benefit from uterus sparing surgery in adenomyosis? Only when the adenomyoma is more than 5 centimeter, recurrent miscarriage or recurrent implantation failure, not responding to medication is the only time that one has to go in for surgery. Because with surgery, one can have high chance of uterine rupture, almost to the extent of 6.8%. So my request, dear friends, is do as much as possible medical management, do ART with pre-ART suppression for reducing the uterine volume. If there is failure of ART, you can repeat the procedure again. Avoid doing surgery unless there are severe symptoms or repeat failures of ART. So I would say that, yeah, this is the last slide. Pre-treatment with GnRH analog seems to be beneficial in improving the pregnancy rates and improves the obstetric outcome. So the benefits of fertility preserving surgery vary greatly and should be performed only in selected patients by experts and not by everybody. Thank you all.
Very good lecture. You have covered almost every aspects of it. Dipindu?
Yeah.
Any comment?
Yeah, a wonderful talk, but this is one gray area which is not very clear to us till now regarding adenomyosis and how do you ideally manage whether it should be a surgical approach. But we've got certain new medicines, Dynogist and GnRH are the options that can be used before an IVF procedure. But once again, we know that in adenomyosis, in a patient with adenomyosis, the receptivity, the endometrial receptivity is compromised. And as such, the success rates are much lower in IVF pregnancy. It was a wonderful presentation, Dr. Rao, and I would request Dr. Suranjan Chakraborty to take the session forward.
Thank you. Thank you very much.
Thank you, Vasha.
It's a big problem of this subcontinent Asia, India subcontinent, adenomyosis, not like other European countries. It's a big challenge for this, in particular, the use of India, this subcontinent. Thank you very much, Asha.
Thank you, Dr. Saranjan.
If any questions, we'll take 10 minutes, we'll discuss after this next speaker. May I invite Dr. Shogata Acharya. She's a senior consultant pediatrician and the head of the Department of Pediatrics and Neonatology, Calcutta Medical Research Institute. He has over 30 years experience of clinical pediatrics and neonatal intensive care, both in India and in UK. Deputed postgraduate teacher in multiple publications. Dr. Shogoto will speak on the outcome of these IVF babies. There's neurodevelopmental that is born with assisted reproductive therapy.
Over the next quarter of an hour, I'm going to talk to you regarding the growth and neurodevelopmental outcome of babies born by assisted reproductive therapy. I'll initiate my discussion on the current knowledge of long-term outcome of children born after assisted reproduction technology. This is based on systematic reviews, meta-analysis, and national registry studies published in contemporary literature. Subsequently, I'm going to share with you my personal experience of following up ART babies. I'm sure you'll all agree with me. Since its inception about 4 decades ago, there has been a phenomenal growth in assisted reproductive technology. The question remains whether these babies are exposed to greater health hazards compared to their spontaneously conceived counterparts. The growth trajectories of ART babies have been followed up worldwide with an overall satisfactory projection. However, the Indian data are still inadequate in this regard. Few confounding factors which can potentially influence the long-term outcome of ART babies have been described. These include advanced maternal age, associated maternal sub or infertility, multiple pregnancies, prematurity, and the techniques employed for assisted reproduction. There are some short-term adverse associations of ART, which we all know. These babies are more premature. They have got low birth weight and they have got increased incidence of birth defects, which may be associated with various confounding factors. We can modify our earlier question and ask ourselves, if we eliminate the confounding factors that may influence the outcome, whether babies born following ART have a poorer prognosis compared to their spontaneously conceived peers. The answer to this question has been given in a recently published article, which has looked after the current knowledge about the long-term outcome of ART children. The parameters assessed here were growth, neurodevelopmental outcome, including cerebral palsy, cognitive development, including ADHD and autistic spectrum disorders, cardiovascular functions, including blood pressure, type 1 diabetes, respiratory disorders, including asthma, malignancy, and reproductive health. As you can see, the ART babies have been further subdivided on the basis of presence or absence of confounding factors. In absence of any confounding factors, this group of babies who were born following ART has got no significant difference as far as the growth, neurodevelopment, and cognitive development is concerned compared to their naturally conceived counterparts. There are conflicting data regarding their cardiovascular functions, including blood pressure. There is no definite evidence to implicate ART with type 1 diabetes in this group of children. There is no significant association between ART and respiratory disorders, including asthma, in this group of children. There is no evidence of increased risk of malignancy or there is no ill effect on reproductive function in this group of children without any confounding factors. However, if we go and study the outcome of children born following ART with confounding factors, we can see their growth may be impaired to start with, but they usually catch up later. There are conflicting findings regarding the neurodevelopmental outcome, and we need further long-term studies to come to a definitive conclusion. Some studies have suggested in this group of children with confounding factors, they may have an increased incidence of ADHD and autistic spectrum disorders, particularly in those with multiple pregnancy and prematurity. They may have an increased blood pressure and suboptimal cardiovascular function in later life. There may one or two studies have suggested an increased risk of type 1 diabetes in this group of children with following frozen cycles. There may be an increased risk of respiratory disorders, including asthma, in these group of children with confounding factors who were born following ART. There is no evidence of increased association of malignancy even in this group of children. However, one or two studies have suggested lower sperm counts in ICSI male offsprings. Keeping all these in mind, let us now turn our attention to our own experience of following up the ART babies. We have performed recently a cohort study comparing the growth and neurodevelopmental outcome of babies conceived by assisted reproductive technology with those of naturally conceived babies from birth till 24 months. This is perhaps the first Indian study which has studied the growth and developmental outcome of ART babies and compared it to naturally conceived counterparts. This was a longitudinal cohort study which was done over a 24-month period. All near-term singleton babies conceived following ART were eligible for enrollment. Babies with complicated perinatal period were excluded. Preterm babies and those requiring special care following birth were also excluded. The growth and neurodevelopment of these babies were compared with the matched cohort of naturally conceived babies from birth till 24 months. Out of 170 babies who met our inclusion criteria, 128 parents had agreed to participate in this study. For comparison, 128 naturally conceived babies born during the study period was randomly recruited. The growth of both sets of babies were assessed on the basis of anthropometric parameters like weight, length or height, and occipitofrontal circumference at birth, at 6 months, 12 months, and 24 months following birth. And wasting, which is defined as weight by height less than 2 standard deviation, was a primary outcome in this study. The motor and mental development of these babies were assessed using the developmental assessment scale for Indian infants, and this was done at 6 months, 12 months, and 24 months following birth, and a development quotient of less than 70 was another primary outcome measure in this study. If we quickly look into the details of the findings in our study, we can see that a significant proportion of babies born following ART were growth retarded at birth. Hence, the proportion of small for dead babies in the ART category was 27.3% compared to 14.8% in the naturally conceived babies. At 6 months, there is a persistent growth delay in the ART category. In ART babies, significantly more delayed in growth compared to the naturally conceived babies. So 21.1% of ART babies remain growth retarded at 6 months compared to 14.8% in the naturally conceived group. The same trend continues at 12 months, where the difference in growth
between the two groups are still statistically significant. However, at 24 months, the difference of growth retardation between the two groups are statistically insignificant. Therefore, only 8.6% of the ART babies remained growth retarded compared to 7.03% of the naturally conceived babies. Therefore, we can say that majority of the babies who were born following ART who were growth retarded at birth and in early infancy catch up with their naturally conceived peers by their second birthday. As far as the mental and motor developmental delay is concerned, at 6 months, the difference between the mental motor developmental delay of the ART babies is significantly more compared to the naturally conceived babies. At 12 months, the trend is similar, wherein the difference between the mental and motor development quotient in the ART babies are statistically significant compared to the naturally conceived babies. But again, at 24 months, the difference between the mental and motor developmental delay at the ART group is statistically not significant compared to the naturally conceived groups. So if we look at the trajectory of growth and development, we can say that the growth of ART babies are delayed at birth during early infancy, but they catch up during the second year, so that by their second birthday, their growth is almost at par with their naturally conceived counterparts. Similarly, at 6 months and 12 months, the mental and motor developmental delay was more significant in the ART group compared to the naturally conceived group. But here again, by their second birthday, the difference is insignificant. Therefore, the growth and developments of ART babies catch up with their naturally conceived counterparts by their second birthday. To summarize our study findings, we can say, despite eliminating most confounding factors, a significant number of babies conceived by ART are born small for gestational age compared to their naturally conceived counterparts. This may explain the persistence of their growth and developmental delay in early infancy. However, almost all of them catch up with their naturally conceived peers by their second birthday. So we can conclude that assisted reproduction technique as such do not have a lasting impact on growth and neurodevelopment of newborn babies. Our findings tally with the similar findings of majority of studies worldwide. With the introduction of more advanced and sophisticated techniques of ART, hopefully the long-term prognosis of ART babies will improve further. Thank you for your patience.
Thank you. Thank you. Thank you, sir.
Very
Would you like to ask any questions, sir? Suranjan, sir?
Dr. Shogato,
Asa, ma'am.
Dr. Shogato, I would like to know the term delivery or near term of the ART babies and the normal conceived babies. That makes a little difference, I think. We haven't included it. The delivery intrauterine age.
Sorry, thank you for your question. Yeah, I just want to let everyone know that these babies are mainly near term, or you can say late. Most of them are term. Some of them are late preterm, above 36 weeks of gestation, because we wanted to eliminate the confounding factor of prematurity from our study. And I think because that is a main problem which we have. Though the current literature suggests that even in those babies who are born preterm, they also catch up with their naturally conceived peers by the second birthday, which is the current findings. As far as the growth, neurodevelopment, and cognitive development is concerned, there is no difference between the two groups, irrespective of the presence of confounding factors or not. However, In this study, we wanted to eliminate the confounding factors by, eliminating the preterm babies or the babies who required special care at after birth.
Any medical comorbidities you have excluded?
Yeah, we have excluded all. As I said, this is a completely uneventful deliveries, which are
And the normal conception is the normal delivery, or the through ellipses?
Well, majority of these babies are born by cesarean sections, as you know.
That's why I'm asking to.
Yeah. So.
And after school during that birth, during the delivery, is there any difference?
They're all born in very good condition, and they're all roomed in babies. It's not that they required any special care after birth, and the ABGARs are all healthy. I mean, the average the mean ABGAR score of above 8, all the babies.
I must congratulate you for this laboratory. Is wonderful work. Wonderful. Please carry on. This is a very good work on Indian data. We are deficient of this
Indian Journal of Pediatrics last month.
Very encouraging. Yes. Anybody, any questions? In the chat box, any questions? This is a wonderful talk by doctors. Then I must congratulate both the speakers for their excellent talks.
Thank you, sir. Thank you. So with your permission, should we conclude the session?
Yeah.
Thank you, sir, very much. Thank you, Asa ma'am. Thank you, Sogata sir. Thank you, Suranjan sir. So we are concluding now.
Yeah.
Thank you. Thanks a lot.
Okay, thank you, everyone.
Thanks, everybody.
So we are closing the session for Holly.
Thank you. Thank you, Atul. Thank you.
Thank
we
you,
are
sir.
logging off right now.
Thank you, sir.
Thank you.